Okay.
Are you Chair? Okay.
Good morning, everyone. We're going to get started. Welcome to the Human Services Committee public hearing on Tuesday, March 10th. We have a number of bills before us today and a great list of speakers, so we are going to get right into it. And so first up is the Commissioner of the Department of Social Services, Andrea Barton-Reeves. Go right ahead.
Thank you. Good morning. Good morning, Chairs Lester and Gilchrist, Ranking Members Perillo and Case, and distinguished members of the Human Services Committee. I am Andrea Barton-Reeves, the Commissioner for the Department of Social Services, and I am pleased today to offer remarks on several of the bills on today's agenda. I will start with Senate Bill 429, an act concerning Medicaid reimbursement for emergency medical transportation. In essence, the intent of this bill is to modernize the currently outdated mileage reimbursement system for ambulances. Our ambulances and our DSS non-emergency medical transportation use GPS to calculate exact mileage. However, the current reimbursement system that we use was developed before GPS was widely available. So after internal review, we are in support of this proposal and don't believe this change would result in any additional costs. Next, I will be commenting on Senate Bill 431, an act concerning palliative and hospice care in Litchfield County. In essence, the department sees significant value in this study and on a report to learn more about the possible needs of palliative and hospice care. But what we ask respectfully is that the report submission date be moved to January 31st of 2027 to allow us more time to conduct our review. Moving on to Senate Bill 432, an act disregarding the cash value of insurance policies in eligibility determinations for certain public assistance programs. This bill would require the department to exclude the cash value of life insurance policies when making eligibility determinations for Medicaid, including those in long-term care. SAGA, which we call the State Assistance the State Administered General Assistance Program, and what we commonly call TFA, which is Temporary Family Assistance, and the State Supplemental Program. Such funds that usually come from the cash surrender of a life insurance policy are routinely considered when determining eligibility for public benefit programs. Because they are accessible liquid assets that can be used to pay for immediate needs that might otherwise be borne by pertinent public assistance programs. This bill would expand eligibility and increase the costs, and such costs are not included in the governor's recommended budget. Therefore, the department cannot support this bill. I would also like to add, though, that in addition, the cash surrender of life insurance policies is already excluded as an asset under the temporary family assistance. Moving to Senate Bill 433, an act expanding long-term care options, we really do appreciate the interest and support in the rebalancing of long-term services and supports. That has been a significant focus of our work for over 10 years, and we do have longstanding relationships with CMS, the Centers for Medicaid and Medicare and Medicaid Services, and our Money Follows the Person program. Those divisions are specifically responsible for ensuring that the state Medicaid program is rebalanced so that there is an opportunity for it to have more individuals receive their long-term services and supports in their community. There is a key finding that suggests that 71% of Medicaid members receiving LTSS are doing so in home and community-based settings using 60% of the Medicaid LTSS budget. With respect to specific language in the bill, Section 1C2, we believe this language isn't necessary because rebalancing efforts are already ongoing. We did, in April of 2025, submit our MFP, our Money Follows the Person, operational protocol to CMS, and that actually deforms and drives our strategic plan and enhanced funding for this specific purpose. We also suggest that in Section 1C2A, to increase outreach for the Connecticut Home Care Program for Elders, CHCPE, is not needed. And that is because of the current enrollment numbers. In 2025, we had 14,021 referrals averaging about 1,168 a month and 4,180 new CHCPE members receiving services. We would appreciate the opportunity to meet with the proponents of the bill to review ongoing rebalancing efforts within the department and to discuss opportunities for future efforts in this space. Next, I'll speak to House Bill 5480, an act concerning peer support under the Medicaid program. This bill requires the commissioner of the department to amend the Medicaid state plan to integrate peer support services into care teams funded under the Medical Assistance Program. We recognize and do appreciate the important work of peers within substance abuse use disorder treatment continuum, and we continue to allow the use of reimbursement for peer supports within the current per diem rate for residential substance use disorder. The department also believes that peer support specialists are longstanding valued members of the intensive care management teams that are connected with Connecticut Medicaid's Behavioral Health Administration organization, what we commonly call an ASO, which is Carelon. They bring lived experience and they do support our members as they work through the challenges of substance use disorder, having often have their own lived experience. We also have peer support through our federally qualified health centers, our advanced networks that include primary care practices, and our person-centered medical home, which is also known as our PCMH Plus initiative. There are other examples where we also have community health workers or peer models. As I just mentioned, PCMH Plus is one of them. Our substance use disorder residential treatment per diem rate, which providers can use community health workers. We're also exploring other opportunities for health workers, which would include home visiting with the Office of Early Childhood, our Justice Involved waiver, and care coordination of chronic disease management. We are actually in phase 2 of testing the effectiveness of community home workers in connecting unattributed members to primary care, because we believe that through our test and learn model that we're using now, we can see which practices are most effective to getting people who are not currently associated with a primary care provider to agree to do so. So while we agree and support the concepts in the practice, at this time, we cannot support the bill because the governor's budget does not include additional funding for this purpose, but we will continue and hope that we can collaborate with the I don't want to say department because I say department all day long, with the committee. I kept wanting to say department, I want to say committee, with the committee to continue to expand the use of community health workers and peer support. Moving on to House Bill 5481, this is an act concerning medical assistance for patients receiving hospice care at short-term hospice specialty hospitals or hospice facility. We do understand that this is a service that is being sought within available appropriations to provide reimbursement for room and board costs for Medicaid recipients who are in fact receiving care from short-term hospice specialty hospitals and the like, and similar facilities. Medicaid does have very strict restrictions against paying room and board in many circumstances. So our caution as the department that is the Medicaid agency would be against broad coverage of room and board costs without further review of available Medicaid coverage. So in that vein, we would appreciate an opportunity to study and research this issue to a greater extent to determine whether or not Medicaid would be permitted to pay for room and board in such facilities. Moving on to House Bill 5482, an act concerning 12-month coverage for contraception and hormone therapy. There may be questions about this, and for that reason, we have our medical director, Dr. Jody Terranova, here today. This bill would allow for a 12-month supply of all FDA-approved prescription hormone medications, contraceptive drugs, devices, or products. Prescription hormone medications encompass a wide range of therapies, which include sex hormones, thyroid hormones, corticosteroids, and growth hormones, and a number of different drugs that you will see in our written testimony. Our concern here is that many of these require ongoing clinical monitoring, including lab testing, dosage adjustments, and adjustments for side effects. So with that in mind, we are concerned that dispensing a 12-month supply all at once would actually not be medically appropriate or evidence-based because many of these therapies actually do require closer monitoring than what would happen in a 12-month period. There are also some pretty significant fiscal implications, and that includes providing a full year of medication that might be needed to be changed perhaps at a subsequent visit could lead to some waste. And it can also cover it with someone who may no longer be in the program, and that may happen from time to time. So given the current language and the broad scope, the department cannot support the proposal right now as written, but as always, we are open to more dialogue and conversation and discussion as to how we might achieve this goal. Moving on to House Bill 5484, an act expanding transportation options for home care clients. So this particular bill seeks to increase reimbursement to certain home care providers who provide non-emergency medical transportation to and from medical appointments for Medicaid home care clients. Well, while this bill does not state the scope or the amount of the potential fee increase, it would actually require an appropriation. In addition, many of these services are already provided by our current non-emergency medical transportation vendor, MTM, as part of our Medicaid program. It's also, I should say that it's also part of our Covered Connecticut program where we do have NEMT covered in that as well. The definition of and reimbursement for personal care attendant explicitly excludes transportation costs associated with the provision of personal care outside of the participant's home. This is billed separately and is not included in the scope of personal care. And finally, the definition of homemaker does not allow services to be rendered outside of the home, and that would include transportation. This actually brings me to the end of my verbal testimony this morning. We have submitted written testimony on the remainder of the bills, and we welcome any questions that you may have. Thank you.
Thank you so much, Commissioner.
Thank you.
I need a little time to process, so I'm going to see if any of you. Are you ready?
Sure.
All right, Senator Lesser, go right ahead.
So I'm going to focus my question just on one aspect of your testimony, which was with regard to the peer support bill. And we've had a number of conversations around peer support services over umpty-ump years and have not been able to pass legislation through this committee. So this is a new approach this year focusing on care teams. I appreciate that your testimony sort of suggests that the way for us to handle this is through value-based payments. And that is in specifically, you talked about another approach that, we had done a couple years ago with the community health worker bill. But I note that even though the DSS has studied the issue, as far as I know, the department is not currently using community health workers. And I guess my concern for folks who are, we currently do have a program funded by DMIS to pay for peer support services through grants to nonprofit providers. But to the extent to which we're looking to Medicaid and to DSS to take a role in that, I'm just wondering, like, how would that likely work, and what's the time frame? Because a lot of the providers out there that are asking for an increased role are concerned about imminent federal cuts and potential gaps of service to folks who need these services. So I'm just sort of walk us through your process and sort of suggesting that outcome as opposed to a fee for service arrangement or some other way of paying for the service.
Okay, so I just want to make sure that I understand the question. You're asking whether or not we would consider a fee for service arrangement, or are you asking how? I guess I'm not clear, Senator. I apologize.
Yeah, and I'm sorry. Your testimony, as I read it, suggested that if we move forward with peer support services, that we should not provide fee for service payments, but instead allow the department to create some sort of value-based payment scheme for funding peer support services, as well as community health workers, which is something we've already authorized in statute.
Right.
But I don't think you're doing anything yet with the community health workers. So that's why I'm just want to make sure that if we do that for peer support, that actually does something.
Right. So thank you for your question, because I think I understand it better now. You are correct that we're not doing anything with respect to the community health workers because our budget has not permitted us to expand in that direction. So only very recently have we had an opportunity with the part of the 500 million that is part of the HR1 emergency fund, as we call it, have we had an opportunity to really focus on the community health workers. Because that is where we've always wanted to start, and we've always wanted to be, but we've always needed more budget capacity in order to be able to engage community health workers in the way that we would really like to. So when it comes to HR1, I think we kind of grasped onto that opportunity because we knew that if we were going to be successful in reaching others in the community, that doing that through community health workers is the way that we've done it. So it is in many ways a parallel to what we would have done if we had more capacity in our current Medicaid budget to do that. So I think that's one part. With respect to value-based payment and peer support, that is it's a different question as it relates to community health workers, because we're really looking for more of a wraparound approach. So it isn't necessarily having community health workers on sort of one path of providing support and then having providers on a different path. We're looking really for a more integrated support approach, which is why we think that having a value-based payment approach would be the way in which we would accomplish that. That doesn't necessarily mean that we're not open to fee for service, but we also know that fee for service has certain limitations to it, which every state, not just Connecticut, is really struggling with. Value-based payments really give us an opportunity, and there's another term that that's not coming to me immediately, that I think better describes what it is that we're trying to accomplish. That allows us to actually provide more incentives rather than disincentives, and it allows us to sort of put different ways in which we can arrange for coverage and support within providers that works for them, as opposed to us saying to them, here, take your community health worker dollars and figure out what you're going to do with it. What we'd rather do is have a more comprehensive approach with providers. So I don't think that is the direction that we're going in. It is taking longer than I would have hoped because of our fiscal constraints, but that is our thinking and our philosophy.
So I was happy to hear about the federal, the federal emergency response funds being
Yes.
used for the community health worker
Yes.
program, because we've been anxious to get the department to do more in that space. So it's great that you're doing that. Can you just detail a little bit about what that commitment is? And I see you've got a lot of staff behind you. So if you need to phone a friend, that's also okay.
I do. I do encourage them. I'm a big girl now. I can, sometimes I can come by myself, but I am so grateful that they always come and support. So I just want to say that publicly. So thank you for that.
I wasn't trying to suggest you weren't perfectly capable of defending yourself. I just know that I asked Bill a question about a bill that's not right before us.
No, I do understand that, and I do appreciate that. So the way that we are engaging community health workers in support for HR1 is that they are going to be our trusted messengers for both SNAP and for Medicaid. So we know that the changes in both of those programs through HR1 are pretty significant. We are still, because the changes in SNAP were actually effective as of July 4th when the bill passed, we are like many states, and we are still trying to catch up to make sure that we're doing the right thing for people who are losing their SNAP eligibility because of those changes. The idea is to work with our community health workers, our community action agencies, and some of our larger and philanthropic partners, which would include the Connecticut Health Foundation and the Connecticut Project, so that we can put community health workers out into the community. The first step is to plan how that's going to occur, and that's already happening. That's what one of our staff members, Suzette DeBeetham Brown, is actually working on right now. The next is to have training for them. So we are going to be providing that training in partnership with the two large philanthropic partners that I just mentioned, the Connecticut Project and the and the Connecticut Health Foundation. Then our workers will be deployed, first for SNAP and then for Medicaid, but the same workers will be trained so that they will understand the entire implications of HR1, so that they can almost be like a ready-made task force that will go out and say, okay, this is what you need to do when you think that you've lost your eligibility in SNAP, and start from the very beginning. People need personalized attention. This is a life-changing piece of legislation at the federal level for so many people. And so rather than feel as if we can handle this ourselves, which we do not have the capacity to do on our own. We're talking about 100,000 people possibly for Medicaid and 36,000 people for SNAP. People need to have some individualized support, and that is the purpose of the community health workers.
And how much funding is being made available through the emergency fund for this
So
purpose?
I want to say altogether it's 4 million, but I'll check on that number again. It's a pretty significant number.
Okay,
Yeah.
thank you very much.
Thank
Thank you,
you.
Madam Chair.
Thank you.
Whatever, I'll go. Yeah.
Yeah. Go right ahead, Representative Case.
Thank you, Madam Chair. Commissioner, how are you?
Yeah.
So a couple questions and 5485, no testimony on it. There's a lot of people in this room that are here to support this supported decision making. Just curious on, we're going to hear a lot of it today. We'll probably
Mm.
circle back with you on it. Something we've been working on since 5001, the bill.
Okay.
Something we want to do. We want to look at, been on plenty of
Mhm.
calls with the probate courts and
Mhm.
others. Any opinion, or you want to hold off on that and hear what we have today?
Yeah, I think I'd like to hold off and hear what you have today.
Okay, because I know we can make some financial decisions here. A lot of this policy stuff will come out of public health because DDS.
Right.
So I just wanted to see, because I didn't see anything in.
So I will say this, and I think that the more people that can support an individual who's making a decision, the better. And determining who has what role in the right circumstances, I think, is an important thing for the person who's at the center of care and the person around them to be able to make those determinations. So it's not about eliminating a particular group, right? It's not about eliminating the probate court, eliminating lawyers, it's widening the circle so that the individual has the right people around them as they find the right people and have people that they feel support them in different ways. I remember doing this work when I was an attorney. I guess I still am. I still pay my fees and have my license. And supporting people that had intellectual disability, and really in the probate court, working with them to decide whether they wanted a plenary conservancy, or they wanted just for medical or for legal, and to make their own decisions around that. And those were actually really productive conversations to have with people, so that they can actually exercise their rights and make their own decisions, and as capable as everyone else is making decisions. So that's really as a department, that's our position, is that we would want the circle to include the people that people believe need to be a part of the decision, and everyone has a different role to play.
I thank you, and I thank you for that that statement, because I just wanted to, there's enough people in this room that are here for that today. And with one of your previous roles, that was very important to myself and you, and
Mhm.
with the population that we work most clearly
Right.
with.
That's right.
And you're right, it's not one decision for all. So we have to look at it, and I'm looking forward to testimony today to see how other people feel about it. And I'm sure we'll be in conversation with you to see what we need to do. But I appreciate, I just wanted to give you the opportunity. And the last one was the 5484,
Okay.
which I think we'll have some discussions with you and your staff. It's about transportation for home health care.
Yes.
And you did mention it in your testimony that, we have MTM, which is not Emergency Medical Transportation Company, but this is something that will allow people who are in home care, their caregivers can take them to their appointments. Why call a third party that we're going to pay to do it when they have somebody that can do it, that is eligible to do it, but they don't get reimbursed for mileage?
Right.
It might be a savings on the MTM side because they won't have to dispatch a driver out of there. It's
Mhm.
just done with the same person that's giving the care at home. They have the vehicle, they have the ability to get there. Some of them are doing it, but they just
Mhm.
don't get reimbursed for it. So I think it's something that we can look on as a cost savings or a
Yep.
cost neutral, because it just bothers me sometimes. Why bring in a third party
Yes.
when somebody's already there that can do it?
So I understand, and I do appreciate that. And, this is why going to law school just sort of ruins you for life, because part of what I get concerned about also is liability. And that is it's a coverage that we have with our third party, right, with MTM. So the vetting of the drivers, the liability in case there's an accident, if something were to occur. these are some of the things that we had, because we really discussed this particular bill at length and understood that it feels more like a natural support, right? The person is there. Why can't they take them? They know where they need to go. They're very familiar with the environments that and the places the person wants to go. But we do have this issue of the sort of Medicaid restrictions around how certain services have to be delivered and how they're paid for. And then we also had a, pretty robust discussion about what if something happens, and what is the personal liability of that particular person who's doing it right now. So I didn't hear the part about them already doing it. We didn't have that discussion.
No, and I appreciate it. And I think we'll have more discussion on this because this has a lot to
Yes.
do with what's going on with the F license, because you talk about
Understood.
liability with the company that has the contract is where the liability holds.
Right.
And if we have to work through that, there's a lot of people that want to get into this. And the bottom line is we want to make sure that the person needing the care gets to where
Mhm.
they need to go
Correct.
in the most fair way that it is. And if it's with I read throughout the testimony that, well, their caregiver can go with them. So if their caregiver can drive, but now you got three people in the vehicle because you got a driver, you got the caregiver, you got the person that's getting the care. But if we can eliminate one and save costs or cost neutral, we need to open up rides for others because the backlogs can get pretty hefty. So I appreciate your
Yeah.
comments today, and I was hoping to call some staff up, but I guess we didn't need to today. But thank you. Thank you, Madam Chair.
Thank you, Representative. Okay, I am prepared now.
All right.
Thank you. So looking at House Bill 5482, the 12-month coverage for contraception and
Yes.
hormone therapy.
Yes.
I know in this building and in this world, we don't often or at all look to cost savings, but would love to discuss further with the department, in particular with the contraception piece. There are studies to illustrate that the cost of unplanned pregnancy is offset by giving 12-month, as
Mhm.
is studies have shown that women are more likely to get pap smears and chlamydia tests during the year if they have
Mhm.
that 12-month. So do think if we looked at it in a different lens, we might actually save money. When it comes to the other piece, I appreciate the testimony saying, let's have further conversation. There is language in there that is attempting to get at prescribing provider discretion, but
Yes.
maybe we didn't hit the mark. So would love to further that conversation.
Yeah, we would appreciate that as well. We have concerns about the sort of the broad umbrella of hormone therapy, our experience with our members in terms of, some responding quite well, others needing more frequent intervention. We just want to make sure that whatever we land on is medically appropriate and that we give people what they need and that we don't cause harm. And we also want our providers to have the flexibility to be able to treat their patients, in the way they see fit. Now, in some instances, they may say, you're fine, you're good. If you have these 5 symptoms, then come back. But other than that, we'll see you in 12 months. But we prefer to have, I think, more oversight by the provider. So we would be happy to see where a compromise could be struck.
Okay,
Okay.
fantastic. And then the other bill, 5486, speaking to the diaper program within the hospitals, I recognize that without the money being put in the governor's budget, the department opposes. Any thoughts, though, on the merits of the underlying concept? I know we've had conversations here before about
Yeah.
access to diapers.
Yeah. I mean, it's hard to argue against access to diapers. So if we talk about merits, I don't really know if there's anything that can be said. I think in opposition to that, as a concept, I think how we do this and where the money comes from and the sustainability of that really is the issue. And I think that's where we can have greater conversation there. We know, I mean, the diaper bank does an extraordinary job. We know that. And the diaper program that we fund, which is the diaper bank through DSS, continues to try to provide the level of support that we believe is needed. But the need is so great. The question is, how do we get to that in a way that's fiscally sustainable for families that need it? Because we don't want to tell poor and low income families, we don't tell families that can't get to the grocery store because it's 25 miles away, that they can't have diapers for their children. Obviously, that's not an acceptable outcome. So I think I and all of us at DSS would love to have more conversation about what we can do and come up with some other creative solutions that can address this concern because we want healthy children. We know healthy children happen when they have their needs met, and, you know, a diaper is obviously an essential need for a child.
Wonderful. Thank you. I appreciate that.
welcome.
Well said.
Good.
Okay. Wow. Thank you so much.
All right, thank you.
Have a great afternoon.
Thank you.
Enjoy the weather. We will not.
It's on its way down.
Okay. I'm gonna, should I go to Amy Porter though first then? Or
Let's see, yeah, there's that.
we believe someone is arriving. Hold on. All right. Next up is Amy Porter, Commissioner of Aging and Disability Services. Sorry for the delay.
Good morning, Senator Lesser, Representative Gilchrist, Senator Perillo, Representative Case, and distinguished members of the Human Service Committee. My name is Amy Porter, and I'm Commissioner of the Department of Aging and Disability Services. I'm here to offer comment on 3 bills being heard today: House Bill 5485, House Bill 5487, and Senate Bill 430. House Bill 5485 addresses supported decision-making. ADS strongly supports supported decision-making, expanding alternatives to guardianship and conservatorship. Formally recognizing these agreements throughout the state's businesses, government agencies, organizations, medical providers, and educational institutions, as outlined in the bill, empowers people to maintain control over daily decisions, both big and small, directly impacting their lives. We greatly appreciate the committee's interest in preserving self-determination options for Connecticut residents. However, we must oppose Section 2 as currently drafted. Specifically, the bill would require ADS to provide information and resources about supported decision-making agreements to older adults and people with disabilities, families, and others, and also to facilitate forming, executing, and terminating these agreements, potentially mediating situations in which a supporter is believed to be acting beyond the scope of their supported decision-making agreement. These functions are outside the department's available resources, as well as outside the scope of the department's current expertise, and it's clear that funding would be required to establish this program, including the cost of hiring qualified staff. House Bill 5487 seeks to do 2 things. First, to create an interpreting pipeline, and second, to change the funding limits for community inclusion services for adults who are deafblind. In terms of the interpreting pipeline, we all know interpreters are a scarce resource in Connecticut, and really appreciate the committee's work to look at this issue. The bill would establish a 3-year pilot program to promote a career pipeline for American Sign Language interpreting, and the program would fund up to 5 local or regional school districts for related high school courses eligible for college credit. While we strongly support the intent of the legislation to address critical interpreting shortages, we do have concerns with the design of the concept. As some context, Connecticut has a limited pool, not just of interpreters, but of ASL teachers to support the proposed pilot program. More than 1,600 students are reportedly enrolled in courses across Connecticut public schools that are related to this. But despite the demand, the state currently only has 4 teachers who are certified by the American Sign Language Teachers Association. And there are only 83 registered certified ASL interpreters residing in the state. When you look at interpreters for individuals who are deafblind, there are currently 3 actively qualified interpreters working for our state's deafblind community. These shortages highlight an underlying lack of access in a variety of settings here in Connecticut for residents who are deaf, deafblind, or hard of hearing. It is worth noting for the committee that another bill raised in the Education Committee proposes a different approach by first addressing the quality of ASL instruction. The bill was drafted in partnership with the Advisory Board for Persons Who Are Deaf, Deafblind, and Hard of Hearing, which ADS provides an administrative role for. And it includes establishing an ASL education working group charged with recommending curriculum guidance, teacher certification standards, and guidance to educator preparation programs. Establishing consistent teacher qualification guidance and ensuring culturally accurate instruction across districts appears to be the next logical step in building upon recent progress made, thanks in large part to the work of this committee, to strengthen recruitment, certification, and training pipelines for both ASL teachers and interpreters. I'd also note that the funding associated with this bill is not accounted for in the governor's recommended fiscal year 27 budget adjustments. In that same bill, switching focus to community inclusion, Section 3 would increase the annual cap for the deafblind grant program from $10,000 per individual to $14,000. This funding is used to create opportunities for recreation, communication, socialization, and other services that further community inclusion for adults who are deafblind. ADS wholeheartedly supports using all available resources within this program for residents who are deafblind, as this population faces significant structural and systemic barriers in all aspects of lived experience. As the grant is a fixed amount of funding, we will caution that raising the per-person cap could further limit the number of consumers we could serve with this funding in the future, as efforts to increase our interpreter pool and efforts to increase outreach for this program to individuals who may be eligible are broadened. Lastly, I want to express strong support for Senate Bill 430, an act codifying the Americans with Disabilities Act. This bill would incorporate provisions of the Americans with Disabilities Act that are not currently included in Connecticut statutes. The ADA provides critical civil right protections for people with disabilities, including safeguards during the hiring process, access to government services, reasonable accommodation in public spaces, and access to appropriate transportation and communication technologies. At ADS, we deeply value the principles of ADA. Our program staff regularly advise not only ADS consumers on the mandates established by the Act, but also potential employers, providers, and stakeholders. We strongly support this proposal and the opportunity it presents to codify our state's commitment to people with disabilities. On behalf of our team of dedicated professionals at ADS, we thank you for your time, your leadership, and your ongoing support for the individuals we're here to support. We'd welcome the opportunity to work with you on any of these critical concepts.
Great. Thank you so much. Appreciate the feedback on 5487 about the education bill. We'll definitely take a look at that. Senator Lesser, go right ahead.
Yes, thank you, Madam Chair, and thank you, Commissioner. Good to see you. Just a question with regard to the raising the cap for the deafblind individuals. Is that fund currently oversubscribed? My understanding is that the reason we considered that was because it appeared that the department had the resources to provide that extra funding to the individuals. So you're saying that they don't, you may not, or you may not in the future.
We do have the available resources to support the increase in the cap. What I was saying as a cautionary tale is that if we do that and that's sustained, then we have been trying to outreach to get more individuals who are deafblind to be able to use it to participate in different community inclusion activities. And so it could have an impact down the road. The other problem is we don't have a lot of interpreters who can provide supports to that population. So as we tackle those two issues, we anticipate more people coming onto the inclusion grant. So raising the cap will raise those costs long term, but at this point, we do have the funds for that.
And if those funds go unspent, what happens to them?
They're lapsed.
Okay. And then I appreciate your testimony in support of codifying the Americans with Disabilities Act. The CHRO testified just they flagged an issue, obviously not our intent, but some concerns that in some cases existing state discrimination law might be stronger than the ADA. Obviously, it's not our intent to weaken state law in any respect, and I assume your department would be fine with making the changes that CHRO is recommending in terms of ensuring that we have those strongest possible protections for folks.
Yes, I haven't seen the CHRO testimony yet, but I'll definitely take a look at that. We want to make sure that we have strong protections for people with disabilities in Connecticut.
I know you do great. I look forward to working with you on that issue and others, and really appreciate your testimony today.
Thank you.
Thank you. Representative Case.
Thank you, Madam Chair. Morning, Commissioner. Going back to the sign language, I know we've had multiple discussions over that over the years. We only have certain facilities or schools out there that actually teach us. I know one is in my community with the community college, and they're having difficulty recruiting. I know we've had many meetings where are we still, a question to you, are we still working with collaborating with other states to bring interpreters into Connecticut? I know there were some issues with that, but we still doing that?
Yes, we use, right now, we're able to use the Massachusetts screening model, and folks who have passed the Massachusetts screening model are able to work here in Connecticut. That's part of our statute. Also, last year, we passed statute for the Interpreter Standards Board. That board is just starting to be set up now, and what they're going to do is create a set of certification requirements so that Connecticut will have our own, and we'll be able to set those standards and hopefully increase the pool of interpreters.
Well, thank you, because anything we can do, because everybody has different abilities, and coming from a community that has, I believe, one of the first intellectual developmental disabilities homes that is of the hard of hearing, the deaf, it's all labeled with lights and all that stuff, which is helped by the community college that has the interpreter program. We can't forget about, because, we can't just leave it on the sidelines because there's no money. It's people that need to understand and need to be able to interpret what's going on. So I appreciate your advocacy for it. I think whatever we can do here, but it's a difficult field to get people to enter into. So I know we've reached out, as you said, Massachusetts, but we need to do something here in Connecticut. People live here that need this service. So thank you.
Thank you.
Thank you. And Representative Hughes online.
Thank you, Madam Chair, and thank you so much, Commissioner. Following up on some of my colleagues, two things. Do we have an understanding of the deafblind community future pool that we are concerned about with raising the cap? Do we have any estimate of numbers as we make these services the inclusive services more accessible to folks?
We do. We have, there are currently 212 individuals that Connecticut has identified as individuals who are deafblind, and adults who are deafblind, and 53 of those individuals are receiving funds through the Deafblind Inclusion Grant.
Great. So do we have any idea if we raise the cap on the grant, and for instance, if we had the honor of serving all those folks, what that cost would look like?
I haven't done that math right now and cannot do it that quickly in my head, but we can certainly get you that. We have the numbers. We know what the cap is right now. If it's raised, it's that math. I think I might even be able to do. So
that's okay.
But we can get you.
Thank you so much. And through you, Madam Chair, I'm just wondering if we can advocate for both, like my colleague saying, the pipeline to serve these folks in terms of interpreters and more inclusion service providers, and the funding to really center these people that it's a small group, but it's so important that we as a state step up to protect them, especially in this climate. I'm not afraid of those numbers. I want to be like really proactive about our commitment to this community.
Thank you.
The other thing I just wanted to say, Madam Chair, is supportive decision making. Is there an opportunity for this committee to work on that language that you are concerned about with capacity for providing resources for, did you call it mediating the supportive decision making process? Is that what your concern is for the department?
Yeah, the way the bill is written, it has aging and disability providing information to individuals and also facilitating, forming, executing, and terminating agreements and potentially mediating. So we do anticipate that there would be a staffing need for that. We're
Mhm.
happy to work with the committee and look at other options, but in order to be able to meet the bill language, we do not have those resources at this time, nor are they contemplated in the governor's budget.
Okay, thank you. We just want to flag that for our drafting going forward. Thank you, Madam Chair.
Thank you, Representative. I don't see any other hands, so thank you so much for your testimony.
Thank you.
Next, we will hear from President Pro Tem Looney. Thank you for being here.
Good morning, Representative Gilchrist and Senator Lesser and members of the Human Services Committee. I'm Martin Looney, Senator for the 11th District, representing New Haven and Hamden. And I would like to congratulate this committee for all of the work that it does year after year in so many important areas of the law. It was my great pleasure to serve on the committee as a freshman state rep back in the early 1980s at a time when we still used quill pens and communicated by carrier pigeon. But so a lot has changed since then. But I would like to speak in favor of two bills on the agenda today: Senate Bill 433, an act expanding long-term care options, and House Bill 5485, an act concerning supported decision making. 433 would require the Department of Social Services to expand Medicaid beneficiaries' access to home and community-based long-term care. And would also require the state's long-term care planning committee to study systems and methods to increase this access. We know that that residents are desperate to find ways to stay in their own homes where possible, and believe that their mental health is improved, their levels of cognition are improved, and their just general sense of well-being is improved when they are able to maintain the degree of independence that allows them to continue living in their own homes and not be in an institution. So that rebalancing Medicaid-funded long-term services and supports will allow elderly Medicaid recipients to select the living situation that's best for them, which is almost always the home if it can be managed in that way. And House Bill 5485 would require entities, including businesses, government agencies, organizations, and medical providers, to recognize a supported decision-making agreement. And what this is, in a way, someone has characterized it as guardianship or conservatorship light. It does maintain the capacity of the decision maker to make ultimate decisions. So the judgment of someone providing assistance is not substituted for the person, but assistance is provided. So as we know, in Connecticut, legal guardianship is granted for some adults with intellectual disabilities or other problems to help manage care, housing, supervision, other important parts of life. And we do not have a provision in the law for a voluntary guardianship, and this bill would offer a greater level of autonomy to persons with those disabilities who still can and want to have more agency over their own decisions rather than being in a situation where that power is taken away from them by a conservator or a guardian. So it preserves the right of individuals with disabilities to make choices while also ensuring that they receive guidance and support from people whom they trust to assist them in understanding options and considering consequences. Thank you very much.
Thank you so much. You've been such a champion for long-term care. Truly appreciate it. Wondering if you have any thoughts that you could share about the governor's proposal on community first choice.
Well, I think I'm not sure what the cost option to that is, but I certainly support additional spending in that area to provide for greater choices in independent living. I think everyone recognizes now that we need to take measures to provide assisted long-term care for people to live in their own homes, to have assistance as often as they need. Obviously, some people need home health aides every single day. Some people need round-the-clock assistance. Others need significantly less of that. But I think we need to provide whatever level of assistance is required for people who are still not at the point where they absolutely have to be in a nursing home, especially so when we now hear about many situations with, like in so many other areas, nursing homes, many nursing homes are being taken over by private equity. And the concern there is what is the level of care? Are they only pushing profit and are not going to maintain the best staffing levels unless they're forced to? And so that's a grave concern I've heard among elderly constituents is they are anxious about what going into a nursing home might mean, and they are in fact worried that the level of care that they might get there would be less than what their parents got there a generation prior.
Thank you very much. Senator Lesser.
Thank you, Madam Chair. Good to see you, Senator Looney. And I don't know, in the early 1980s, probably dealing with the exact same issues that we're dealing with today.
Yes.
But it's good to have you back in Human Services. We're trying to figure out some procedural way to put you on the committee, but we haven't figured out a way to do that. So just a question, just following up on Representative Gilchrist, she was asking, so the governor is specifically proposed moving Community First Choice program is one of the main ways we support people in the community in this state and keep them out of nursing homes. And so the governor's proposed to convert that to a waiver, which would create a waiting list. And so that there's a clear fiscal reason why we might want to do that. That will save money. And I think the concern is that might actually cost more money to the extent that it diverts more people back into nursing homes. And I know that there are a number of different efforts that we have been undertaking over many years to move people out of nursing homes into the community. So the concern that we've heard from some advocates is that we might be moving in the other direction. So I don't know that I'm not asking you to, weigh in on this ultimate state budget or any of those big issues, because I know that, ultimately that's a subject of the Appropriations Committee and negotiations. But just, what do you have guidance for us or thoughts for this committee about how to handle those questions about where to seek savings and how do we manage costs and whether or not how to address this issue?
Well, I think again that the best care that people can get, as long as they are still independent enough to be able to manage it, is to be in their own homes with support from aides coming in to help them to whatever degree is necessary. So I think just in terms of your question, general policy, anything that supports that, I think, is good policy. Anything that kind of moves us back toward the days where the people thought first about a nursing home as the option once people reach a certain level of disability, I think that's bad policy, especially because people dread it and people fear it. And there's a high level of depression among people who finally feel that they've reached the end of the road and now I have to be in a nursing home, and that's how they feel about it. And to the extent that can be avoided by having people maintaining viability in their own home as long as they possibly can, with measures to support that, I think that should be the state's policy.
I appreciate that. Well, thank you very much. Good to see you.
Thank you, Senator. Any additional questions or comments? Representative Hughes via Zoom.
Thank you, Madam Chair. Thank you, Senator Looney, for your testimony. I do want to build on my colleagues' questions around the arc of Connecticut's history with trying to rebalance, right, and serve people with disabilities in the community. One of the questions that came up in our review of this policy is that it is not a static group. Any one of us could become disabled in the future. And I think that it is I wonder if you can comment on that in terms of the arc of how Connecticut has responded to that. You know, we started a very forward-thinking rebalancing of moving people out of institutionalization, but now we're looking at limiting that as if the disability community is a finite number, but in actuality, any of us could be and likely may be in that boat in the future. Can you talk about that?
Well, I think there are many facilities, including some that are quite expensive to live in, to have graduated care that people can move in there when they are in need of just some assistance in terms of maybe a housekeeping and other maybe heavy tasks around the house that they can no longer do. But many times those folks are still maybe still driving, still able to perform many tasks for themselves. And within that facility, they will then gradually move to higher levels of care, including skilled nursing home care, perhaps near the end of their lives. But I mean, that's really an ideal model for people, I think, who are able to be served at the level they need at a given time.
Right, but some people move in and out of that depending on their abilities, right? You know, it's
That's right. I
not
mean, some people
it's
have
not a
attempted-
progression,
No.
you know, like ultimately not necessarily a progression like you described. It could be you know, for a period of time. And that's what I think that this policy is very regressive in considering. So I appreciate your views on how to not go backwards. Thank you.
Okay, thank you.
Thank you very much. Not seeing any questions. Thank you for being here today.
Thank you very much, and congratulations again on the great work of this committee year in and year out.
Thank you. All right, next we will hear, because we have 2 minutes before the hour, from Melvet Hill from the Commission on Women, Children, Seniors, Equity, and Opportunity.
Good morning. Good morning, Senator Lesser, Representative Gilchrist, Senator Perillo, Representative Case, Senator Marr, Representative Comey, and other distinguished members of the Human Services Committee. My name is Melvet Hill. I'm the Executive Director for the Commission on Women, Children, Seniors, Equity, and Opportunity. And I'm joined here by my colleague, Michael Werner, who will introduce himself momentarily. We wish to express support for a number of bills, which is reflected in our testimony, our written testimony that's posted. I will speak to a few bills and Michael as well. So the Commission on Women, Children, Seniors, Equity, and Opportunity supports HB 5486, an act concerning a diaper partnership grant program, as it is an investment in the health and economic stability of Connecticut families. The bill establishes a $1 million grant program administered through the Department of Social Services to support diaper distribution through trusted community partners and hospitals. This is a smart and effective approach because it leverages existing community networks that already serve families and understand local needs. Diaper insecurity is linked to negative health outcomes for the child, for parents, and for caregivers. Infants and toddlers encounter severe rashes and infections, while parents, especially new mothers who are unable to afford diapers compared with those who can, are twice as likely to report feeling depressed nearly every day. When families cannot afford diapers, there is also an economic impact. Most licensed childcare providers require parents to supply a 1 week's worth of diapers. Without them, parents can't drop their children off and they can't go to work or they can't further their studies. 1 in 4 caregivers has missed work or school because they lacked enough diapers for childcare, leading to lost income and financial instability for families already experiencing financial strain. Organizations such as the Diaper Bank of Connecticut have demonstrated the success of this approach through programs like the Diaper Connections Program, which distributes diapers through community-based partners across the state. These partnerships help ensure that diapers reach families quickly, efficiently, and with dignity. CWCSEO also supports HB 5488, an act establishing a task force to study expanding the 211 info line program, with the recommendation that we be added to the task force. We engage and collaborate with a diverse group of constituents so that we can understand their needs and drive solutions. Our inclusion in the task force will ensure that the unique and intersecting needs of our residents will be included. Establishing a task force to study the expansion of the 211 Info Line program is a timely, prudent, and necessary step, and we support efforts that strengthen the infrastructure connecting residents to vital services. And Michael, I invite your comments.
Thank you and good afternoon. My name is Michael Warner, Lead Aging Policy Analyst for CWC SEO, and I am here to speak in favor of Senate Bill 432 and 433. And we really applaud the Human Services Committee for raising these bills, which help to give guidance and affirm our commitment to self-direction and aging in place, as well as to improve accessibility to important benefit programs. HB 433, an act expanding long-term care options, thoughtfully lays the groundwork to meet the needs of our booming older adult population. By 2040, the nation's population aged 85 and older is projected to more than double, and Connecticut ranks 4th in the country for its share of residents in this group. In addition to my role at the commission, I serve as the administrator for the Long-Term Care Advisory Council, which partners with the Long-Term Care Planning Committee to design our state's 3-year long-term care plan. And this bill continues our state's efforts on rebalancing while emphasizing home and community-based services and increasing opportunities for greater participation by those who may not qualify among the aged, the blind, and disabled populations to receive care at home. And the bill also calls for the Long-Term Care Planning Committee to study systems and methods to expand services and report out to the CGA. And while we're currently engaged in this work for the next 3-year report, it's important to have this direction to further affirm this work in exploring new and innovative solutions. And Senate Bill 432, an act disregarding the cash value of life insurance policies in eligibility determinations for certain public assistance programs, it continues the legislature's efforts to promote intergenerational wealth development by ensuring that families aren't harmfully penalized following the passing of a family member. Currently, life insurance policies that have a face value of over $1,500 are counted as assets when determining eligibility for several state benefit programs. The current bill would disregard the cash value of these policies when determining eligibility for Husky, temporary family assistance, the state supplemental program, and the state administered general assistance program. So this bill follows precedent by Public Act 21-161, an act concerning property that is exempt from a judgment creditor. And similarly, this bill importantly preserves a safety asset for family and allows the next generation to build towards long-term financial independence. Thank you for the opportunity to testify today.
Thank you both so much for being here. And I made a note about 211. Representative Hughes, go right ahead.
Thank you so much for your testimony. About that disregard, do you happen to know if other states already disregard the life insurance policies as part of eligibility?
Yeah, thank you so much for that question. And while here in Connecticut, we're working towards that, I'm going to circle back to you and follow up with you about other states also doing this work. Thank you.
Thank you, Madam Chair. It just seems like this is a leftover, penalizing folks who are trying to support self-determination. So I appreciate your testimony because it seems like a no-brainer. Thank you.
Great. Thank you so much. Yep, Representative Comey, go right ahead.
Thank you so much, Melva. The diaper bank bill, or the diaper, I don't know if it's a bank bill, but the diaper bill. As you mentioned, the diaper bank distributes to some of the community organizations and that sort of thing. Are you familiar why this sort of different approach? Is there a different clientele that, to go through the hospitals and things like that? Is there a different approach to this that maybe will catch some more folks, or are you familiar with what the thinking is on that?
I'm not familiar with the thinking is on that. I do know that the bank has shown their success over a number of years, including during the pandemic when they were delivering diapers to as many people as they can in those areas where we normally didn't see people needing diapers, and also partnering on things like how can we ensure that we get books to children, right? So I think that there's innovation that exists at the diaper bank, and I think by supporting, more funding and really thinking about the catchment areas outside of the norm, I think that there is a need out there that we're not quite seeing, similar to what we're seeing with food insecurity, where there are towns that we weren't quite aware that people were food insecure. So I think we're seeing some of those similar trends, but we can get back on more details and data.
We'll probably learn some more today when the long day ahead. Thank you so much. Thank you both. Thank you, Madam
Thank
Chair.
you. I don't see any other questions. Thank you so much for both of you being here today.
Thank you.
Next, we'll hear from Marianne Langton. Yep, you can testify on whatever bill you'd like.
Hello, Senator Lesser, Representative Gilchrist, and distinguished committee members. My name is Marian Langton from West Hartford, and my personal assistant, Kayla Sage from Hartford, will be reading this statement. This statement is for the CT ADAPT, which fights for the civil liberties of people with disabilities. CT ADAPT is in the favor of HB 5485. Supportive decision-making, SDM, is a powerful alternative to guardianship and conservatorship that empowers people with disabilities and other adults to maintain their rights while receiving assistance and making important life decisions. Why should people with disabilities give up their rights when all they need is a little support with making a choice? We know many people with disabilities that will find supported decision-making very helpful while seeking new and better options that will assist them with everyday life. These options covered under HB 5485 enable written SDM agreements to be honored in critical areas such as housing, healthcare, education, and finance, ensuring that individuals can access support where it's most needed. Currently, 29 states and the District of Columbia honor SDM as a valid option. CT ADAPT is urging all of Connecticut to join them by adopting SDM and supporting the autonomy of its residents. This is the second one. Hello, Senator Lesser, Representative Gilchrist, and distinguished committee members. My name is Marianne Langton, and I am from West Hartford. My personal assistant, Kayla Sage from Hartford, will be reading this statement as well. This statement is from CT ADAPT, which fights for the civil liberties of people with disabilities. CT ADAPT is in favor of HB 430, an act codifying the Americans with Disabilities Act. This bill is so needed at this time where our country dismantled the ADA law on a federal level. CT could be a leader with the protecting the rights for people with disabilities while demonstrating to other states the importance of this act. Thank you.
Thank you. Thank you for your testimony on both proposals and for being here. Representative Hughes on Zoom, go right ahead.
Whoops. Sorry, got the wrong one in. Thank you, Marianne, for your testimony always. I just want to ask two questions of you. Well, one question. Sorry, I had the wrong earbuds in. Can you hear me now? Yeah.
We could hear you the whole time.
Oh, sorry. Marianne, I want to ask your opinion as to why you think we have not, as a state, codified the Americans with Disabilities Act here in Connecticut and passed supportive decision-making. What's your opinion? Why we have not yet?
We bring it up every year. Maybe this is the right year. More education, make you feel comfortable.
Is it the education of the legislature, the legislators you think that needed to happen?
Everyone.
Everyone. Thank you, Madam Chair. I just wanted to hear her perspective.
Great. Thank you so much. Representative D'Amico. Oh, it went up, it went down. Do you have a question?
Yes, thank you, Madam Chair. I just wanted to say thank you, Marianne, for coming and testifying. You have testified in front of this committee, in front of the Environment Committee, in front of the Public Health Committee, in front of the Appropriations Committee, and to reference what Representative Hughes was talking about with you a few minutes ago, you have educated us to a tremendous extent, and we are. I personally am grateful. I know my fellow legislators are grateful for your constantly keeping us informed. So thank you. Thanks, Madam Chair.
Thank you very much. I second that. Thank you. Great afternoon. Next is number 41, Susan Garafa. We're
Hi, my name is Suzanne Graffa. I'm representing ADAPT, and Ruth Gobi is going to read my statement to you.
And Suzanne is also a volunteer advocate with the Citizens Coalition for Equal Access and the Wheelchair Reform Coalition. So now these are Suzanne's words. I have had cerebral palsy since birth, when I was put in an incubator because I was premature. I am now 60 years old and have been battling for my independence my entire life. I am alarmed by developments at the federal level that may undermine the rights that people with disabilities have been fighting for years. I already have a hard life, and the federal government is making it even harder. It will be like going back to the 60s, and we will have to start all over again. We really need Connecticut to continue safeguarding our rights, and SB 430, the act codifying the Americans with Disabilities Act, would assure that process. As part of the protection of my rights, I also support HB 5485, an act concerning supported decision-making. Just like every other disability rights issue, the protection of my decision-making has taken years of effort to address in Connecticut, even though lots of other states have adopted supported decision-making. When it comes to difficult issues in my life, I already consult with trusted allies, but I would like my independence to be recognized by banks, doctors' offices, and housing services, especially as I am presently trying to find a new apartment home. Please make up for so much lost time and raise SB 430 and HB 5485. Thank you very much.
Thank you very much. Thank you for being here and for your testimony. Senator Lesser.
Thank you, Madam Chair, and thank you for your testimony in support of both bills. And I have family member who's gone through a very similar experience than you have. So it's very important to hear your voice. Specifically with regard to the Americans with Disabilities Act, where I think the concern is about potential future action nationally, how to make sure that people are protected in Connecticut. I have heard from some folks who say that we don't need to do anything because the Connecticut Constitution says you can't discriminate against people with disabilities. You said that's not true. We get discriminated against it all the time, and I think that is.
Sorry.
Yeah. No. I think that's what we're looking at exactly. That's the question we're asking. So when we hear from folks, I heard from someone this morning who said we don't need to do anything because the Connecticut Constitution since 1984 has said discrimination doesn't happen. Clearly, you think that we need additional statutory protections. Okay.
2026 right now, right? And we've had the ADA for years, okay? And we have to fight for it now. And that's not right. So whatever you could do to keep this going would be greatly appreciated because I don't want to end up in a nursing home. She doesn't want to end up in a nursing home. We want to stay able and forget we're disabled. We are people.
Yes, you are, and we hear you loud and clear. Thank you very much.
Thank you.
Thank you very much. Yes, Representative Dathan. Wait, don't go.
Oh.
I'm so sorry. I'm so sorry. Thank you so much, Madam Chair. And I just wanted to follow up on your testimony on 5485. How have you seen and how would you expect to see supported decision-making work in your life?
I think it would give, when I go to doctors, people will look at me instead of the PCA. I keep my PCAs in the waiting room because if you have them in the room with you, they look at the PCAs. So I don't have my PCAs go in with me because of that reason.
So it's almost like, you know, if you have the PCAs there, you feel like you're treated like a child.
Yes.
Yeah.
So that's why I keep my PCAs out in the waiting room.
Understand. What about in certain situations like going to the bank or other sort of situations like that? How would you feel that supported decision making would have that in statute explicitly? How would that help your life?
You wouldn't. You would not be able to go. You would not be afraid to go in the bank because people will look at you. I have gone to the bank because I lived in Bishop Corner. Okay, so I just walk over there. And I also say, if you don't look at me, you're not going to get my business. But there's a lot of people in this community that doesn't have that opportunity. So I'm here fighting for them as well.
Yes, you know, especially if and going into another bill about wheelchair repair. But, you know, if you have sort of disrepair of your wheelchairs, you're not able to get out. And again, this is so important. And just like
me.
Yeah. And just like anytime any of us go to a store and somebody's helping you, if they're not paying attention to you, it really is dehumanizing, I think. And I think you've highlighted that in your testimony.
I think, all right, I'm going to try to be politically correct here. I am not a person that will fight you all the time, but when I have to fight, I will fight. And this is time we need to fight because everything wants to change and we'll be going backwards. We cannot afford that. All right. We are disabled and we have different disabilities. If you keep waiting to see if this will pass, people will die. People will die. So please think of us, think of the people that died already and that the people that could die don't die. So pass this bill.
Thank you so much. Thank you for your testimony. Thank you, Madam Chair.
Thank you.
Back up or not?
Yes, I don't see any other questions. Thank you so much for your testimony. Next, we're going to go to number 39, Karen Healy.
Hi, good morning, good afternoon. My name is Karen Healy and I live in Hartford and I'm a consumer and I vote also in Hartford. My situation is that I live in I'm out in the community. I was discharged from CVH in December 4th of 2014. Thank the graciousness of my mother because I had 2 long admissions there. My first admission was 5 years. Was there from January of 2006 to May of 2012. My grant went from there. I went to a program that the DEMIS when the commissioner had set up for me, saying that I would never ever lose my place. Guess what? They said I lost that bed very quickly and wound up back at CVH. And the last time I was there, with a little over a year, I got into a program that's very good for me. I have 24/7 staffing. But my problem is that as a person who's been in the system, if my mom and my family didn't hire an attorney when I got out of the last time, I might still be 11 and a half years later, still sitting in a day room being made fun of and being laughed at. When you're at from my experience, when I was at CVH, I could sit in a day room and people would be talked to and be made fun of and things would happen. I've had things happen to me where I've had the APO officers come and tell me, oh, you're a liar. That couldn't have happened to you. Where I had things of proof of things that happened to me, bruises and stuff. You know how they look at you and they tell you, oh, you're crazy. You're nuts. You don't know what's happening to yourself. And you don't see things and nothing like that can happen to you. And situation that me and another patient, we were in the day room, we both saw a staff take a client, pull the corner of their collar of the shirt because they wanted a cup of water. And then we got taken to 2 different rooms to be told we were liars. We didn't know what we were saying. So in my opinion, for certain things like that, being in the community and being out in the community, my family didn't hire attorney, like I said, they said it was like 270 laws were broken just on my case at that time at CVH when I was there. The other thing is that I'm trying to say is that like people like me, I have a long history of mental health issues. I was hospitalized for 24 and a half years of my life as a young adult to an adult age. My situation is that when I go, like if I go to Hartford Hospital for a medical thing, the first thing they're going to do is they're going to treat me like, okay, what'd you do to yourself this time, Karen? Put me in an orange pod or put me in another area which now closed off that holds you for psychiatric issues. And that happened to me in December of last year. When I had a medical issue, they brought me right into the back room in orange pod, took all my belongings away, took my shirt, took my pants, took my everything. The only thing I left had was my undergarment, not on the top, and my cell phone. That was very grateful they let me have that. But it's really true that people like us do not need to be judged because of our history. You know, your history doesn't mean it's always going to be with you. You have every right to change my behaviors of hurting myself to a point really badly after my mom died. Grateful that God knew it was in my time to go, you know, but I'm as human as everybody else in society. I might deal with issues differently, might take medication, might have a therapist, might be in a program longer than I need to be or anything.
Can you please summarize?
Yeah, I'm just wanting to say, I think it's very important that people with consumers who have disabilities should not be neglected or made fun of or not taken seriously. So that's my opinion for today. That's what I wanted to share. Thank you.
Thank you so much. Thank you for your testimony and for being here today. I don't see any questions. Have a great afternoon. Next, we will hear from Kelly Dorsey.
Good afternoon, Senator Jay. Good afternoon, Gilchrist. Good afternoon, Mary Fortier. And good afternoon, Datham. My name is Kelly. I'm a self-advocate coordinator here at Midstate ARC, where I support my peers in speaking up for themselves, making their voices heard. I've also worked at ShopRite for 27 years. I recently moved into Bristol's Mason Transition House, where I'm learning to live independently. I cook my own meals, make grocery lists, clean my home, and manage my own medications. I use assistive technology and remote support to help me along the way. My goal is to live in my own place and make my own choices and decisions. Right now, my mother is my plenary guardian. That means she has legal right to make decisions for me. When I turned 18, guardianship was the only formal option available. There were no legal middle ground. No legal middle ground. It was either full guardianship or nothing. My mother has always practiced supported decision-making within that guardianship. She helps me understand my options, teaches me how to make good decisions, and I am grateful for that. But if supported decision-making had been in Connecticut when I turned 18, I would have chosen it. I would have kept my rights while still having the support I needed. Unfortunately, many of my friends do not have the same support I do. Decisions are made for them, not with them. They do have someone that helps take the time to help them understand or learn. That's not right. And it does not have to be this way. Raise Bill 5485 would give people like me, people who can make their own decisions with the right support, a legal way to help keep in our rights. For those who truly need a guardian, that option would still exist. This bill creates a path that fits the person, not a one-size-fits-all solution. I respectfully urge you to vote yes on 5485. Every person deserves the chance to make their own choices with supports when they need it. Thank you.
Thank you so much. Thank you for your testimony. That's very helpful. Representative Dathan.
Thank you so much. Thank you for your testimony. So how did you hear about supported decision-making? Because it's available under the law, but it's not sort of explicitly stated. So when you have come across this, how did you hear about it, or how did your family hear about it?
Through Pam Fields, Mid-State ARC. She's phenomenal. So she was the one that talked to my mom a while ago and said, when I was growing up, well, this is not available. Well, this is hopefully a bill that you guys support it. So come on, make it happen.
Great. I know the good House ranking chair and our House ranking member and I worked on this discussion a couple years ago when we were doing our 5001 bill. And I know this is something we really wanted to tackle at that time, and it just wasn't available time restraint wise. But one of the things that did come out of that bill is information passed to schools, so that when people who have maybe 504s or IEPs get the information about supported decision making as they transition from the school system, I think that, you know, will help facilitate folks like yourself, if you were 18 at the time, to get that information a little better. But
Sure.
Anyway, thank you so much. And thanks to your mom for being such a good mom.
Thank you, everyone. Thank you,
Thank you,
Jay.
Madam Chair.
Thank you. Have a great afternoon.
You too.
Next, we will hear from Carolyn Newcomb.
My name is Sarah, okay, and Carolyn and I are close friends, but this is Carolyn Newcomb's testimony, okay? I just happen to be loud. Anyway. My name is Carolyn Newcomb. I have lived in northeastern Connecticut most of my life. Recently, I reside in Willimantic. Currently, excuse me. I have a lifelong disability. Specifically, I have cerebral palsy, which in my case was due to lack of oxygen during the birthing process. One of the effects of my disability is speech impairment. it makes it difficult for someone who doesn't know my speech pattern to understand what I am saying. For many years, I've had difficulties doing business with certain types of institutions, namely banks and health insurance companies. For 37 years, I had a trusted personal assistant help me with financial transactions or health care information. Every time we did something out of the ordinary with a bank or credit card company, we had to go through this rigmarole to verify that she could speak on my behalf. Even though I spoke to saying I was allowing Cleo to speak on my behalf, the representative would usually decline verification or make us go through more hoops. Finally, after much frustration, we decided to put her name on my bank account. Years later, shortly after she retired, someone pointed out that there could have been unintended consequences for having her be on my bank account. She isn't on the account anymore. A similar scenario occurred with some health insurance companies to a lesser degree because interaction wasn't necessary. The above are primary examples of why support decision-making concept needs to be in the Connecticut statute. There are 29 states that have laws in their state. Can Connecticut be next? It could have a great positive impact on people with various types of disabilities. I would also like to express my outrage with the governor's proposal to cut funding to the Community First Choice, which is a program which enables people to live in the community of their choice. I know several friends who could end up in nursing facilities. Their fear is great and my heart hurts for them.
Thank you so much. Thank you for your testimony. Thank you for reading the testimony. Any questions? Thank you very much. Appreciate you being here today. Next, we are going to Sylvia Elias.
Madam and Mr. Chair and distinguished members of the committee, I'm Sylvia Allais. I'm President and CEO of the Connecticut Hospice, and I'm in support of Raised Bill 5481. This will help patients who are physically stuck in hospitals because they are not eligible under Medicare or Medicaid for inpatient hospice, decompress hospitals, and save the state millions of dollars. Hospital emergency rooms are backed up with patients waiting for medical and surgical beds. The beds are filled with patients on comfort measures, with disposition issues, their illness too complicated, needs too great, and life expectancy too short for a nursing home to accept them. They have no family or caregivers to take care of them. They are stuck in settings not designed to manage their advanced illness or end-of-life needs. Rapid expansion for-profit operators nationwide has triggered aggressive Medicare and Medicaid clawbacks, making providers hesitant. As a result, patients who could benefit from our care remain in hospitals. Connecticut Medicaid spends $207 million a year paying for extended hospital care for patients stuck in hospitals. Discharged or placed patients then end up back in the emergency room. A 20% rehospitalization rate in Connecticut is costing the state $110 million a year. As a specialty hospital, we can prevent unnecessary hospitalization. A 1% reduction in preventable hospitalizations will save the state $1 million a year. Only 55% of eligible patients access hospice. Earlier access can save the state an additional $18,000 per beneficiary per hospitalization. The proposed legislation establishes a partnership with the state to allocate funding to the Connecticut Hospice for 30 beds to support patients with disposition issues. Paying room and board at $820 a day will be a fraction of the current cost to the state. and will result in savings of 13 million a year and more based on the high per diem outlier costs of Connecticut hospitals. We conducted a study admitting patients earlier and allowing them to stay when they no longer met hospice criteria, inpatient criteria. The average length of stay was 8 days, with a median of 2.5. As the founder of the hospice movement in America and a nonprofit, we are urgently calling on you, who once had the foresight to establish hospice care, to step up again and do what's right for the people of Connecticut. We hope you will partner with us to resolve a systemic issue. Based on the heartfelt testimony you will hear today, I strongly urge the committee to endorse and support Bill 5481. Thank you.
Thank you very much. Representative Comey.
Thank you so much. Hello, Sylvia. Thank you for coming here with your team. I'm looking forward to hearing all the different testimony from different perspectives. And as CEO, I suppose, of the Connecticut Hospice, which happens to be in the lovely 102nd District, I would like to ask just a few questions because we've sat down a couple of times and talked about how this could really improve patient care, especially when you have folks coming, people that are fragile, patients that are fragile coming in and out of the hospital. And so I was wondering if you could explain the difference between, say, a routine hospital stay and a general inpatient hospice stay.
Absolutely. So routine hospice is really your standard hospice care that will be provided in a home setting. So it's at home or it's in a nursing home. The patients are very stable, their symptoms are under control, and they don't need frequent interventions. And those are often the patients that are stuck. They can change rapidly at any point. And that is when they qualify for general inpatient hospice care in a facility. So this is a short-term hospital or a facility stay. The patients are very symptomatic. They need frequent interventions. They cannot be at home, and they cannot be in a different setting than a facility. And those patients, sometimes, many of them would become very symptomatic, and they would pass. But sometimes they actually stabilize, and now they need to go home, or they need to go back to a facility. And the study that I just talked about really showed that they sometimes live for 2 days or for 8 days. It is a horrible thing for families to move from a facility back into the community when they clearly can't take care of them. So this is for upfront and the back end. Thank you.
Thank you. And so right now, the room and board is not covered. You do get, I think, $200 or something a day, but the room and board is not. Who pays that?
So the room and board, if a patient that is no longer qualifying for general inpatient is moved back to routine level and would stay in the facility at $200, the family would have to pay the difference or would have to pay for the room and board. Now, clearly, when we talk about Medicaid patients, they don't have money to pay for that.
Yeah. And you have, I know I'm asking too many questions. You have, how many beds do you have that, we have a lot of overcrowding issues. We haven't heard a lot of that in this committee. It's been a public health committee issue, but we know that the hospital ERs and things like that, and we're constantly shifting patients around. And I'm just wondering, we're a few miles from the hospital in New Haven, and wondering how many beds you have that you would be able to open up for this.
So we currently have 52 licensed beds, and I was suggesting, just to show the cost savings, that we allocate 30 of those beds specifically for for patients with disposition issues stuck in hospitals.
Wonderful. I think that's it for now, Madam Chair. Thank you for coming. We'll see you.
Great. Thank you very much, Representative Comey. I don't see any other hands. Thank you for being here and thank you for your testimony.
Yeah.
Next, we'll hear from Pamela Fields. I just want to remind folks on the Zoom that you need to accept the promotion, please. You just need to push the button. There
Now
you
it's
go.
on. Okay. Good morning, Representative Gilchrist and members of the Human Service Committee. My name is Pam Fields. I'm the CEO at Midstate ARC and Living Without Limits, our new company. I have submitted a longer version of my testimony, and I am in strong support of House Bill 5485, an act concerning supported decision-making. This bill addresses a critical gap, one that I witness firsthand as we support the people through my organization each day. Midstate ARC has 24 people living in supported housing with assistive technologies and remote supports right now. We have an additional 34 people moving into these environments in the next year. And we also have 5 people in our Mason transition house, which Kelly talked about earlier, working toward moving into supported housing. And there are many agencies providing these services throughout our states. Supports for the first time in history that people with complex cognitive issues finally have the choice to live independently. So it's a big issue for a lot of the people we support. When supporting decision-making is not formally recognized, well-meaning families, providers, and courts frequently turn to guardianship. And the consequences of this can be profound and lasting. What we have seen is individuals inadvertently lose their voice, they lose their ability to make decisions, they lose their ability to self-preserve, and they lose their autonomy. The state of Connecticut and many nonprofit agencies such as Midstate ARC are investing enormous resources in these new technologies that increase independence. It would be a profound waste of these resources and a disservice to the people we support to equip someone with every tool they need to direct their life and then deny them the illegal authority to do so. Supported decision-making is not the end of this journey, it's the framework that makes it possible. This is what allows a person with a disability to grow into independence. It's what allows them to practice decision-making in real life with real support, with a legally recognized way. The people I work with every day are not asking to be left alone. They're asking for the right kind of support that accompanies them but does not replace them. House Bill 5485 gives Connecticut the legal infrastructure to provide exactly that. I respectfully and strongly urge you to visit supported housing and transition housing located around Connecticut to see this in action. It's a solution we have been waiting for. It's the future. It not only helps people with intellectual disabilities, but people with any kind of barriers to independence. And I urge you to support House Bill 5485 because Connecticut's residents who have disability issues deserve the opportunity to make their own decisions. Thank you.
Thank you very much. Representative Case.
Thank you, Madam Chair. Pam, I just want to say, there's been a lot of discussions on this and we get it. We want to make sure that, I always talk about different abilities. Everybody has different abilities and we want to make sure that people are able to make those choices. Representative Dathan and I have been on multiple meetings with probate judges, judiciary. This is going to come out of here, but it's going to have to go to another committee because you are impacting probate courts and other things. And we need to educate those on why this is important. We want people to have the ability to make their decisions with a little bit of assistance, but we have to follow the guidelines of the judiciary. So we have many more steps with this. I think Representative Dathan will say that our meetings have been very robust and a lot of learning. We get it. We just need to know how we get it one step farther to make it law. So everybody can be able to make their own decisions. So I thank you for coming, and everybody else that's here to make sure we have commissioners buy-in on DSS, DDS. I mean, we just have to get it across the line. But thank you.
Thank you.
Great, thank you very much. Let me just check Zoom. Yes, Representative Hughes.
Thank you, Madam Chair. I'm just so grateful for this opportunity to really get some of these nuances on the record. Like my colleague said, this is going to have to go to judiciary, and we're trying to educate everyone and the public as to why this is so important. I'd just like to ask you, what like you said, we work every day to support people. You said something about the practice of this supportive decision making and self-determination. I think that's really critical for us to understand that we have systematically denied people with these cognitive barriers full empowerment. So talk to us just briefly about how this bill would support an onboarding and practice of, supportive decision-making and self-determination.
I think the unintended consequence we're seeing in the systems we've already established is people are making decisions for other people and they never learned how to do that. And so they become quiet and they become more vulnerable and they're not really fully included in their community. So by giving supported decision-making as an option, people can now use their voices and learn how to speak up and therefore become more included and more powerful in their own lives.
Thank you, Madam Chair. I just wanted that to be fleshed out for us a little bit as we move this forward. Thank you.
Great, thank you, Representative. Thank you so much for being here. Next is Monica Nugent.
Good afternoon, Representative Gilchrist and members of the Human Services Committee. My name is Monica Nugent, and I am the Manager of Public Policy and Advocacy at the Connecticut Community Nonprofit Alliance. The Alliance is the statewide association of community nonprofits. Community nonprofits provide essential services to over 500,000 individuals and families in Connecticut every year, improving the quality of life in communities across the state. The Alliance supports House Bill 5480, an act concerning peer support services under the Medicaid program. This bill would create an avenue for peer support services to be reimbursed under the state's Medicaid plan. This is a step forward in recognizing the important role that peer support specialists play in an individual's recovery. Peer support services are recovery-focused services provided by specialists who have experienced recovering from mental health or substance use conditions. They are a crucial part of behavioral health treatment, and a growing body of evidence and experience in Connecticut indicates that these services are highly effective at treating mental health conditions and helping people recover from substance use disorder. Peer support specialists create the type of authentic connection necessary to sustain recovery, more so than just clinical intervention alone. Currently, only specific grants are available to nonprofits to cover peer support services. Nonprofit providers are unable to afford these valuable patient resources without such grants. Additionally, federally funded Certified Community Behavioral Health Centers, CCBHCs, are getting reimbursed for this work. The state is going to hopefully be bringing the model under Medicaid, but that timing is still unclear. The work of peer support specialists can be just as impactful and important as licensed counselors or APRNs who are able to bill for these services. It's long overdue for Connecticut to include these services in its Medicaid program. The Alliance urges the committee to support House Bill 5480. Thank you.
Thank you very much. Any questions? Okay, thank you. Appreciate your testimony. Next up is Michaela Fissel. Is Michaela with us? Yes, go right ahead.
Hey, good afternoon, respected members of the Human Services Committee. My name is Michaela Fissel, and I work in the role of Executive Director at Advocacy Unlimited. Advocacy Unlimited is a nonprofit organization. We have existed for over 30 years, providing holistic, peer-led recovery resources in the areas of mental health, addiction, and trauma. And I'm here today also with over 18 years of professional experience in program administration, research, and also service delivery in the space of peer support services. And I also have the information from our organization where we have been tracking the number of individuals we've served now for years through an internal accountability system and also in compliance with our contract provided primarily through DEMIS funding. We serve over 13,000 people annually. And as part of that number, we actually receive over 3,000 calls annually from Connecticut residents who are seeking resources. And also 300 of those callers are people seeking individual advocacy supports. And so this brings me to asking the committee to please support House Bill 5488, which is the task force to study expanding 211 info line, and ask that Advocacy Unlimited be included as a member of that task force, given the unique insight that we can provide as a peer-run organization, but also having so much contact with the community with over 3,000 calls annually. We also are asking the committee to support House Bill 5485, which is the supported decision-making for many of the reasons already shared by folks testifying today, and that can be seen in public testimony. And this is really to strengthen consumer and patient rights protections. We know firsthand, based off the calls that we receive, but also as people in recovery ourselves, that often patient rights are kind of put aside. And we know that this will strengthen the DEMIS Connecticut Patient Bill of Rights and also the American Medical Association Code of Medical Ethics 2.1 Informed Consent and Shared Decision Making. It's really important that Connecticut adopts a supportive decision-making law. Finally, it brings me to House Bill 5480, Peer Support Services and Medicaid Program. I am asking the committee to support this bill. And this is important for all the reasons already shared. And it's so wonderful to see so much support coming out for this bill. We know the importance of funding reimbursement for this essential service. I am asking that there also be consideration for the inclusion of peer credentialing in Title 20 as part of this bill, and that a review of the newly released peer credential CPSRP as referenced in the DEMIS Commissioner's testimony be reviewed through legislative oversight, with 800 certificates already given out through the grandparenting process. We as the peer recovery community have significant concerns regarding the standards and rollout of this new credential. We are requesting strengthened legislative oversight, and we are available to provide feedback and information regarding our experiences having held.
Can you please summarize?
The Connecticut contract for actually providing the education and the RSS peer credential for over 15 years. We would really greatly appreciate the opportunity to participate more meaningfully in the process. Thank you so much for giving me an opportunity to share, and thanks for giving me a couple extra moments.
Thank you very much. Don't tell anybody I did. Any questions from members of the committee? Representative Dathan.
Thank you so much, Mr. Chair. Thank you, Michaela, for your testimony on peer support services as well as supported decision-making. It's really useful. I know last year there were some concerns on the bill, and we've talked a lot and tried to take into account some of the concerns that were raised. Can you kind of elaborate what Title 20 accreditation might mean in comparison with other sort of accreditations in our state?
Yes, thank you so much for that question, and also to legislative leadership for inviting many members of the peer community to participate in the crafting of this current bill. The best example would be community health workers. As you can see in Title 20, the credential is clearly defined, recertification is clearly defined, the provision of service is clearly defined, and there's actually an association of community health workers that is a nonpartisan inclusive group who provides leadership and directive on matters pertaining to this professional credential. And we would love for that to be replicated for peer support workers here in the state of Connecticut.
That's useful to know. This association, is this a U.S. Organization or Connecticut, just or federal?
This is a Connecticut-based association of community health workers. And I do believe that the peer community in Connecticut, the peer support workers, we are ready to participate meaningfully in that level of leadership at the state level.
Okay. And my last question, Mr. Chair, is you talked about oversight. I'm co-chair of the Government Oversight Committee, and this is something that I think a lot about. Under this proposed bill, what sort of oversight would you suggest on the peer support community to ensure that we're doing things correctly?
Thank you for that question. So back in, I believe it was 2019, there was a task force to study peer support services proposed, and that's okay that it wasn't actually established. I understand that there's a lot of task forces that are proposed that don't come through. However, there was some important work that was going to be carried out through that task force to look at the total landscape of Connecticut's peer support services landscape, and the importance of oversight ensures that there's a checks and a balance. And currently, it appears that peer support services is not found in legislative statute or government statute. And so inclusion of Title 20 would be a great step, but also it would be helpful to have a task force to study peer support services here in Connecticut and to look at the CPSRP credential that's currently in the grandparenting phase, as mentioned in the Demas Commissioner's testimony. Currently, there's 800 certificates that have been given out. However, we know as a credentialing agency currently that there are no standards for the CPSRP that have been released to the public. There's no recertification standards or process that's been defined by Demas. And although we've asked repeatedly for information and for a greater degree of transparency, this has not occurred. And so at this time, we are asking for the legislature to engage Demas in a process where we can have transparency within the CPSRP credential. And that may be inclusion in the Title 20.
That's super helpful. Thank you, Michaela, for your testimony, and thank you, Mr. Chair.
Thank you for your questions.
Thank you, Representative. Other questions from members of the committee? Seeing none, thank you for your testimony. Next, we'll have Carl Mancini, followed by Carla Torres.
Good afternoon, Senator Lesser and distinguished members of the Representative Gilchrist and distinguished members of the Human Services Committee. My name is Carl Mancini, and I'm the business manager for Advocacy Unlimited, a peer-led nonprofit organization that has supported recovery in Connecticut for more than 30 years. Advocacy Unlimited is also one of the state's 4 designated training organizations for peer support workers, preparing individuals with lived experience to provide effective, recovery-oriented services across Connecticut. I am also a person in long-term recovery and a former pharmacist who personally benefited from peer support services during my own recovery journey. As someone who spent decades in the traditional healthcare system, I can tell you that peer support provided by a nonprofit organization like Advocacy Unlimited fills a gap that clinical services alone cannot. For me personally, peer support was the bridge that helped me move from surviving to thriving. It allowed me to reclaim my life and eventually give back to others walking a similar path. Today, I have the privilege of supporting a statewide organization dedicated to recovery and empowerment. And I know that many others could experience the same transformation if peer support services continued to be strengthened and supported. House Bill 5480 represents an important step towards expanding the availability of these services so that more people across Connecticut can access support from trained peer professionals. Increasing the number of individuals who can provide peer services will help reach communities that are currently underserved, reduce wait times for support, and create more opportunities for individuals to engage in recovery earlier and more consistently. At a time when our state continues to face significant mental health challenges, expanding access to peer support is both practical and cost-effective. Peer services have been shown to improve engagement in care, reduce hospitalizations, and help build meaningful lives in recovery. While I strongly support the intent and direction of this bill, I do have one concern regarding the language that states that a peer support professional may have lived experience. From my perspective, lived experience is not optional in peer support, it's essential. For that reason, I respectfully encourage the committee to consider strengthening this language so that lived experience remains a required and fundamental component of peer support roles. In addition, I would also like to express my support for adding peer support services to Title 20 in Connecticut. Including peer support within Title 20 would help formally recognize peer support as a professional service within our mental health system and move forward towards standardizing the credential in a way that is similar to other like professions. This kind of recognition helps establish clear expectations around training, competencies, and ethical practice, while also strengthening the credibility of peer workforce. I ask you to support House Bill 5480 because expanding access to peer support means expanding access to hope, recovery, and community for thousands of Connecticut residents who are still searching for a path forward. When we invest in peers, we invest in people who turn the recovery into lifeline for others, and that is one of the most powerful tools we have to strengthen our mental health system. Thank you for your time and consideration, and I'll be glad to answer any questions you may have for me.
Yes, thank you, Carl. Good to see you, and thanks for your testimony. Just so with regard to Title 20, I don't know that that's within our, so that each committee has its own cognizance, its own scope. I think that's the public health statutes, and we're happy to have a conversation with that committee about what that looks like, and I understand where you're coming from, but I'm not sure. We'll have to sort of see like if that's something we can take on, because we don't like it when they talk about Medicaid, and we don't like to step on their toes either. So we'll have that conversation and appreciate your other testimony about lived experience. I think that's very important. I see Representative Comey though has a question.
I'm right here. Thank you. Thanks for your work. I think I heard you testify in other places as well, and I've been checking out your website a little bit. My question is, you mentioned that you think it's critical that people with lived experience are recognized with the peer support. I think that, I guess where my mind goes is to, you have families who also have lived experience, right? And they have other things to share with folks. And while they're not specifically maybe in recovery, I'm wondering if you have if your organization works with them and how you would view that.
Well, I mean, I don't want to negate the benefit that family would provide in that. Also, family that has had that type of lived experience with, their family members going through it. But I think that would be something separate, than what a peer professional would be. We continuously have family support groups that are part of our peer services. And I would say that, those could be utilized, or even consider a separate credential for that. But for, the purposes of a peer support professional, in the sense that we're currently performing the work now, I would say that lived experience is very important.
Thank you for expanding on that.
Thank you, Representative. Other comments or questions from members of the committee? Seeing none, thank you for your testimony today.
Thank you, Senator.
Next, we have Carla Torres, followed by Aaron Holder.
Hello, good afternoon. My name is Carla Torres. Honorable Chairs Lesser and Gilchrist and distinguished members of the Human Services Committee. My name is Carla Torres, and I am Senior Human Rights Counsel at the Center for Reproductive Rights. And I'm here to testify in support of House Bill 5483, an act concerning fertility care under the Medicaid program. As part of my organization's mission, we work to ensure that people's reproductive autonomy and rights are protected, such that all people can make decisions about their reproductive life, including if, when, and how they build their family. To make this right real, we believe that all people without discrimination should have meaningful access to fertility healthcare that is available, accessible, acceptable, and of good quality. There are well-documented disparities in access to fertility healthcare in the United States that reveal that people of color, people living with low incomes, people with disabilities, and the LGBTQ community access fertility healthcare at disproportionately low rates. If enacted, House Bill 5483 would help to ensure more equitable access to fertility healthcare under the state's Husky program, which is excluded from the state's current private insurance mandate, and which exclusion has contributed to inequitable access to care among Connecticut residents. Specifically, House Bill 5483 would require Husky to cover 3 rounds of ovulation-enhancing medications, as well as monitoring while on those medications, and standard fertility preservation. This is critical coverage for so many, given that the out-of-pocket costs of fertility healthcare is prohibitively expensive for most individuals and families, making it out of reach for most of us. If enacted, Connecticut will be following a growing trend of states that have amended their Medicaid programs to provide some level of fertility healthcare coverage. According to data from the Movement Advancement Project and Resolve, Medicaid programs in 7 states and the District of Columbia currently provide some level of fertility healthcare coverage. House Bill 5483 then would align Husky's current coverage with what other states and DC have already enacted. Connecticut has a real opportunity with this bill to better support its Husky enrollees' access to the care that they need to build the families that they want, to embrace the evolving landscape of family formation, and thereby to better reflect the diversity of Connecticut's residents. The Center emphatically encourages the committee to report House Bill 5483 out with a favorable recommendation. Thank you so much for the opportunity to testify today.
Thank you for your testimony, and really appreciate your thoughtful comments. We've supported this legislation or versions of it in previous years and haven't been successful at getting it enacted into law. And I don't want to speak for all of the barriers that we've come across, but one of the issues is simply the cost. And I note, which, I will note, and I think your testimony reflects that we currently have a fertility coverage requirement for folks with private health insurance, but we don't have that for folks who have Husky Medicaid. And there's that inequity sort of baked into our state laws. But with regard to the cost, the Department of Social Services ran some numbers there. They are sort of threatening, they're saying that there's a threat about potentially losing our federal match for fertility care. I'm not sure what reason they have for being concerned about that particular issue. My understanding is that there is a 90% match in many cases, although some of the services for prenatal, postnatal, and delivery costs would be 50%. But for infertility services, it should be a 90% match. And yet their testimony, if I'm reading this correct, suggests that that alone would cost up to $28 million in state fiscal year 2029. I don't know if you've had a chance to look at those figures, if they seem truthy to you, because, would love to figure out a way to do this, but that is a lot of money.
Yeah, I agree. And I also am concerned about what all they have taken into account to calculate those potential numbers if and when Medicaid does provide this limited coverage to fertility healthcare. I am curious if whether they're taking into account the cost of prenatal care or the cost of healthcare to infants or newborns in thinking about the full cost of the fertility healthcare that we are advocating for in this bill, which, as I mentioned, is limited to the ovulation-enhancing medications and monitoring while taking those medications, as well as standard fertility preservation. And I will also note that other states and the District of Columbia, which have enacted, again, not full IVF coverage, but limited fertility healthcare coverage in their jurisdictions, likely have seen not such a substantial growth in their costs under Medicaid. Although some of these mandates are relatively new, it's a growing trend. So, for example, New York in 2024, DC more recently. So, I think calculations are still being, or, actuals are still being reported.
As I look at their testimony, it looks like they are factoring in just the cost of having more children in the state, and the children will be on Medicaid. That seems a little, they may be slicing the bologna a little thin there, but let's like that. They don't really break down exactly how they get to that, but I'm wondering if how much of that they're contributing, because
I will,
yeah. Go
if
ahead.
you will allow me, I just will say that as someone who has used IVF to grow their family, IVF is very much a numbers game. Fertility healthcare is a numbers game, and not everyone who has access to even limited coverage for fertility healthcare will have the child that they so wish to have. And so I think assuming that access to fertility healthcare then leads to a live birth, I think is I don't know if that's what they did, but if that is the assumption, I think that is misplaced.
Got it. Other questions from members of the committee? Seeing none, thank you for your testimony today.
Thank you.
Next, we have Aaron Holder, followed by Jennifer Gaines.
Madam and Mr. Chair and members of the committee, I am Aaron Holder, the Director of Quality, Infection Control, Education, and Information Systems for the Connecticut Hospice. I reside in Wallingford, Connecticut. I am in emphatic support of Bill 5481, and I'm here today to help you understand why. Death can bring peace and closure, but the first step to a good death is having the right systems in place. When I was a home hospice nurse, I regularly had families with multiple loved ones on service. When one spouse falls ill, it's common for the other two as well. I reconcile this by knowing that there's beauty in death and remaining with the person you chose to spend your life with. The story is no different. One spouse fell ill and was ready for hospice, and the other decided that they had no intentions of continuing life without the person they loved so deeply. So they too forewent their treatment and decided that they would pass in the most profound romantic gesture, truly signifying that they simply could not live without the other. And while this is a beautiful love story, this is also a tragedy. These two individuals had only one child to care for them, and throughout their hospice course, both patients began to have terminal agitation. Terminal agitation is where a patient can become aggressive, restless, and often attempts to get out of bed, making for an unsafe situation. The caveat was that each individual patient was responding to the therapies as prescribed. Because these patients could technically be managed with oral medications if they were given around the clock, neither patient individually qualified for general inpatient hospice care. They were consistently told to hold out. If they just get a little sicker, they will qualify. But instead, the family struggled and fought and cried and begged for this to be over. When the day finally came, when the couple finally felt peace, suddenly there was silence. And that silence was flooded with guilt, second guessing, and pleas with a higher power to bring them back so they'd have just a few more moments. What this bill is proposing is for families to have more moments of being a child instead of a caretaker, with expert nurses and physicians tending to these symptoms. More moments of reflection, quality time, and education on what is happening with the support of our interdisciplinary team day and night. Fewer moments of guilt, regret, and resentment with professional shoulders to lean on. Fewer moments of wishing for this to be over, and more moments of being grateful for the time they had. Death is almost always sad, but it does not need to be traumatic, and that's what we do here best at the Connecticut Hospice. We take the trauma away and let our patients and families just be as they are instead of becoming someone they regret. Thank you.
Thank you for your testimony. I think Representative Comey may have a question for you.
Thank you so much for coming out today and joining us, Aaron. I don't necessarily have a question, but I do want to thank you for that sort of poetic presentation of the work that you do. And thank you for continuing to care about not only the patients that are in their last days, but also their family members.
Thank you. It's an honor and a privilege.
Wonderful. Thank you. Thank you, Mr. Chair.
Thank you, Representative Comey. Other comments or questions from members of the committee? Representative Hughes.
Thank you, Mr. Chair. And I want to also echo, having just recently firsthand experienced the professionalism and expertise and absolute necessity care of hospice care for my mother, as we were able to indeed be the family members and not be the direct caregivers during this essential time. So I just wanted to echo my colleagues that your testimony really elevates how essential hospice care is and what it is and what it isn't. And I just wish more families like mine also took it, took advantage or, got hospice care sooner, so that they could have the kinds of peace that you describe.
I'm so sorry for your recent loss, and thank you for your comments.
Thank you, Representative Hughes, as we all are. Want to check any other comments or questions from members of the committee? If not, thank you for your testimony today.
I appreciate it. Thank
Really
you.
appreciate it. Next, we have Jennifer Gaines, followed by Quinn Giannetti.
Can you hear me?
We sure can.
Oh, perfect. Okay. Well, good afternoon, Senator Lesser, Representative Gilchrist, and honorable members of the Human Services Committee. My name is Jennifer Gaines, and I am here today in my own capacity as a mother to express strong support for House Bill 5486, an act concerning a diaper partnership grant program. The opinions I express today are my own. And I was born and raised here in Connecticut. I'm a mother of 3 young boys and a former colleague at the National Diaper Bank Network. I have seen firsthand how essential access to diapers and necessities are for families across Connecticut. For nearly 5 years, I served as the National Program Director and Manager of National Engagement at the National Diaper Bank Network and the Alliance for Period Supplies, advocating for families and partnering with hundreds of community organizations across the country, ensuring their families have access to the necessities they need, such as period products and diapers for their babies. At the same time, I was also raising my own family. And when I began this work, my youngest children were 3 and 2 years old. By the time I transitioned last year, I had welcomed my 3rd child. Today, they are 8, 6, and 22 months old. And for nearly 9 years, I've been buying diapers, changing diapers, potty training, and doing everything parents do. And during this time, the cost of diapers has climbed dramatically. We've lived through a pandemic, supply shortages, economic strain, and a moment when families are simply overwhelmed by the cost of living. My family was fortunate we could keep up, but many families in Connecticut cannot. And no parent should have to choose between buying diapers and paying for food or rent. According to the National Diaper Bank Network, Connecticut is home to more than 100,000 children under the age of 3. And 29% of them live in families below 200% of the federal poverty level. And this is simply unacceptable. Imagine a mother doing everything that she can do to raise her children, but day after day listening to the cries of a baby who needs a clean diaper she cannot afford. This is the reality for nearly 1 in 2 US families with young children. And Connecticut has the power to change that. The data is clear, and without clean diapers, babies are exposed to potential health risks. Mothers are at risk for increased maternal depression. Parents are unable to send their children to daycare, which most of the time require daily supply of diapers, and parents often have to miss out of work because of it. Our community partners and nonprofits in Connecticut are already shouldering a lot of this work, but they cannot do it alone and continue meeting the rising need of families without meaningful support. By passing this bill, Connecticut can lead the nation in showing that when we ensure babies have access to the basics that they require, we strengthen families, communities, and future workforce. So I urge you today to support House Bill 5486 and help every child in Connecticut the healthy start they deserve. So thank you for your time and your commitment to Connecticut's families. Thank you.
Thank you so much for your testimony. I have recent experience as of last night with the price of diapers, so very familiar. Would love to ask the members if they have any questions or comments. Seeing none, thank you for your testimony this afternoon.
Thank you.
Next, Quinn Janetti, followed by Tracy Wodak. Okay, no Quinn. Is Tracy with us? Yes, Tracy, there you are. After Tracy, Doug Shaw.
Good afternoon, Senator Lesser and distinguished members of the Human Services Committee. My name is Tracy Wodak, President and CEO of the Connecticut Association for Healthcare at Home. I'm also a registered nurse with more than 40 years experience. Our association is the united voice for our state's licensed home health and hospice agencies, as well as several homemaker companion agencies. Our members deliver high quality, cost-effective care to Connecticut residents in the setting they overwhelmingly prefer, their own homes. There are 4 bills before you today that impact our provider members, and more importantly, the individuals and the families that they serve in the community. First, SB 433, an act expanding long-term care options. I assumed the proposal looked to align with the governor's plan to sunset community first choice and transition Medicaid beneficiaries into more agency-based care. However, Commissioner Barton Reeves' testimony doesn't seem to support that thought. Yet, given the current wait lists, the need to expand existing waivers and possibly create new ones, the concept of this bill makes sense. However, any expansion must be paired with adequate funding to support the capacity of agency-based providers. While there is evidence that agency-based care can be more cost-effective for the state than self-directed models under CFC, those savings are in part driven by the severe underfunding of our agency-based services. Second, HB 5484, an act expanding transportation options for home care clients, proposes a creative approach to addressing non-emergency transportation needs by allowing homemaker companion agency staff to be reimbursed for their time, mileage, and the wear and tear on their personal vehicles, and to be able to transport clients while helping to improve access to their essential appointments and services. While we support exploring this concept, we would emphasize that our primary concern remains the need to invest in the underlying Medicaid rates for this provider sector. Third, SB 431 concerning palliative and hospice care in Litchfield County, which proposes a study of hospice and palliative care needs in that region. We appreciate the intent behind this bill. It's important to note that at least 5 licensed hospice agencies already serve Litchfield County. We are not aware of gaps in care in that county, and hospice utilization for that county is just above the national percentage. However, we understand the interest may be around the exploration of a facility-based hospice residence, a home-like setting for individuals who cannot remain at home but do not wish to spend their final days in a nursing home. Connecticut does have several models for this type of care. Perhaps it makes sense to explore those models to see if one of those might be a good fit for Litchfield County, and we are happy to partner in that. Finally, HB 5481. I know you're hearing from a lot of people about it. We support this model. You've already heard many of the statements and reasons. The routine level of care does not have a room and board. It does have a room and board in nursing homes. So I do hope that we can do a parity and alignment of those. So I'll answer any questions if you have them to avoid going too far over time.
You were just a half second over, so we're good. Any comments or questions, Representative Comey?
Thank you, Tracy, for your advocacy on behalf of the industry. Can you talk about, if you know anything about the way that private equity is has moved into the field, the hospice field?
The hospice field, we don't have too much private equity in the state of Connecticut. I have worked with a couple of our agencies coming into the state, but really there isn't too much going on right now.
In Connecticut, but perhaps other
Connecticut.
parts of
There are
the country.
certainly in other parts of the country.
Okay.
Our state regulatory and licensure set up restrictions to some degree do help keep things under control in how detailed they are in the oversight and reviewing of applications and how they would license someone.
Sure. Anything else you want to say about that bill that kind of got cut off?
Yeah, I would love to. I mean, Sylvia really is the expert in that area. And I do feel strongly that we have 3 great inpatient facilities in the state of Connecticut, but I've talked to all 3 of them, and they all struggle with that patient that vacillates between qualifying for routine level of care and occasionally the general inpatient level of care. The routine is $220 a day, and that has to cover everything: your medications, your supplies, your durable medical equipment, your care. So all of that does not cover a bed in an inpatient hospice facility. So being able to get room and board through Medicaid would be very helpful.
And right now, it seems that the hospice organizations themselves are covering that.
For
or
Medicaid,
having-
yes.
Yeah.
For the Medicaid, they're
Covering that
absolutely
cost.
covering. For people that are private pay,
Yeah.
they try to collect a room and board.
Thank
for
you
that.
so much. Thanks, Tracy.
Thank you, Representative. Other comments or questions? I would just with regard, I appreciate your suggestion about hospice care in Litchfield County. There are some folks in this building from that area, and it might make sense for you to sit down with them as well to have that conversation to see if that addresses their concerns. Not being a Litchfield County resident myself, I will refrain from opining on the needs in that area.
Thank you.
Any other comments or questions? Seeing none, thank you for being here this afternoon. Next, we have Doug Shaw, followed by Sandra Roberts.
Madam Chair, Mr. Chairman, and distinguished members of the committee. My name is Doug Shaw. I'm the Chief Development Officer at the Connecticut Hospice. And I'm here today in support of HB 5481, an act concerning medical assistance for patients receiving hospice care at a short-term hospice specialty hospital or hospice facility. Each time I visit this facility, I'm struck by its beauty, and I always appreciate the opportunity to be here. I would like to begin by thanking Representative Comey, Senator Cohen, and my Minority Leader Candelora for their support and guidance in helping bring this proposal forward. I've worked in the nonprofit sector for 25 years, and I have often come here before the legislative body for advocacy or to attend a bond commission meeting in pursuit of funding. Today, however, I'm especially proud to be here in support of this bill because we seek a meaningful partnership with the state of Connecticut. Our proposal addresses several important challenges facing our healthcare system. It helps reduce the emergency department bottleneck we see across Connecticut. It decreases hospital readmissions from skilled nursing facilities and supports more patients and families during some of their most difficult moments of their lives. Importantly, it also offers an opportunity to save money within the state budget while reducing overall healthcare costs for Connecticut taxpayers. Our CEO has already provided additional detail on the proposal, and I stand with my colleagues whose powerful personal experiences, one has been shared, you're going to hear a few more, and also through written testimony, demonstrate the meaningful impact this legislation will have. I thank you for your willingness to serve the residents of Connecticut. Advancing this bill out of committee will allow us to continue an important conversation about improving care for patients and families while responsibly managing state healthcare costs and providing a savings in the state budget. I hope for your support, and we welcome the opportunity to discuss this proposal further.
Thank you for your testimony and your advocacy. Representative Comey and many others in this building are pushing for to work with Connecticut Hospice and pushing support for the bill. So we really appreciate your testimony. And any thoughts or comments or questions from members of the committee? Representative Comey.
I just want to say thank you, Doug. Thanks for your continued advocacy on this issue, and we'll keep working with leadership in the governor's office to get him out there to check out what you guys are doing. Because as you mentioned, it is a beautiful location and very peaceful, needed at that important time of someone's life. Thank you.
Thank you, Representative, and thank you, Senator, for your comment.
Thank you. Other comments, questions, members of the committee? Seeing none, thanks for being here this afternoon. Next, we have Senator Roberts, followed by Gretchen Knopf.
Good afternoon, Senator Lesser and other honorable members of the Human Services Committee. Can you hear me okay?
We can hear you great.
Okay, great. My name is Sandra Roberts, and I am here today to testify in support of HB 5485, SB 430, and SB 433. In regards to HB 5485, not concerning supported decision-making, I want to mention many years I was an advocate at the Center for Disability Rights, and many of the consumers I worked with were conserved by the probate court. Unfortunately, many times when they were conserved, they were assigned to an attorney who maybe they might see once or twice a year briefly, or right before a potential probate hearing. And many times the attorney was not involved in their day-to-day life, and the goals of the consumer might be different than what the goals of the attorney was. So I really want to speak in support of this bill because I think it's so critical that people will be able to have people involved in their lives who know them well and can be of support to them in decisions they make in their life. And I just want to refer back to something Carolyn Newcomb said, and I started thinking about myself when she mentioned having her PCA on her bank account. And I have done similar things. I mean, thankfully, nothing had happened to my account. But I started thinking about, geez, what if something were to happen or I make a poor decision and a person's on my bank account then ends up, unfortunately taking money from me. So I really think it's critical that we have the supported decision-making bill for people with disabilities. In regards to SB 430, codifying the Americans with Disabilities Act, I realized that most of the Americans with Disabilities Act matches what Connecticut has passed as far as their own accessibility laws. But one thing Connecticut does not include is the integration mandate, which, if this is passed, might actually support keeping community first choice. Because it's going to require DSS to make sure clients are living in the most integrated setting. So obviously I would be in support of that. In regards to SB 433, I enact expanding the long-term care options. Again, I believe this bill, if it's passed, would support the community first choice remaining in the budget, because this is, again, has to provide opportunities for people with disabilities to be able to live an integrated life. So I thank you very much for your time today and for listening to me. Thank you.
Thank you for your testimony, and appreciate your thoughts about the intersection of those different issues that are before us. Other questions or comments from members of the committee? Seeing none, thank you for being here today.
Thank you.
Next, we have Gretchen Knopf, followed by Lisa Tepper Bates.
Good afternoon, Senator Lesser and distinguished members of the Human Services Committee. Thank you so much for the opportunity to testify on House Bill 5485, an act concerning supported decision-making. The Supported Decision-Making Coalition has been working for many years to get legislation that formally brings supported decision-making to Connecticut. We thank the committee for recognizing the importance of SDM for older people and people with disabilities.
Okay, my name is Lisa Knopf, and this is my sister, Gretchen, and one of my supporters, Gretchen Knopf. We urge you to support HB 5485. Older people and people with disabilities should have the same opportunity to make decisions with support, which I have all my adult life.
So supported decision-making is an alternative to guardianship and conservatorship that allows older people and people with disabilities to maintain their civil right to make decisions with the assistance of one or more supporters. Research shows that many, if not most people with disabilities, even those with the most significant disabilities, can use SDM to make at least some decisions. Using SDM, decision makers have supporters assist them with gathering and providing information to help the decision maker understand the pros and cons and consequences of decisions. Isn't this what we all do when we ask for input from others before we make a major purchase or make decisions about healthcare or other aspects of our lives? I know I do. So SDM would give people with disabilities and older adults the same opportunity. Before we continue, I want to be clear that supported decision-making does not eliminate guardianship or conservatorship. It is an alternative. It is an option, just as guardianship and conservatorship are options. Shouldn't families, older adults, and people with disabilities have SDM as a choice? Other testimony submitted for the public hearing is going to give you details about the coalition and the importance of HB 5485. And the fact that SDM is now in at least 29 states and the District of Columbia. However, Lisa and I wanted to talk to you about the role SDM has played in our family for more than 40 years. Our family has informally used SDM even before somebody named it. My parents believed in instilling independence for all of us, including Lisa, who just happens to have an intellectual disability. So Lisa is now 60 plus years old, and until she became an adult, always lived with the family despite low expectations of the experts who told my parents to institutionalize her. As siblings, Lisa, our brother, Robert, and I all played together, did chores together, and went to school together, making choices, learning things, making decisions. Lisa is going to give you a few details about her life now, a life that has been enhanced by high expectations and the opportunity to make her own choices.
Please summarize.
Oh boy, go ahead, Lisa. Okay, Lisa, I live on my own, cook for myself, and do my own laundry. I love UConn basketball and the New York Mets, Brad Paisley, and Bruce Springsteen. I belong to self-advocacy groups and have friends at my condo and on Zoom. I do my own grocery shopping, take trips to the pharmacy, walk to the post office to mail letters, get takeout from local restaurants, and visit Dairy Queen.
Do you want us to summarize, unfortunately? Okay. This testimony is in writing, in the written testimony, so you can see examples of how Lisa has used supported decision-making. I just want to clarify that we have worked with the probate court on supported decision making, and we met with them about this bill. They explicitly told us that there was actually no reason for them to be involved with this. There wasn't anything in this bill that would involve them needing to see it or any interaction with the probate court. So we wanted to make sure that was there. And then also I wanted to let you know that I submitted information on Senate Bill 430 testimony and codifying the ADA, because I think it's critically important for Connecticut to do that in this climate. So thank you very much.
Thank you.
Thank you for your testimony, and appreciate it. On both of those issues, those are very important. Other comments or questions from members of the committee? Seeing none, thank you very much to you both. Next, Lisa Tepper Bates, followed by Claire Circus. Is Lisa with us? No, Lisa. Okay, let's go to Claire Circus, followed by Conant Shonley.
Everybody, can you hear me?
Sure can.
Awesome. Well, I'm honored to be here today, Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Claire Circus, and I'm a resident of Farmington. I'm also a fourth-year medical student and will graduate as a physician this May. I am grateful for the opportunity to testify in strong support of both HB 5482 and HB 5483 today. HB 5482 is a critical step in returning reproductive autonomy to patients and honoring the physician-patient relationship. Hormonal prescriptions are used for anything from pregnancy prevention to helping with painful periods and heavy bleeding to alleviating debilitating menopause symptoms. They provide essential health care, and patients deserve unencumbered access to this care. Unfortunately, under current policy, patients are often subjected to unscientific restrictions when filling these medications. Many patients who are prescribed them face 30, 60, or 90-day prescription limits, not for clinical reasons, not for safety reasons, but because insurance companies require it. This results in unnecessary barriers to care, which can often lead to patients not getting the care they need at all. Imagine a mom of 4 living in a rural area, working 2 jobs in addition to being a full-time mom, making 3 extra dedicated trips to refill medication that doesn't even require that level of clinical oversight is next to impossible, and can leave this patient without the medication and coverage she needs, and often does. I've met this patient. Or a college student who does not have a car and could barely coordinate a ride to the clinic to get her first prescription, let alone figure out a way to refill it 11 more times that year. I was this patient. There's no clinical reason why every patient on contraceptive should be limited to month-by-month prescriptions. If more regular check-ins are warranted, then a physician and their patient can make that determination together. As it stands, these requirements are nothing more than an unscientific insurance restriction and leads to delays, mismedication, and prohibitive barriers for patients. Data also supports ensuring patients are not subjected to these restrictive contraceptive prescription limits. Randomized control trials, the highest standard of evidence when forming clinical guidelines, have shown that longer windows for birth control prescription refills significantly improve adherence. In addition, governing medical bodies such as the American College of Obstetricians and Gynecologists recommend a 13-month supply of contraceptives. This law would make life easier for patients and would make it easier for physicians to care for their patients. I would also like to express my strong support for HB 5483, which would expand fertility coverage to those in our state on Husky insurance. Simply put, everyone deserves reproductive justice, which includes the right to bodily autonomy, the right not to have children, but also the right to have children and raise those children in safe and sustainable communities. Fertility care represents an extraordinary advancement in medicine and science, giving people the opportunity to build a family who may not otherwise be able to do so. Denying access to fertility care to those on Medicaid, as our current state law does, disproportionately excludes low-income Black and Hispanic residents from this opportunity. Everyone deserves a chance to build a family if they wish to, when they wish to, and this bill would be an important step towards ensuring that's a reality for the residents of our state. Thank you so much, and in conclusion, I strongly urge you to vote favorably for both HB 5482 and HB 5483. Thanks so much.
Great. Thank you for your testimony. Questions or comments from members of the committee? Yes, Representative D'Amico.
Thank you, Mr. Chair. Thank you, Claire, for coming to testify, as you have done on several occasions in front of the Public Health Committee, and now you're here in front of the Human Services Committee. So I was just wondering if you would like to expand on some of the examples that you gave of people not being able to get adequate access on the two bills that you were referring to. Would you care to share a couple more stories or expand on your testimony a little bit?
Yeah, definitely. And thanks for the opportunity to do so. So the examples I used were just two of many. You know, I worked as a medical assistant in a sexual and reproductive health clinic before medical school, and I'm on my 4th and final year of medical school. So I've seen a bunch of patients over many different, years and experiences. But the example that I used was, a patient that had compounding barriers, right? She was from a more rural area, less access to care where she lived. She had an enormous amount of family requirements, an enormous amount of work requirements as well. But, there's layers of different prohibitive barriers for patients. I have another patient that comes to mind who lived in the town over from the clinic that we worked, but didn't have a car and took the bus to work, and worked during the hours that she worked were mostly hours that her pharmacy was open. So that patient as well, had, readily was in the same town as her pharmacy and, was close to the clinic, but still had barriers to accessing care due to her work schedule and due to transportation issues. And so, there's many compounding factors here that can cause patients to not be able to fill prescriptions. And I can't even begin to describe how common it is for patients, especially on contraceptive medications, to not be able to pick something up, which decreases adherence and thus decreases the effectiveness of the medication. So yeah, that's just one of many examples, and happy to expand on that more if anybody would like to hear.
Thank you, Claire, and thank you, Mr. Chair.
Thank you, Representative. Other comments or questions from members of the committee? Seeing none, thank you for your testimony.
Thank you.
Next, we have Conant Shonley, followed by Anna Allen.
Good afternoon, distinguished representatives. My name is Conant Shonley, and I am the president of Charter Oak Home Care, which has provided home care services to Connecticut seniors for over 41 years. I am testifying in support of HB 5484, an act expanding transportation options for home care clients. A large number of the clients that we serve are Medicaid recipients who live in the remote northwest corner of Connecticut, where transportation services are sparse, to put it mildly. For years, our caregivers have transported their Medicaid clients to medical appointments out of the goodness of their hearts, although the state does not provide reimbursement for their travel. As gas prices have risen along with the cost to maintain their cars, our caregivers are caught in the difficult predicament of wanting to drive their clients to doctor's appointments while incurring significant financial expense. We have seen the number of caregivers willing to drive Medicaid clients decline significantly over the last several years. Many will say that caregivers should just help their clients organize transportation from services that are currently paid for by the state. And this is really unrealistic for several reasons. Many transportation services require significant advance notice for appointments in remote regions and are often inflexible if travel plans need to be changed at the last minute. And because our caregivers are with the clients multiple times each week, sometimes almost every day, they can quickly accommodate those scheduled changes. Also, the majority of transportation options do not provide seniors assistance getting into and out of the cars. And that is what our caregivers help do. And then finally, our clients already know and trust their caregivers. who they're spending hours with each day in many cases, and they would feel much more comfortable with someone that they know accompanying them to their appointment. Our request is simple. It's just a fair reimbursement rate for our caregivers driving Medicaid clients to medical appointments. This will enable the seniors that we work with to receive the medical care they need with the caregivers they already know and trust. And I also just want to say a special thank you to Representative Case for being an advocate on this particular bill. Thank you.
Thank you for your testimony. I think Representative Case has a question for you. Representative Case.
Thank you, and thank you, Mr. Chair. Thank you, Conant, for coming forward. Couple things this cycle here. There's a few bills here for the Northwest corner for Litchfield County, and I think what impacts yours the most, or the bill that we have here today, is we're about 900 square miles in Litchfield County where you don't have transportation. We don't have. You got to go to a doctor's appointment, and it's quite a ride. What makes you understand that the clients really want this and want to be able to have their caregivers bring them to their appointments? Because I don't find it realistic to call out to our non-emergency medical transportation. Number one, it's hard to get rides because of the remote area we are in. And it's just easier to flow the way that we're trying to do through this bill.
Yes, no, that's a great question. And it's coming directly from our caregivers. So our caregivers are telling us, our clients are asking us to provide them transportation to their doctor's appointments. They're asking us this, and we would love to be doing it. It's just we can't do it because there's a cost to gas, there's wear and tear on their car. And these requests have only increased over the years. And it's so easy for the caregivers that are spending hours each day with their clients to say, okay, I'm happy to take you to your doctor's appointment because they're there with them. It's just something that really makes sense and is common sense. And the caregivers have been telling us this, and I believe that you have even heard it from the caregivers. This is something that they have brought up to us as an agency, saying, hey, we would love to be paid for the transportation that we're providing to these clients that need to get to the doctor.
So thank you, and thank you for coming forward. I think we'll keep working on this. What we have to understand is Northwest Corner is a little bit challenging at times when transportation stops at the municipal level of Torrington, and you go 900 square miles around that corner of the state, and there's no transportation. So we need to work to help people get to their appointments back and forth. We've had a lot of ideas over the years come up, and we need to pin something down to make it happen. So I thank you for coming forward. Thank you, Mr. Chair.
Thank you, Representative Case, for your question. Other comments or questions from members of the committee? Seeing none, thank you very much. Next, we have Anna Allen, followed by Jean Mills Arana. Is Anna with us?
Yes.
She is.
Hi, good afternoon, distinguished members of the Human Services Committee. My name is Anna Allen, and I am the Executive Director of the Keep the Promise Coalition. We are a coalition focused on platforming the voices of those with lived experience in mental health conditions, disabilities, and more. I'm testifying on HB 5480, HB 5485, and SB 430. When we talk about peer support services under Medicaid, we really want to push for the sustainable and livable wage reimbursements of peer support specialists, just to prevent burnout, but also to ensure that the work that we're doing, the work that folks are doing, is adequately compensated. I also really want to stress the definition of peer in the bill. We definitely want to look for language amended. People can support in many different ways, and we notice that in in peer support work, folks do support in many different ways. As a representative had mentioned, we have family members, we have so many different folks from all different walks of caregiving who have shown up for individuals in recovery. However, it's important that we understand that there is an imperative distinguishment between a peer support person with direct experience and a peer support person who has caregived. People can support in different ways, and they can support in the capacities that they've lived. In this way, we adequately match people with their peers who understand their situation and can effectively help improve their quality of life through engaging in self-advocacy, recovery, and leading a positive autonomous healthcare journey. Of course, family members and workers with experience in caregiving should be recognized for their ability and huge contributions. However, when we discuss the peer support position, we really want to emphasize that it has been proven in Connecticut time and time again through the work of peer support workers that individuals in recovery need peers that have lived experience in their direct or similar situations. When discussing House Bill 5485 in regards to supported decision making, it's important that we push for less restrictive protections of autonomy, allowing for folks with disabilities to retain their legal rights. We also recognize that autonomy is so important in all these discussions that we're having. I've seen in my own position here as executive director that in many cases it's damaging to both youth and to older folks. That for youth, they haven't received the type of independence they needed through supported decision making. And so then we see older folks who are suffering from the overpowering guardianship.
Please summarize.
Yes, especially in those living with mental health conditions because there was no early intervention. So I do also want to recognize my support for codifying the Americans with Disabilities Act as we see there's less federal support and that we need all the help that we can get from Connecticut as we have seen you support us in the past. So thank you so much for your time today.
Well, we try. Thank you very much for your testimony. Other comments or questions from members of the committee? Seeing none, thank you for your work and the work of your organization. Next, we have Jean Mills Aranja, followed by Chaplain Rich Miller Murphy.
Thank you. My name is Jean Mills Aranja, and I'm an elder law attorney with Connecticut Legal Services. I currently serve on the boards of the Southwestern Area on Agency and ARI of Connecticut, a nonprofit agency serving people with disabilities. I submit this testimony on behalf of Connecticut's 3 legal aid programs and our low-income disabled and elderly adults. I'd like you to think about how you make decisions in important matters. Most people think about the issue, gather information, talk to others who may be knowledgeable, and then proceed to decide what they think is best. Supported decision-making, SDM, is simply a formal way for adults with disabilities to get the help they need from people they trust and choose. We are often too quick to take away the rights of people who have some level of disability. Yet they usually know best what their lives are like and what effects their choices are likely to have upon them. Often when someone appears to need help making decisions, a conservator is sought in the probate court. But an involuntary conservatorship under Connecticut law requires the person needing assistance must be found to be incapable. And for a young person not yet 18, parents can request this determination to be made in advance of the person's 18th birthday, before they even have a chance to make a single adult decision. SDM changes this constrictive landscape and allows an adult to maintain his or her own civil rights by creating a document in which he or she names the people whom the adult feels will be helpful and reliable in making decisions. These considered choices can then be communicated with assistance as needed to others, including healthcare providers, government agencies, housing providers, and financial institutions. The probate court is not involved, and the process is relatively simple. This proposed statute will put Connecticut in the company of a majority of states which already have some form of SDM, including New York, Rhode Island, and New Hampshire. Other states, including New Hampshire, Maine, and Pennsylvania, actually require that courts imposing conservatorships or guardianships consider whether there is a less alternative means than a conservatorship or conservatorship, such as SDM, before they may appoint a more restrictive assistance. I was excited to see that on February 9th, 2026, the American Bar Association got on board and amended its model rule of professional conduct for representing what used to be called clients with diminished capacity and now is renamed clients with decision-making limitations, to recognize SDM as an accommodation that can eliminate or alleviate concerns about a client's capacity to make legal decisions. The revised rule also recognizes affirmatively that the clients with disabilities are capable of making legal decisions. HB 5485 is an excellent proposal which allows many Connecticut residents to maintain dignity, control, and autonomy over their own lives, and we strongly support its passage. We do suggest that there be a clear mechanism for revocation of the appointment of a supporter, and we attach proposed language to accomplish this. I'd also like to express our support.
Summarize. Thank you.
Okay, we support Senate Bill 430, especially because of its integration mandate, and we support 433, an act expanding long-term care options. But I found it quite disturbing that when the commissioner commented on this, she didn't even mention the fact that community first choice, which has long been lauded as an important program for expanding long-term care options, has been completely removed in the current state budget, and we're definitely not in favor of that. I've supported written testimony, and I thank you for your time and attention to improving the lives of people with disabilities.
Thank you so much for your testimony on all of those issues. Just with regard, we've had a number of folks mention sort of in passing the integration mandate in the Americans with Disabilities Act. Trying to understand, because obviously, you know, we're codifying some federal law here, and there are places where federal law differs from state non-discrimination law, and we're trying to understand what this would mean and how to how CHRO might enforce it. Can you just talk a little bit more about what the integration mandate is, how it works, and you know, specific, you know, I think we're trying to understand what the substantive import of this
right. The integration mandate expressly bans the unnecessary segregation of people with disabilities, so that state and local governments that provide services to people with disabilities must offer these services in people's homes and communities, not just in institutions. And it's a key civil rights requirement aimed at ending the isolation and segregation of people with disabilities. And Connecticut's Disabilities Act doesn't contain that specific language. So I think that's why people keep mentioning it, because that's a very important piece of the Americans with Disabilities Act, which, by the way, is not really being enforced currently in the present administration.
Thank you. That's actually super helpful. Other questions or comments from members of the committee? Seeing none, thank you for your work and for your testimony this afternoon.
Thank you.
Next, we have Rich Miller Murphy, chaplain from Yale New Haven Health.
Hi, my name is Richard Miller Murphy. I'm pleased to have the honor of addressing the esteemed members of the Committee on Human Services and all of you present here today. Thank you to Senator Harding of the 30th District for his leadership and support of this bill. This topic, this end-of-life topic, is of special interest to me, as my 84-year-old mother died in hospice in 2020. My 91-year-old father died in hospice of January 27th of this year. My entire life and career focus has been healthcare. I started as an orderly at age 18, and currently I'm employed by the Yale New Haven Health System in the Spiritual Care and Education Department at Bridgeport Hospital as a staff chaplain. I also work as a part-time hospice chaplain closer to home with Visiting Nurse and Hospice of Litchfield County. The views expressed in this testimony are my own. This bill, SB 431, which I fully and completely support, is all about humans, all about us. all about being prepared to meet the end-of-life needs of our loved ones. We must be prepared for the demands that will be placed on our healthcare system over the next 10 to 15 years as the population ages at what has been called and very likely will be one of the fastest times of aging in our country's history. Litchfield County has 32% of its 185,000 residents over age 60 and 21.9% of its residents are over age 65, the largest among all 8 counties in Connecticut. They will need, and they do deserve, the best end-of-life options that can be offered in both palliative and hospice care. Currently, there is no residential hospice care facility in Litchfield County. End of life has many challenges for all of us. When we reach this phase of our own lives or accompany our loved ones there, we don't know what choices we should make that will result in the best end of life quality of life. People are confused at the very time when they actually need the services most, when they need this care. Often they're just plainly overwhelmed. We can do better to address their needs, but to do that, we must provide meaningful, community-based, community-engaged education on these very difficult to talk about options. This very focus on community-based education is what I hope and trust the bill will and should address by our very capable commissioners of social services and public health. End-of-life care that we will all face at some point in our lives. Maybe you faced it with your own parents or grandparents or even someone closer to you, a son, daughter, or a close friend. Do you remember? Did you feel anxious, lost, unsure if your decisions were the right decisions? Let's all please plan hospice educational programs now and access to all levels of hospice care through passage of SB 431. Thank you for this opportunity. It's an honor to work with patients and families to provide peace for all at end of life. I'm honored to offer my experience, thoughts, suggestions, and ideas to the committee if requested at any time or place to benefit all seeking the best end of life options for themselves or their loved ones. Thank you.
Thank you for your testimony. I was not sure how whether you've been in the hearing room all day or not. There have been some suggestions from different folks about how to approach this bill. One suggestion, for example, was from an advocate from the home care industry. Obviously, that's an alternative to a facility-based hospice facility. So I didn't know if you'd have the opportunity to hear those other voices and if you had any opinions on the suggestions that have been brought forward.
Sure, I did hear the opinions of the home care industry. I think the word partnership is the most important word that I've heard. I believe that education so that people understand the facts and myths associated with hospice are primary, the first step. The people who are faced with these challenges don't want to travel with their families. You heard from Representative Case how rural Litchfield County is with 900 square miles. So the people who are faced with more than just home care options or hospice at home, if they go to the next level, they really don't have any choices. We've also heard about the cost. Certainly, anything that can make the cost system work better for existing or future inpatient or residential hospice facilities should be explored more optimally.
Thank you. Thank you for your suggestion. Sorry for your own personal loss, but I appreciate you sharing your story and your work. Are there comments or questions from members of the committee? Seeing none, thank you. Next, we have Selena Ose from followed by Tanisha Noreen. And a blanket apology to anybody if I'm mingling your name.
No, that was perfect. Good afternoon. Thank you for the opportunity to testify in support of House Bill 5486, an act concerning a diaper distribution grant program today. My name is Selena Ose, and I'm the Director of Health Equity and Community Engagement at the Connecticut Hospital Association. Connecticut hospitals see firsthand how social and economic factors affect the health of infants and families. CHA supports this bill because it recognizes diaper insecurity as a public health issue that's often overlooked and builds on successful hospital community partnership models already operating in the state. Without adequate diaper supply, we know that the risk for preventable health conditions due to infants potentially being left in soiled diapers longer than needed increases their risk for diaper rash and urinary tract infections. Diaper insecurity is also associated with caregiver stress, maternal depression, and has economic consequences for families. Addressing this need improves the health of the infant, mother, and provides household stability. In 2022, we had the privilege of partnering with the Diaper Bank of Connecticut, hospitals, and their community partners to launch a statewide diaper distribution program called Diaper Connections, which really included hospital screening for diaper need and connecting families to diaper resources through trusted healthcare and community settings. What this bill would do is that it would help expand these efforts and ensure more families receive the support that they need. It will sustain hospital participation, ensure consistent diaper distribution, maintain care coordination pathways that connect families to wraparound services, and support data collection to measure healthcare outcomes and cost avoidance. CHA also supports the bill's reporting requirements, but has made a suggestion for one technical clarification to ensure that any data reported under the program is aggregated and consistent with state and federal privacy laws, including HIPAA. Thank you so much for your time and consideration of my testimony. I'll be happy to answer any questions if you have any.
Thank you for your testimony. Are there questions or comments from members of the committee? Seeing none, thank you very much. Next, we have Tanisha Noreen, followed by Kate Sims.
Good afternoon, Representative Gilchrist, Senator Lesser, and all honorable members of the Human Services Committee. My name is Tanisha Noreen, and I live in New Haven. I am a student at Yale University, where I'm concurrently pursuing 2 bachelor's degrees in political science and history medicine, as well as a master's in public health and health policy. Thank you for the opportunity to testify in support of HB number 5483, an act concerning fertility care under the Medicaid program. This bill provides low-income, infertile Connecticut residents with the opportunity to take back control over their reproduction by removing the financial barrier to fertility care access and increasing utilization of such services. Thousands of Connecticut residents are infertile, which creates immense difficulties for the family planning process. Fertility services can help these residents to overcome these difficulties. However, these services are very costly. On average, one cycle of IVF in Connecticut could cost up to $25,000, and many residents need to complete 2 to 3 cycles to be successful. It is impossible for infertile Connecticut residents on Husky to afford even one round of treatment, which not only prevents them from accessing fertility services, but strips them of their agency over their reproduction. This bill removes this financial barrier, which makes services more accessible for those who need them. Medicaid coverage of fertility care services will lead more patients to utilize these services, not only those from lower income backgrounds, but also those from communities of color. I was raised in Queens, a borough of New York City that's known to be one of the most ethnically diverse places in the world. Black and brown pregnant people, including those from my community, are less likely to seek fertility care services because they may be unable to afford them, which leads to worsened pregnancy outcomes. This intersectionality between socioeconomic status and race is undeniable. Therefore, increasing fertility care access to Medicaid recipients also means increasing access to these services for communities of color. I urge you to vote yes on HB number 5483 because everyone in Connecticut, regardless of their socioeconomic background or racial background, deserves to have access to care and services that can help them to accomplish their family planning goals and also uplift their reproductive rights. Thank you for this opportunity to testify in favor of this bill, and I'm happy to answer any questions you may have.
Thank you so much for your testimony. If I'm reading it correctly, you're pursuing 2 bachelor's degrees and a master's at Yale all at the same time. Is that right?
Yes, sir.
Well, that's intimidating and it's exhausting. Thank you. Thank you for fitting us in your free time. No, but in all seriousness, thank you for your advocacy on this important issue. It's great to hear your voice. Are there questions or comments from members of the committee? Seeing none, thank you very much. Next, we have Kate Sims, followed by Maureen McIntyre.
Good afternoon, Madam Chairperson, Mr. Chairman, and respective members of the committee. Thank you for the opportunity to speak in support of Raise Bill 2615, Testimony 5481. My name is Kate Sims, Chief Operating and Compliance Officer for the Connecticut Hospice. I come before you not as just a healthcare leader, but as someone who is routinely called into some of the most sacred and emotionally charged moments in a family's life. At the Connecticut Hospice, we care for patients where cure is no longer possible and comfort becomes the goal. These are mothers, fathers, spouses, veterans, people who deserve dignity, peace, and expert symptom management in their final days. Yet today in Connecticut, Medicaid and dual eligible patients face a painful gap in access to hospice specialty beds. When there's no safe discharge plan, when a spouse is physically unable to lift or reposition a loved one, when a daughter is terrified she'll give the wrong medication, when there's simply no caregivers at home. That's when I'm called in. By the time I meet the families, they're already grieving, they're exhausted, and they're afraid. And instead of focusing on how to make their loved one comfortable, instead of helping them create meaningful final moments, I'm forced to discuss coverage limitations, placement barriers, financial decisions, and disposition options. Our conversation shifts from how do we ensure a peaceful death to what will Medicaid cover. These decisions are deeply emotional. They determine where someone will spend their last days of life. And this burden extends beyond the family. Nurses, social workers, and physicians experience moral distress knowing the patient's needs exceeds what can be safely managed at home or in a facility. No family should have to make these choices because they cannot provide a safe, appropriate hospice bed. We see this repeatedly among Medicaid and dual eligible patients in hospitals who qualify for hospice but are not yet GIP, individuals waiting for nursing facility placement with pending Title 19, high acuity patients who are medically complex, not rehab eligible, and too fragile for many nursing facilities, and patients held in hospitals simply waiting for placement. These are simply not statistics. These are people with final journey of their life. And too often they're stuck in a hospital filled with alarms, bright lights, and settings designed to save lives, not to gently support the end-of-life journey. This gap does more than creates emotional distress. It contributes to hospital overcrowding, increases avoidable readmissions, it redirects staff time away from the bedside, and it forces families into roles they're just unprepared to do. This bill will restore dignity to patients and peace of mind to families. It will ensure that Medicaid status does not determine whether someone dies safely and/or comfortably. At the end of life, families should be holding hands, not negotiating coverage. They should be focused on love, presence, and comfort, not overwhelmed with placement and funding decisions. I thank you for your time and respectfully urge you to support Raise Bill 2615. Thank you.
Thank you for your testimony this afternoon. I think we've got the entire Connecticut Hospice here, but no, very much appreciate your testimony. Are there comments or questions from members of the committee? Representative Comey.
Thank you very much, Kate. So can you explain to me, you mentioned GIP. Can you just talk to me about how the state could save money by discharging patients who are hospice eligible, but not general inpatient eligible, which I guess is GIP,
Yes, so
from hospitals to hospice facilities?
yes, so the GIP is the general inpatient. That's one of the 4 levels of hospice. So if you are not GIP eligible, you're not accepted into hospice. So often patients are in a hospital acute care bed waiting to be eligible for hospice criteria. And that is the perception of one's assessment, right? Because when a patient comes, and Sylvia alluded to this earlier, out of the 90 patients that we did at routine in our test environment, the average length of stay was 8 days. That means that that patient waited for someone to say, you're GIP eligible, and then they came over to us for 8 days. Where, hospice eligibility is the last 6 months of life. So 8 days to 6 months of life means we are not getting our patients into the care they deserve, the care they need under the Medicare benefit for those 6 months of life. And we're waiting too late, just simply too late, to give the family and the caregivers the peace of mind they need in that final journey of life.
Thank you. Thank you for clarifying that for us
Absolutely.
laymen up here. Appreciate that.
Absolutely.
Thank you. Thank you, Mr. Chair.
Thank you, Representative Comey. Other questions or comments from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have Maureen McIntyre. After Maureen, we're going to go back to Lisa Tepper Bates, who's joined us, I believe.
Good afternoon, Senator Lesser, Representative Gilchrist, and other members of the committee. I am so grateful to be here today. Thank you so much for taking the time. In light of the copious and incredibly moving testimony of many of my colleagues, I will be keeping my remarks today somewhat brief, as I am also here, both as the Chief Operating Officer of the Atwood Dementia Group, but also as a member of the Innovations in Aging and Disability grant received by the Connecticut Council on Developmental Disabilities. I am here also to voice my support for the House Bill 5485, an act concerning supported decision-making, which you have heard incredible testimony this morning, first-hand accounts and personal stories, I might add, that really should rule the day here. So I will not be boring you with the additional facts and figures, because it would be unfortunate to step on the testimony of those who have lived this experience. Let me first, however, go back to something that Representative Hughes correctly identified with respect to the fact that our older adult and individuals with disabilities populations here in Connecticut does continue to increase, and yet their experience with well-being and access to care is far different from the mainstream population. However, there is ample data to support the fact that individuals who utilize supported decision-making principles do report having a higher quality of life and are able to live in the community longer and more successfully. I would also like to offer a couple of, let's say, 2 contextual details or reasons why supported decision-making may be a great call for this particular session. Number 1, this bill does not place additional stress on the state's home and community-based service infrastructure. In fact, it maximizes by leveraging the power of relationships and relying on person-centered care. Number 2, this bill does not pit one constituency group against another. It benefits older adults and individuals with disabilities, but its practice is a framework of tremendous value for all of us, for anyone who expects to be involved and have a say in their future care. And I would like to reiterate one point, because I do think it is important. Number 3, this bill is not without precedent. 29 other states have figured out a way to make this happen, and I believe that 2026, with the wind at our backs, is the time to get this done. It is time for Connecticut to take the reins on this. Again, the wind is at our back and we are poised. I thank this committee so very much. I wish Representative Case was still here to hear me say thank you for the confirmation that you get it. With that, thank you so much for the opportunity to be here and have a wonderful day. Thank you so much.
Thank you, Maureen. Good to see you in this new capacity, and thank you for your testimony. Are there comments or questions from members of the committee? Seeing none, thank you. Good to see you. Next, we have Lisa Tepper Bates, followed by Jonathan Martinez.
Good afternoon, chairs and members of the Human Services Committee. I'm Daniel Fitzmaurice, Director of Advocacy at United Way of Connecticut. With me today is Lisa Tepper Bates, our President and CEO. We're here in support of House Bill 5488, an act establishing a task force to study expanding the 211 Infoline program. We'll briefly summarize what's in our written testimony and look forward to your questions. 211 is a one-stop connection to help. This year marks the 50th year of this critical public-private partnership between United Way and the state of Connecticut. When you call, a trained contact center specialist answers with empathy and understanding and real solutions. They take time to understand your entire situation, connect you to resources you might not have even known to ask for, and make a plan to make sure that nothing stands in your way of accessing them. 211 operates two major service lines. The first is information and referral, which is a basic needs hotline for 23 state and federal benefits and 40,000 community resources across 4,000 partner agencies. The second is the Housing Crisis Hotline, which is the front door to Connecticut's coordinated access networks that helps residents facing homelessness find shelter. With increased financial hardship and growing uncertainty across our communities, demand for 211 is surging. Excluding COVID-19 services, requests have actually increased 300% since 2019. What they need most over and over again is the same: a stable place to live, support for their mental health, and food on the table. I'll turn it over to Lisa to tell you how we're meeting that demand.
Thanks so much. Many of you were generous enough with your time to come visit us at the 211 Contact Center, and we appreciated that. We think you got a great view of our contact center, which is actually one of the leading 211s in the nation. 211s cover about more than 90% of the United States, so a lot of 211 contact centers, and we are really a leader. So I hope you're proud of that, since it is a private-public partnership. But that does require sustained investment. And as you also know, for 15 years, our funding was flat. And that actually meant that even though we have harnessed technology as best we can to be very efficient in our operations, we lost a lot of staffing over that time. Its costs went up and the dollars didn't. So we are really grateful to all of you and to the governor for the additional funding that we did receive through the Emergency Response Fund, and that will allow us to respond to 1,000 additional requests a week. We're really very excited about that, and it's urgent because the need is certainly up. But do just want to flag for you that one-time investment does expire June 30th of 2027. So we're already looking forward in time, and we'll be back here to talk with you about it then. The last point I'll make is that, unfortunately, this funding that we've talked about is for our basic needs hotline. That is a separate operation from the housing crisis line, which is struggling to keep up with demand as homelessness has increased. We'd be glad to answer any questions.
Thank you both for your testimony. It was well-timed, just under the wire. And appreciate the work of United Way in administering the 211 program. I was one of the legislators who had the opportunity to tour the facility in Rocky Hill. Glad to have it in my district, but also was really impressed by the professionalism and the dedication of your staff that make that program work for so many Connecticut residents. Totally hear your comment about 2027. We will continue to work with you going forward, and just appreciate your presence here today. Are there comments or questions from members of the committee?
Thank you.
I would just say I really appreciate your communications with us as legislators. Knowing what's going on in our community is core to what we can do while we're sitting in this seat. So
keep them coming. I read those crazy monthly emails as far as and say, oh my God, my poor people, you know, things are, I am seeing definitely an increase in my community in need. And I appreciate you keeping me alert of it and a task force, well, you know, is one of those things that people are like a dime a dozen sort of things. I think that this could be a real great planning tool for us as we move forward with the increased capabilities of your organization. So thank you so much.
Thank you, Representative. Other comments or questions from members of the committee? Seeing none, have a wonderful afternoon.
Thank you.
Next, Jonathan Martinez, followed by Adam Rendell.
Good afternoon. My name is Jonathan Martinez. I'm the Senior Director for Law and Policy at the Burton Blatt Institute at Syracuse University. I'm here on my own time today, not using federal funds or Syracuse resources, to urge you to pass 5485 on supported decision making. It is rare that a state has an opportunity to say our laws should and can match our values. I was looking at the Department on Disability Services website today, and it extols the virtues of self-determination, having control over your life, making decisions about your life, saying the kind of life you want to live. 5485 provides people with disabilities a vehicle to do exactly that. The opportunity to say, I do control my life, I do make my own decisions, and most importantly, you should respect me when I do. My written testimony I submitted today shows you what others have said, the research showing the real life benefits that come from people who have more self-determination, including study after study showing that people with disabilities who exercise more self-determination, who make more choices and have those choices respected, have improved quality of life, including a better ability to recognize and avoid abuse. And that's where I want to finish today. I know that others may testify that you shouldn't pass this bill because it may subject people with disabilities to undue influence or may put them at risk of abuse or having their bank account information or medical information taken. And to that, I say this. I know of no data showing that. Almost 30 states have passed supported decision-making laws, and I know of no studies indicating that there is a measurable or markable increase in abuse, neglect, or exploitation. And perhaps that's because, as one doctor testified in Kansas, a supported decision-making agreement helps me recognize and stop abuse because I have the names of the people in that person's life. So I know where to start with my questions if I think there might be abuse, neglect, or exploitation. The same is true of a bank teller or an attorney. With a supported decision-making agreement, you know who's involved in that person's life. And therefore, if you suspect abuse, you know who to ask first, or more importantly, to ask the person about. So I'll close today where I began. Connecticut has an opportunity to say today, we want our laws to match our values. We want to give people the chance to do what we say they should, and we want to give them the best opportunity to have the best life. I urge you to pass 5485, and I'm happy to answer any questions.
Yes, thank you so much for your testimony and for freelancing here. I see Representative D'Amico has a question for you.
Thank you, Mr. Chair. Thank you, Jonathan, for coming in and testifying, or I should say for testifying remotely on your own time. Thank you. So I appreciate all the work that you have done over the years on this, and you have educated me quite a bit about the benefits of supported decision-making. But I do have to ask you a couple of questions, only because in looking through some of the testimony that was submitted, most of it is quite positive, but a couple of people raised some questions relative to what you just talked about regarding coercion and exploitation and so forth. So I know 29 other states, or I'm told 29 other states have this model. In those other states, I guess you just mentioned that you don't know of any significant situations where people are being defrauded or coerced. Why is that? How is that? Are there some safeguards in other states that we should be looking at here as we go forward with this legislation?
I think there should always be safeguards, and we should always be on the lookout for abuse, neglect, and exploitation of everyone, not just people with disabilities. You should be looking out for me to make sure I'm not abused or neglected. And if you think I am, there are places you can go to raise that concern. The police, doctors, adult protective services, the Department of Justice's Medicaid fraud unit, if I'm a recipient. The same is true if you pass this bill. The exact same safeguards are in place with the exact same mandated supporters, and that's the point of supported decision making. It is to put people with disabilities in the same place as people without disabilities. The Americans with Disabilities Act says that having a disability in no way impacts people's opportunity to fully and equally take part in all parts of society. That's what SDM does. And maybe that's why we haven't seen an increase in abuse and neglect. And also, as I put in my written testimony, there are several studies showing that when people with disabilities are empowered to be more self-determined, to make more choices, they are better able to recognize and avoid abuse. That's not rocket science, is it? If you know it's your body, your money, your property, your choice, aren't you going to fight like hell if someone tries to take it away? That's what self-determination means. And I suspect that is why not only have we not seen a measurable increase in abuse or neglect, we have seen story after story and studies showing there have been improved quality of life outcomes for people who use supported decision making.
So I appreciate that. And if I could, Mr. Chair, just one more question of Mr. Martinez. If I could, thank you. I appreciate that, Jonathan. I will just ask one other thing. It was suggested in some of the testimony, and maybe you can speak to this, whether it has been done in these other states that have implemented this. It was suggested that we should have language about someone who is a part of this the supported decision-making process should be a mandated reporter. It was suggested that perhaps those individuals should not have the ability to sign a DNR, a do not resuscitate order. And there were a couple other suggestions that were given, that the decision maker should be present at all times when decisions are being made on their behalf. So would you care to speak to any of those suggestions?
Well, first, with regard to supported decision making and the decision maker being present, the person is the decision maker. So they will be present because they're making the decisions. That's the point and intent of a law like this, is to ensure that decision making sits where it belongs with the person, as long as the person is able to do that. And I heard Ms. Knopf say this, and I agree. Not everyone can do this. This is a vehicle for people who can make their own decisions. Some people will need guardianship or conservatorship. Second, I think it's a good thing to talk about safeguards, to talk about making sure there are protections in place, and there are models for that. Other states, Colorado leaps to mind, and others have provisions in their supported decision-making law about reporting. Colorado, for example, has on their supported decision-making form a reminder to mandated reporters that if they suspect abuse or neglect, to report it. So there are ways that we can put common sense safeguards in, and we should always be on the lookout for abuse and neglect of everyone. But we should not let concerns about abuse and neglect get in the way of people's equal opportunity to direct their lives. And we can't say you might make a bad decision, so you shouldn't have the right to make decisions. You can't say you might make a misjudgment or someone might give you bad advice. Because if that's our standard, if we say, as some say, you can't empower people with disabilities to do this because they might get led astray, they might make bad decisions, then we all have to look in the mirror. We cannot condition the right to make decisions on only making good ones. None of us can meet that standard. If you pass this law, people will make mistakes, just like I do, and they will learn from them, hopefully, just like I do. That is the nature of self-determination. So while we must always guard against abuse and neglect, we cannot use guarding against abuse and neglect as an excuse to deny people their most fundamental rights.
So I appreciate you saying that. And as someone who has made his share of bad decisions, I doubly appreciate your words. So thank you for clarifying that. And I appreciate your insights. And Mr. Chair, I thank you for your indulging me and asking my questions. Thank you.
You are a duly selected member of this committee, Mr. Representative. So you ask the question. Subcommittees tell their members not to ask questions. We're not that committee. So we won't mention those other committees' names. Other questions or comments from members of the committee? Seeing none, thank you very much.
Thank you.
Next, we have Adam Rendell from Fairhaven Community Health, followed by Pamela McKeever.
Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee, my name is Adam Rendell, and I work in the Development Office at Fairhaven Community Healthcare. I'm testifying today in support of Raised Bill 5486, an act concerning diaper partnership grant program. At Fairhaven Community Healthcare, we have over 38,000 patients annually, and more than 60% of those patients are children. In my role, I spend a lot of time working with donors, foundations, and community partners to raise the funds that support programs for our young patients and their families. Programs that go beyond clinical care and address the everyday needs that affect health. One of those needs is diapers. Through the generosity of donors and through partnerships with organizations like the Diaper Bank of Connecticut, we are able to help get diapers in the hands of new mothers and families who need them. The early years of a child's life are meant to be joyful and full of possibility, but many of the families we serve, those years are also financially fragile. Partnerships like these allow us to ease that burden a little bit, to help make sure these patients have one less thing to worry about while they care for their babies. Insufficient access to diapers or rationing supplies can lead to direct health impacts like UTIs or severe diaper rash. It can also have other impacts, like one mother who had to miss work because she couldn't send her child to daycare after running out of diapers. Diaper decisions affect entire households, impacting young children and their caregivers. Programs that help meet basic needs also strengthen the relationship families have with trusted community health providers. When families know they can turn to us for help, they continue coming back for primary care, well child visits, and preventive services that keep children healthy. Diapers are expensive and they're not covered by programs such as SNAP or WIC. For families already stretching every dollar for rent, food, childcare, and transportation, the cost adds up quickly. As a development team, we are proud to raise private dollars to support these programs, but the need in our community and the communities across Connecticut is far greater than what philanthropy alone can cover. That's why the partnership model proposed in this raised bill is so important. By supporting collaborations between health providers and diaper distribution organizations, the bill strengthens the work already happening in communities like ours and paves the way for more families to access basic necessities like diapers. On behalf of FC8 Fairhaven Community Healthcare and the families we serve, we respectfully urge you to support 5486, and thank you for your time and consideration.
All right, thank you for your testimony and continuously being reminded how much those diapers are. I would love to see if any of my colleagues have any comments or questions. Seeing none, thank you for your testimony this afternoon.
Thank you.
Next, we have Pam McKeever, followed by Karen Healy.
Good afternoon. Hello, distinguished members of the Human Services Committee. I am very happy to be sitting here in front of you, talking about supported decision-making. A lot of times I have my daughter with me. However, I'm going to see if I could play later a message that she has for you all. We became conservators to my daughter Emma in 2015. So over the last 11 years or so, we have been operating under what sounds like supported decision-making guidelines. I've come to realize what a gift our probate judge gave to us when he gave us a few guidelines that I would like to share with you all. The conservators of person shall also exercise said duties and authorities as conservators of person, assist the conserved person in removing obstacles of independence. And there are several more, but I've come to realize that we always function that way. So in hearing what's going on now with supported decision-making, I'm happy to say that we have practiced this, and you will hear from Emma hopefully later through a recording about how she perceives this particular process. Recently, we went to her PC for her annual exam, and we discussed how that would go. She wanted to go in alone, and so I let her walk in alone. Not much long after, I was called to join her. And she was a little frustrated. And I was thinking if there was just something that could have been on file, something more legal, this would not have happened. I was happy to sit in and be a more passive observer, but she felt strongly that she had the information that she needed to make the decision she needed to make. And if she had questions, she knew to ask for me. I think the biggest issue was that she wasn't given that choice of whether or not I could enter the room. And she really noticed that. And so we talked about how that was a good example to kind of bring up today about how some of those small things make a big difference. The village is important, and she knows that I have questions of my own, and I have my own village, and I seek guidance and support on things in my own life. So she doesn't expect to have all of the answers, but what she does know is that she has a group of people that she trusts, that she knows she can lean on and ask important questions, and that they have her best interest at heart. Does she want to make the final decision? Absolutely. Can she do that most times? Absolutely. Are we all looking over her? Yes, we are. But you know, again, that's life. I think I heard that when I just walked into the room. That's how our life goes. You have people looking over you and helping you to make really important decisions. So I hope that you can hear what she said to me. We had a conversation. She has class today. She couldn't join us. So she's very busy, but she did want to be able to share some of her ideas and thoughts about supported decision-making. Thank you.
Thank you. Questions or comments from members of the committee? Seeing none, thank you for being here this afternoon. Next, we have Karen Healy. Oh, I'm sorry, she already went. Thomas Berendt.
Good afternoon. I'm Tom Barrett. I'm an attorney, counsel emeritus with the Connecticut Legal Rights Project. I've been an advocate and attorney for clients with disabilities for the past 45 years. and I'm involved with national and statewide organizations. I'm going to take a different approach here. Others have offered moving and powerful testimony on the benefits of supported decision-making. I'll talk a little bit about our experience with clients who needed support with decision-making and their interface with conservators and the system we have through the probate courts, which would continue to exist, of course, if we adopt this legislation, and guardianships and conservatorships will continue to serve an important purpose. I've observed Connecticut conservatorship and guardianship close up for many years since the last century. I've worked closely with the probate court administrator's office over the years since the 1990s, assisting with their continuing legal education programs for probate judges, the attorneys that they appoint, and individuals, often some of the same lawyers that courts appoint and who serve as conservators and guardians. I drafted probate administration's performance standards for lawyers that the court appoints to represent respondents in conservatorship proceedings, similar proceedings. And I served as a member of the Killian Commission, otherwise known as the Conservatorship Revision Commission, which studied conservatorship, and it drafted the statutory overhaul that was adopted by the legislature and signed into law as Public Act 07116. Bottom line is that our statutes, which focus on guardianship and conservatorship, elevate the principle of least restrictive means of intervention, and they have for decades. And that's powerful. So the way that should translate into practice is that conservatorship and guardianship should be the least restrictive means of intervention. Other options should be explored and used, which should obviate the need for conservatorships and guardianships, which can be draconian and interfere with the individual's independence. And if there is a need for conservatorship, the powers of a conservator are to be narrowly tailored. But the goal is, with least restrictive means of intervention, to avoid conservatorship and
Can you
guardianship wherever
please
possible.
summarize?
I will. Basically, the issue is, this is important to further and advance this legislation. Supported decision-making is a powerful and necessary tool. Connecticut, although the statutes have recognized least restrictive means of intervention, this is the land of steady habits, and our culture is very slow to adopt and adapt to that. Please act favorably on House Bill 5485. Thanks very much.
Thank you for your testimony. And I do have a few questions. So if this bill were to move forward and it's enacted into law, what do you think the bill will actually do? So I think that's what I've been sort of trying to get my head around, because we've had the conversation. I know that there was a conversation last year around the operation of the probate courts. This bill is separate from that. And, what some folks who were arguing against it last year were arguing was that we don't need legislation. You were talking about the slow-moving cultural evolution in the space.
Yes.
But is it that this is more of a nudge than a sharp departure? How do you think this will actually play on the ground?
I think it's both, all of the above. There certainly are some probate judges who have been, narrowly tailoring. I've observed more conservatorship proceedings than guardianships, narrowly tailoring conservatorships and not appointing conservators when they're satisfied that folks have, family, friends, supporters, trusted professionals in place. So supported decision-making is happening already. But then there are other courts, other probate judges that don't take the things that way. And they'll basically do, the way things were done in the last century, where, if you establish A, B, and C, then we'll appoint a conservator for the individual with decision-making capacity issues who needs assistance. And we'll give them plenary powers over everything, which is basically infantilizing. So we still see too much of that. Then there are situations that, occasionally I have a window on, but I hear about it more close up from folks that are clinicians and working closely with their clients with disabilities, where there are issues just with, it may be landlords or banks or loans or employers, where it would just be very helpful to have this recognized and memorialized in a statute. And I think it would also be a very helpful and powerful message to, some of the, the members of the probate bench that may be slower to, go along with the evolution in our thinking and philosophy. And, it's cultural change. It's the judges and the lawyers they appoint, and, they're used to doing things a certain way. So, I think this will send an important message and a necessary, it's a necessary provision that we adopt this and get it memorialized in statute.
Understood. Well, thank you so much. Are there questions or comments from members of the committee? Seeing none, thank you for being here this afternoon.
Thank you.
Next, we have John Board, followed by Heather Zimmerman.
Good afternoon, Senator Lesser, Representative Gilchrist. I see Representative Comey as well there. Chairs Gilchrist and Lesser, ranking members Perillo and Case, members of the Human Services Committee. My name is John Board, and I'm here to submit testimony on 5487. This bill isn't just simply about education policy. It's about whether Connecticut as a state is serious about building the workforce and service infrastructure needed to ensure real communication for deaf, deafblind, and hard of hearing residents, making this directly a human services issue. As you know, you guys have cognizance over DADS. So the mission of this bill, as it relates also to the education co-bill, is to strengthen the long-term pipeline for ASL educators, interpreters, and communication access professionals that Connecticut really needs. You heard earlier today that there are only 74 residents certified as interpreters, and now we only have 3 ASL/TA certified teachers statewide. So clearly these numbers aren't sustainable. We don't have enough ASL teachers to build student proficiency to create that pipeline. HB 5487 is a practical response to the issue that we need. It invests not only in high schools and dual enrollment programs, but we can also have workforce development and certification pathways directly under DADS and other similar departments, working with the Department of Labor and the Department of Education. This is really the kind of upstreaming workforce development that the state needs. Ultimately, and I know there might be some members who might have questions, it's treating this issue as a larger workforce development strategy that communication access can't simply just be ignored while having a workforce crisis underneath it. Thank you, and I'm prepared to answer any questions, comments, or concerns that the committee may have at this time.
Yes, thank you for your testimony. I think Representative Gilchrist has a question.
Great. Thank you, Mr. Chair. Hi, John. So good to see you. Earlier today, when the commissioner was speaking to this bill, she raised that there's a similar concept in education. Are you familiar with that proposal?
Good to see you, Representative. Yes, I am familiar with that proposal, and I did testify in the Education Committee, and I'm be more than willing to send over both my testimony as well as my expanded 12-page testimony for the record.
Do you think these work together? Do you think both are needed, or do you think at the end of the day, one is stronger than the other? Yeah, just wanted your thoughts.
So my thoughts there are, I think they can work together in tandem. I think we need a all of the above approach to something like this. While I understand the education bill sort of lays the groundwork, I think that this bill can be used as sort of a workforce development model beyond the K-12 situation. I think that also, let's be honest, we need to get the Higher Education Committee in having reciprocal agreements. I know Representative Case mentioned his community college in his district, and they do a great job with their ASL program. But I think we need to have an all of the above approach. So to sort of summarize, Representative, I think, yes, these bills need to work together. The education bill lays the foundation for the education requirements, but this bill can be used as a workforce development outside of a university model.
Okay, great. I'd love to continue the conversation with you. Thank you so much.
Absolutely.
Thank you for your testimony. Other comments or questions from members of the committee? Seeing none, thanks for being here this afternoon. Next, we have Heather Zimmerman, followed by Danielle Middlebrooks.
Good afternoon, Senator Lesser, Representative Gilchrist, and the distinguished members of the Human Services Committee. My name is Heather Zimmerman, and I am the treasurer of the Connecticut Ambulance Association, here today to testify in strong support of SB 429, an act concerning Medicaid reimbursement from EMS. Connecticut Ambulance Services currently calculate mileage for Medicaid billing in two ways. They use current mapping tools for any transports within a certain town, but are required to rely on an outdated 1970s mileage guide for trips between towns. The Public Utility Control Document, also known as PUCA, was originally made for commercial vehicles and does not currently represent today's roads or actual technology. Using this obsolete system causes inaccurate mileage reporting, adds extra administrative work, and leads to inconsistent billing. I would strongly recommend the elimination of the PUCA and switching to a more up-to-date mapping tool such as Google Maps, which would make billing more consistent, improve accuracy, reduce inefficiencies, all without changing our EMS reimbursement rates. In addition, this change would also put Connecticut Medicaid more in line with the EMS industry. I thank you for your consideration and your continued support of the EMS Connecticut system.
Thank you for your testimony. When this proposal came to us, it seems wild that the statute doesn't contemplate that we can actually tell how far it is to go from one point A to point B. In 2026, we have phones and other devices for figuring these things out, so Google Maps. So appreciate it, and I appreciate the department not opposing this legislation. Are there comments or questions from members of the committee? Seeing none, thank you for being here this afternoon, and thank you
very much
for work. Okay, next I see Danielle Middlebrooks, followed by Mark Anthony Gallucci. Good afternoon.
Good afternoon. Good afternoon, members of the Human Services Committee. My name is Danielle Middlebrooks, and I serve as the Director of Advocacy and Public Policy for the ARC Connecticut. Through the work and partnership of our 14 chapters across the state, we provide, promote, and protect the civil rights and rights of individuals with intellectual and developmental disabilities. We've submitted written testimony, but I'm here today as well to express support for HB 5485, an act concerning supported decision-making. SB 430, an act codifying the Americans with Disabilities Act, SB 433, an act expanding long-term care options, the ARC Connecticut's legislative agenda, which copies are available, or I can email them to you if you haven't received it, and to urge this committee and our legislators as a whole to reject the proposal to turn CFC into a waiver program. Together, these bills and actions directly affect the independence, stability, and civil rights of people with disabilities across Connecticut. HB 5485 would recognize supported decision-making as an alternative, another option to guardianship and conservatorship. Supported decision-making empowers individuals to retain their legal rights while receiving assistance from trusted supporters to help understand options, communicate choices, and make informed decisions. SB 430, as I have learned, will incorporate the ADA integration mandate into Connecticut state law, something that's not currently in our state anti-discrimination law. And SB 433 will help expand long-term care options for ALICE families, including individuals with disabilities, to include more home and community-based care rather than institutional settings. And I'll use my last minute to urge the committee and our legislators as a whole to reject the proposal to convert Community First Choice into a waiver program. CFC was created to ensure that people can receive services in their homes and communities rather than institutional settings. And the proposed plan could come with enrollment caps, waiting lists, reduced access to services, and institutionalization, the exact opposite of what HB 5485, SB 430, and SB 433 seek to do. Challenging though it may be to fund a necessary program, it's not impossible. And I'm reminded of how Rep. D'Amico ended the ADAPT press conference on March 5th, where he said, Connecticut has the wallet, we need only have the will. And so I encourage you to remember those words, and thank you for your consideration of this testimony and everything you do in service to our neighbors across the state.
Thank you very much for your testimony. That was an eloquent man you quoted, but appreciate the work of the ARC and all of the issues that you work on. Are there questions or comments from members of the committee? Seeing none, thank you for being with us this afternoon. Next, Mark Anthony Gallucci, followed by Dr. Sue Lagarde, a frequent flyer.
Good afternoon, Senator Lesser and other distinguished members of the committee. I'm here primarily to testify in support of House Bill 5485, supported decision-making, but I want to give a very quick shout out that the Center for Disability Rights, of which I'm the CEO and Chief Advocate for 33 years now, is strongly supporting 430 to codify the ADA, again, because as other people have said, because of the federal climate. And also in support of creating a stronger pipeline for interpreters. So we're supporting Bill 5487. That's so important. I'm deaf myself, as some of you know, and I'm strongly in support of that, and my center is as well. Now, 5485, I submitted a written testimony, but I feel it's necessary to depart from my written testimony because of what other people have said, and as Senator Lesser and other legislators have brought out, some of the remarks made by people who are in opposition to supported decision-making, and I like to address that. First of all, I want to clarify something. Supported decision-making is not another form of power of attorney. It is not. I do power of attorneys all the time. I've been an attorney since 1987. It's not. Power of attorney allows the person given that power to act on behalf of someone or in place of them to do things, instrumental things, and also to make decisions. Supportive decision-making, on the other hand, is about having supporters who do things with the decision-maker, not on their behalf, not in place of them. So I know banks and other people are very worried that somebody can come in and say, hey, remember me last month? I was in the bank with so-and-so. I'm her supporter, and I want to get the balance, and I want to do this, and I want to do that. And banks are saying, whoa, that's very vague. We don't know what we're going to do. No, they're not going to be able to do that. That decision maker has to be with the person or has to somehow contact the bank by Zoom or phone or something, or send some kind of a notarized letter saying, I'm sending this person down to do this. So if you look at the way this bill is written, the words help and assist show up several times. You're helping the person, you're assisting the person, you're not doing anything on behalf of them. The only place in the bill that where we don't use help or assist is number 5, which says ascertain the wishes and decisions of a decision maker, and when requested by the decision maker, assist in communicating those wishes and decisions to other people. And that's there because, as I know from Rhode Island, I was in Rhode Island for a while, and that's where I became familiar with supported decision making. That to assist people who have speech
Mark Anthony,
impediments
can you
with oral
summarize?
interpreters. Yes.
Can you summarize, please?
So I would simply suggest, if anybody's worried about that you put language in there saying nothing in this act shall be construed as giving a supporter the power to act without the decision maker or in place of the decision maker or make decisions on behalf. Thank you.
Okay, thank you. Other comments or questions from members of the committee? Seeing none, thanks for being back with us again. Next, Dr. Sue Lagarde.
Good afternoon, Senator Lesser, Representative Gilchrist, members of the Human Services Committee. My name is Dr. Suzanne Lagarde. I come today in support of House Bill 5481, an act concerning medical assistance for patients receiving care at a short-term hospice specialty hospital or a hospice facility. As many of you know, I have come before this committee on many occasions over the years in my capacity as CEO of Fairhaven Community Healthcare in New Haven. And while passage of this bill will benefit many of my Medicaid health center patients, I come today primarily as a board member and past board president of the Connecticut Hospice, and as a physician for more than 40 years who has witnessed time and time again the power of high quality hospice care for those facing end of life. The Connecticut Hospice, founded in Branford in 1974, was the first hospice in this country. For over 50 years, it has remained true to its mission as a non-for-profit institution that provides dignified, high-quality end-of-life care. However, a glitch in our bureaucratic system often denies patients access to this care, while at the same time costing the state many millions of dollars. There's a solution to this problem which would allow patients to die comfortably and with dignity, and at the same time save the state tens of millions of dollars every year. Here's the issue. Currently, hospitalized patients who are at the end of life often do not meet Medicare criteria required for transfer to an inpatient hospice facility. The terrible irony is a medically complex, frail person whose life expectancy is measured in terms of days or weeks can and often is denied admission to Connecticut Hospice because they are not sufficiently symptomatic. For example, they're not short of breath or they don't have intractable pain. The end result is that every year, thousands of Connecticut hospitalized patients who no longer require the level of care of an acute care hospital end up languishing in a hospital bed for days and weeks if nursing homes can't or won't take them and they remain too ill for discharge to home. The cost of languishing in a hospital bed is not only millions of Medicaid dollars to the state, but also a loss of dignity for the dying. When patients eventually end up either going home or going into a nursing home, neither environment is capable of managing these complex patients, so they are often readmitted, adding exponentially to their Medicaid bill. Connecticut Hospice and several other organizations in the state are able to care for these complex patients. They just need to get paid for these services. Calculations show that Medicaid payment of as little as $820 a day would save the state dollars, reduce the pressure on hospitals by opening up beds, and perhaps most importantly, provide patients with great comfort during their final days. This would truly be a trifecta, a win-win-win, a win for patients, a win for the state, a win for hospitals. Thank you very much.
Thank you, Dr. Lagarde. It's good to see you. You're always welcome in front of the Human Services Committee. Representative Comey.
Hello, Suzanne. It's good to see you. We've become seeing each other almost every day in the past 4 or 5 days. Thank you so much for your continued advocacy on this. I know that you have a specific sort of talent and interest in thinking outside of the box and delivering care. So I appreciate your position on the board of directors of the Connecticut Hospice and highlighting the issue in such a practical, matter-of-fact way. And I look forward to working with you and your team to get this across the finish line. Thank you.
Thank you, Representative Comey. Hospice is a very special place. And, you know, we're all going to face death and dying. And the more we can acknowledge this and do what's right by all of us, and in the process, saving money for the state, I mean, it really makes, you know, it makes tons of sense. So thank you for those words.
Thank you. Other comments or questions from members of the committee? Seeing none, have a wonderful afternoon.
Thank you, Senator Lesser.
Next, we have Emma McKeever, followed by Molly Cole.
So as promised, I have some a recording from Emma, so she's not on video. Let me just set this up for everyone, and hello, members of the Human Services Committee again. We were talking about how we were growing and strengthening Emma's independence. And I don't want anyone here to think I just send her out into the world and let her make every decision she needs to make. We are there. We are the guardrails. I've just heard that term today for her. And although she sounds very confident, please know that we are always looking over her and helping her to make these decisions.
Hi, Emma. I know you're busy at class today.
Sorry.
Yeah. How so?
Did.
How?
I'd say about at a doctor's appointment, and it's before their appointment, and me and you we talk about how it would go about saying something. We listen to the doctor's advice or information, and then we decide with each other to advise me some information and what you think. But in the end, the decision is up to me.
Okay.
Yeah.
So you always feel like the final decision is yours, even though you take the information that I'm sharing with you and the doctor is sharing with you?
Yep.
Okay. Is there anything else on that list, on that decree, that you want to talk about briefly?
Let me see. Assist the conserved person in achieving self-reliance.
Do you think we do that with you?
Yeah, you definitely push me a little bit, but you know, but I can handle it what I have to work on. So yeah. And you care about me.
I sure do. Is there anything else on that list that you want to talk about briefly? Because we don't have much more time to share.
Okay, let's see. Make all reasonable efforts to assure their healthcare instructions and other wishes. Huh? What was that?
Oh, I think we might have run out of time, but keep going.
Um,
So that looked like,
that. What?
it looks like that was just about following through with your wishes for healthcare. Do you feel like that happens?
Yeah.
Okay. All right. Well, it's getting late. I think you have to get ready for class, right?
Right.
Oops, sorry.
But the,
Okay. So that's just how it goes. That was just right before, that was a few hours ago. I include her, I support her. She has a big say in things, but we're careful. We follow what doctors say, professionals of all sorts. And she really does enjoy advocating, and she knows that the people in her village care about her. And I would say to all of those supporters out there, it's really important to give the people who you are helping to make decisions the time they need. It takes her a while sometimes to communicate, and I was not going to rush her. And I thank everyone here for having the patience to listen as well.
Well, thank you for being here, and thank her for her testimony. And you say she takes a while, but she was just over the 3-minute line, so it was very, very good. So
Yep.
thank her for that, and just appreciate her lending her voice to this issue. So, other comments or questions from members of the committee? Thank you very much.
Thank you.
Next, we have Molly Cole, followed by Marion Blake.
Good afternoon, Senator Lesser, Representative Gilchrist, and the committee. My name is Molly Cole. I'm here to talk to you about our favorite bill, supported decision-making. And I am not going through my testimony. It's submitted. It's fine. You can read it later. We're not going to talk about the same things. But I really also want to express my thanks to the committee, because Gretchen Knopf and I and a small coalition have been working on this for years, probably about 9. And this is the first chance we've had to have a public hearing to allow you to hear from people with disabilities how important choice is in their lives. So here we are. I'm the State Independent Living Council. I am the executive director there. And our role is to promote choice and equal access and opportunity and inclusion into the mainstream of society. And one of our major initiatives has been supported decision-making, because we know how important that is in having independence and having the life that you choose. So I just want to leave you with a couple of things that you need to remember. This is a civil rights issue. This is about choice. When you go into the court to leave with plenary guardianship or conservatorship, you've given up your rights. You've given up your choice. You've given it all up. It's gone. We want to avoid that for the people who are able to make those decisions for themselves. And we know that we need to have guardianship for a number of individuals, but certainly not for everyone. So we're kind of urging you to go forward, protecting those civil rights and making sure that we have the ability to choose the things we want, to have that self-determination that's so integral to so many of our values in this state, but somehow eludes us when the only thing we have is guardianship and we don't have that choice. I think that's about it. Everything else is in my testimony. We believe it is an essential element of independent living for people with disabilities, and we believe it is time for Connecticut to join the ranks of 29 other states and promote supported decision-making. And while I am testifying, I also want to testify about SB 430, which codifies the ADA. This is a gigantic leap forward. And I have to tell you again, it's very reassuring for people with disabilities to think about that the state is working on protecting the rights of people with disabilities. So as we talk about rights and we talk about the civil rights in supported decision-making, we are also talking about civil rights under codifying ADA. Thank you.
Thank you so much. Yes, Representative D'Amico, followed by Representative Comey.
So So thank you very much, Molly, for being here and testifying. And thank you for all the hard work that you've done on the supported decision-making issue legislation. So I want to ask you a question, not about that, but about the other bill that you referenced just now about incorporating by reference the ADA. The fact that that is not currently established in Connecticut, what does that mean as a practical matter?
Well, I will tell you that this year has been an anxious year in the disability world, not just in this state, but across the country. My colleagues are all worried about what's going to happen to the rights of people with disabilities. And so we all believe that the more that we can protect those rights within our own states, the safer we're going to be should the federal government continue to erode some of the advances we've made. So there's just, it's been a tough year of waiting, not being sure whether our programs would be funded, not being sure what will happen to them in the future, and knowing that some of this is codified and that we have at least that protection within Connecticut makes us indeed a very fortunate state if that happens, because I will have colleagues around the country who will be very jealous that this happened here.
So if you don't mind, Madam Chair, so have other states taken this action and codified the ADA?
I don't know that. Okay. I'm happy to find out. I have a call actually with my colleagues tomorrow and I'll ask.
No, yeah, I'd be curious to know. And just one more, if I could, Madam Chair. So correct me if I'm wrong, Molly, but Ms. Cole, I should be more formal. Okay. So I think and I don't have the bill right in front of me here, but I seem to recall that it indicates that if this goes into effect, that people will be able to file a complaint with the CHRO, the Commission on Human Rights and Opportunities, as opposed to what I think is their only other recourse, which is to file some kind of formal complaint with the Department of Justice. Do I have that right?
You have that right, and that's hit a logjam in a lot of ways for complaints. So having it within CHRO would be a step forward, I think, for us.
We'd get better service and faster service, hopefully.
I would hope so.
Yeah. Okay.
It couldn't get much slower. Let me just put it that way.
Thank you. Thank you for saying that. Okay. I appreciate that. Thank you, Molly, and thank you, Madam Chair.
Thank you, Representative. Representative Comey.
Thank you. I was just wondering if you had a guess as to sort of the percentage or of people that you feel like might take advantage of this. Do you think it would be a large, percentage, or, I mean,
I will tell you this
about your organization.
Silk has been working really hard over a number of years now to do training around this, because frankly, it's not something that has been widely known. And we continue to do that. We know that Disability Rights runs a clinic to help people come through this. So we know that, I just can't give you an estimate on whether, is there going to be a groundswell right away, or is it going to be a more gradual work? I will say that we are really committed to continuing to do this training around supported decision-making for as long as we are able. We've developed a number of materials. We continue to make those available for at no cost on our website. We've offered webinars, we've offered in-person training. Jonathan Martinez has been our consultant for a number of years and has helped us with all of these. We will develop a toolkit. We are ready to move forward with this. So I can't answer your question about numbers, but I can tell you that we're working pretty hard to help people understand how to use it and when it's appropriate.
Well, thank you. I mean, just what you've shared as far as how important it is to have these resources out in folks' hands, and your steps that you're willing to take as an advocacy organization is meaningful. Thank you.
You're welcome.
Thank you. Representative Fortier.
Hi, I just wanted to respond to Rep. Comey because my sister had a traumatic brain injury when she was in high school, and she lived with my parents for many years, and she was actually in some supportive housing for short periods of time, and moved to assisted living at a certain point, and then had some seizures that worried them, and ended up in a nursing home. My sister, even before her accident, is the most stubborn, independent person pretty much that I've ever known. So my parents had never even suggested the idea of a guardianship or a conservatorship. Anne was going to make her own decisions, even if we had those things in place. She would have been arguing with a caregiver either way. My parents are both gone, and I try to support her in any way I can. Recently, she has been falling a lot, and her physical abilities are degrading. And the most recent tests show that she may have Parkinson's. So she's a 63-year-old person. And because of the traumatic brain injury, Wikipedia tells me that she is a likely candidate for Parkinson's. But these multiple falls are worrying the nursing home and me, and they have cushions around her bed because she tries to get up in the middle of the night. And part of it is her original brain injury sort of helps her not remember how limited she is. And as she gets more and more limited, she really doesn't realize how limited she is. I was desperate to do something because one of the times she was taken to the hospital after a fall, they didn't want to talk to me. What they told me, and I won't even name the hospital, but they told me that they only speak to the facility that sent her. They don't want to speak to anyone else. So while I, again, am in no way wanting to be her conservator or guardian, because that would just be a fight on a daily basis, I'm sure, I did have an attorney friend of mine draw up a power of attorney and a healthcare proxy, so that if on one of these falls she happens to be unconscious or some other way not able to make her own decisions, that they will at least speak to me. I had no idea about your movement. So I'm just trying to tell my colleague, Representative Comey, that I think many, many people would use this because it is a much more limited form of assisting loved ones where they are the decision maker as long as they can be.
Absolutely.
And yet, sometimes we need providers to at least be able to talk to somebody on the phone that does care about that person and that often knows that person at least as well as any of us can. So thank you for your work.
Well, thank you. And, let me just say that we know that over time, people who have had supported decision-making agreements, as they lose skill and lose capacity, may need a guardianship, maybe not even a full guardianship, but maybe they need somebody to make some decisions for them. And so, as you go through the life course and you age, some of those things may or may not change, but they may.
Great. Thank you very much. Thank you so much for your testimony. Let me make sure. Okay, we're good. Next up is Marion Blake. Amy Etzel.
Good afternoon, Madam Chairperson and respected members of the committee. Thank you for the opportunity to speak in support of Bill 5481, an act concerning medical assistance for patients receiving hospice care at a short-term hospice specialty hospital or hospice facility. I am Amy Etzel, Manager of Ancillary Services at the Connecticut Hospice, where I oversee our pre-hospice programs, dementia care, and palliative outpatient care. I want to begin personally. In 1985, my mother died on hospice care with this very organization. She was surrounded by people who understood that dying is not a medical episode to be managed in an acute care bed, but a profound human experience that deserves its own space, its own care, and its own compassion. That experience shaped who I am and ultimately the work that I do every day. 40 years later, I see patients in my programs, people living with life-limiting diseases receiving palliative care who are walking the same path my mother walked, and too many of them will not have the same chance she did. This bill addresses that gap in care. The patients we serve in our pre-hospice programs are not yet eligible for inpatient hospice care. They are in a waiting period, medically complex, functionally declining, without adequate caregiver support at home. When their condition deteriorates, they end up in acute care hospital beds. They wait. They often die there alone in a setting built for cure, not comfort, because the system has no funded pathway to move them to the right place at the right time. And then when a patient does finally meet criteria for general inpatient hospice care and transfers to the Connecticut Hospice, families often arrive exhausted and traumatized by the chaos of the hospital environment. The disruption of that late transfer adds suffering not just for patients, but for families who will carry the memory of those final days forever. This bill changes that. By providing reimbursement for room and board at our facility, it creates that funded pathway to the right care in the right setting at the right time. The data supports this urgency. 55% of eligible Medicaid patients in Connecticut die without access to hospice care. That is not a statistic. Those are people. This bill is not only the right thing to do, but also the fiscally responsible thing to do. As my leadership has shared, this is projected to generate significant annual savings to the state by reducing avoidable hospital readmissions, freeing acute care beds, relieving emergency department bottlenecks, and reducing the burden on skilled nursing facilities that are often unable or unwilling to accommodate their highest acuity patients. The patients I work with, the ones who come to us before they are ready for hospice, deserve a system that can catch them when they fall. Their families deserve to say goodbye in a place of dignity and peace, not in a hallway or a hospital room designed for everything except what they need most. My mother had that gift, and I'm asking you to help give it to the patients and families of Connecticut who are waiting for it right now. I urge your support for Bill 5481. Thank you.
Thank you so much for your testimony and for doing the work you do.
Thank you.
Representative Comey.
Thank you, Amy. I wasn't going to mention this, but my mother as well in 2015 passed away in a hospital after a 45-day stay. And I was there for 45 days with her while trying to get into hospice. And I was alone because I didn't want the kids to come in, into an environment like this. And it was definitely a clinical, environment that really was isolating.
Yeah.
And so, I hope that if we get, 5481 over the finish line here, that no one else has to do that. Right. And that they get the care and attention for not only the people who are sitting by their bedside, but, correct care for the patient, but also strong reimbursement for the hospital. So thank you.
Thank you for sharing that. And thank you for your support on this bill.
Great. Thank you so much. Next up is John Flanders.
Good afternoon, Representative Gilchrist and ranking members. And I see that my Senator Lesser has departed on me. My name is John Flanders, and I am the president of Special Education Equity for Kids of Connecticut, or SEEK. We're an organization of parents, attorneys, and advocates who work for improved educational opportunities that the students with disabilities need, deserve, and are entitled under law. As such, we are more than pleased to offer our support for Raised Bill 430. We think this is an important step, but we do have some suggestions. You'll hear more from my colleagues, but number one, while there's significant overlap between the Americans with Disabilities Act and Section 504 of the Rehabilitation Act, both of those federal statutes cover individuals with disabilities, and both of them have enough differentiation so that you would be far better off including Section 504 with your incorporation of the ADA, and that would certainly coordinate and support what is being done by your friends in government oversight down the hall today. The reason that we are so pleased with this is because it fills in a huge gap that's developing for the protection of children with disabilities. There's no surprise to learn that the Department of Education, the U.S. Department of Education, has decimated its Office for Civil Rights, which protected students with disabilities from discrimination. Over half of OCR's staff has been subject to reduction in force actions, and 7 of the 12 regional offices, including the Boston office that handle Connecticut claims, have been closed. In 2024, fully 35% of the cases brought to OCR addressed disability discrimination. Since January 25, that figure has dropped to 1%. Historically, over half of all OCR complaints have involved disability. In the period from March to September 25, OCR received roughly 99,000 complaints. Of those, only 635 were investigated, and over 7,000 were resolved, of which 90% were dismissed as not meeting the qualifications. While working with the federal government was never a perfect vehicle for protecting the rights of students with disabilities, today even that minimal protection is gone. Connecticut needs to step up and to protect the rights of the most vulnerable students, and adding the protections incorporated in the ADA and Section 504 to Connecticut law, if done properly, is an important and vital step in that direction. And I will stop unless you have questions.
Thank you so much. Let me make sure. I don't see any hands. Thank you so much for your testimony and for being here today.
Thank you.
Next up is Andrew Bate.
Members of the Human Services Committee, thank you for the opportunity to testify on Race Bill 433. The stated purpose of this bill is to expand home and community-based long-term care service options. This bill is being proposed as the flagship program of Connecticut's home and community-based long-term care system. Community First Choice is proposed to be eliminated entirely from the budget. In previous testimony, I've talked about the fact that on average, home and community-based services cost less than institutional care, and I've also mentioned how home and community-based services are certainly better for me and many others because they have a loud choice in how our lives are lived. Here is an example of what can happen when a program like CFC is not available. I was a social worker in Jane, named Change by the way, was in her mid-20s, living in the community. Her parents both deceased. Jane lived with her grandmother. My supervisor, Teresa Nadeau, had managed to put some supports in place using the PCA waiver so that Jane could live in the community. Then Jane's grandmother developed Alzheimer's type dementia. Jane could not be left alone because she was nonverbal and she could not perform any activities of daily living. Though she had no cognitive impairments and could communicate by eye gaze. Teresa and I quickly realized that a change in living situation was going to have to be made. In the mid to late 90s, there was no home care option that would provide 24-hour care, including the PCA waiver, which still does not provide 24-hour care. We met with DSS and tried to devise a plan in which DSS would pay for 23.5 hours of care and Jane would pay for half an hour. After discussion, we discovered that this was just not an option. Soon after, a person who was a West Hartford School's honor student pursuing her associate's degree was forced into a nursing home. As a result, Jane's life simply stopped. No more education, no more community. Being nonverbal, we both knew that she was definitely at risk in a nursing home. In fact, she died within 2 years. This situation haunts me to this day. This happened on my watch. In the event that CFC is eliminated, more situations like this will occur. Although, I'm sorry about that. Although on average, CFC plans cost much less than nursing home care under Medicaid. CFC is the only state-funded program that can provide.
Can you please summarize?
Essentially, CFC is the only state program that can provide 24-hour care. And without this program, you're going to see more situations like Jane's, many, many more coming down the road in the future. Thank you very much.
Thank you very much. Thank you for your testimony and for being here today. All right, Joan Cullen.
Good afternoon, Madam Chair and respected members of the committee. My name is Joan Cullen. I am the Director of Volunteers, and I have been with the Connecticut Hospice for 17 years. I live in Fairfield. I am speaking on behalf of Bill number 5481, Medical Assistance for Patients Receiving Short-Term Hospice Specialty Hospital or Hospice Facility. In 2019, my father was 93 and in good health. He took a fall in his living room. He severely scraped his side and arm on the rug and was seen by urgent care. After he came home, we dressed the wounds for 2 weeks, but realized he was not recovering as he usually did. After a night in terrible pain of unknown origin, we took him to the emergency room and he was admitted to the hospital. We learned that in the fall, he suffered a fracture of the tailbone and his wounds had turned septic. The next day, his doctor told us that it was time for hospice. The hospital had an inpatient unit and he should go there. Shocked, we asked the hospice agency to visit him in the hospital for assessment. They ended up assessing him daily for 6 days, and each day we were told he was not appropriate for inpatient hospice care. Yet the doctor was clear that his uncontrollable symptoms meant death would be soon. We could not take him home, yet we could not keep him in the hospital. As the hospital presented us with the reality that he would not be able to stay, he ultimately died on the 7th day of his hospitalization without hospice care. The discrepancy between the prognosis of the physician, intractable symptoms, and the assessment of the hospice frightened my father and caused undue stress and confusion for my family. Approving Bill 5481 would help patients like my father receive hospice care in the right setting at the right time.
Thank you so much. Thank you for your testimony. Have a great afternoon. It's very helpful. Next is Rosanna Ferraro. Nope. Sydney Glasgow.
Hello,
Hello, go right ahead.
there's my camera. My name's Sydney Glasgow. I'm testifying in support of Bill 5484. This is my first time testifying. I'm a student at UConn. I guess it's my first time testifying not as a character because I do mock trial at the University of Connecticut. But I want to support 5484 because of my neighbor, Frank. He's more like a grandfather to me than kind of my own grandfather, actually. But he has dementia now, and Parkinson's, and he can't drive himself anymore, which is unfortunate because my fondest memories with him is him driving me to school every single morning in elementary school. I try to drive him whenever I'm home from college to his appointments and stuff, and my parents take him whenever they can. But when we're away, if they're at work or I'm at school, he has an visiting caregiver that comes in, but she only kind of organizes the house. And since he lives alone, he does need that support. But it would be really, really helpful to have someone have the initiative and the incentive and the funding to be able to take him to appointments. And it would alleviate a lot of stress and worry from me and my family. Thank you.
Thank you so much, Sydney. Sydney, how did you hear about this bill?
I'm an intern with the Active Voice, which is run by Christine Palm, who I've heard is your close friend of Representative Gilchrist.
Yes, yes, I am.
Yeah, and she has us testifying on a lot of bills, writing testimony, and it's just a nice way to go out and support things that I'm really passionate about. So that's how I heard about this bill.
It's fantastic and a fantastic story you told us. So thank you so much. Appreciate you being here.
Hey,
Representative Hughes has a question.
thank you, Sydney. Thank you. I thought you did an excellent job testifying. What would your brother want to tell us, or your family member want to tell us about this service?
Well, I mean, I think my parents would just be really grateful to have someone take care of someone that they love so much. I mean, my dad goes out with Frank for breakfast every single morning. And I think Frank would be really happy to have someone take him somewhere without having to ask us. He's truly the sweetest man I've ever met. And if you had asked him to drive himself, he would, even though he can't and he's not allowed to. So I think he would be really grateful to have someone that's being paid to support him and not just doing it out of, the goodness of their heart.
So he would be empowered through you, Madam Chair, is what you're saying to us, is that he would have power to live his life more fully if he had this support and the right resources.
Yes, yeah.
Okay. Thank you. Thank you, Sydney, for your testimony firsthand.
Thank you so much. Thank you. Have a great afternoon.
Thank you for having me.
Next, we'll hear from Catherine Crashall.
Hello, Representative Gilchrist. I don't know if Senator Lesser's still in the room or not, but hi to him if he's around, and other distinguished members of the Human Services Committee. My name is Catherine Crashall. I'm a law professor at Northeastern University. My research in particular focuses on reproductive justice, fertility care, and assisted reproduction. I live in Mystic with my wife and our 2 children, and I'm also the board chair of Planned Parenthood of Southern New England. Today, I'm here to testify in support of raised House Bill 5483, an act concerning fertility care under the Medicaid program. This bill will improve access to fertility health care for people who have Husky health insurance. Now, our state law has required private insurance companies to cover fertility care for some Connecticut residents for nearly 20 years. The state's employee plan was also updated to clearly cover fertility care, and it's important now for our public health insurance program to follow suit. As others have testified, Black women are disproportionately likely to experience infertility, but underrepresented in the patient population that accesses care, owing to factors including institutionalized racism. Black and Hispanic individuals are also disproportionately represented in our Husky program. So while ensuring care for those on the private plans or who work for the state government improves access for some, it's not adequate to address issues of disparities in care. And in fact, in 2024, I co-authored a piece published in the American Journal of Obstetrics and Gynecology, partnering with a statistician from Amherst College and a reproductive endocrinologist from Yale. We showed that states with private insurance mandates that do not provide coverage through their Medicaid program as well may in fact exacerbate racial disparities. Moreover, limits on access to fertility care especially burden members of my LGBTQ community and we are constantly under attack. While President Trump has claimed to improve access to IVF, his recent directives are cold comfort for the vast majority of Americans. Given the administration's other threats launched on the social safety net, we have no reason to think that whatever his administration may come up with will improve access for people covered by Husky. But HB 5483 gives Connecticut a real opportunity to make fertility care more accessible. In the wake of the Alabama Supreme Court decision that likened frozen pre-embryos to children and shut down IVF clinics across that state, legislators across the country have been asking what they can do to protect IVF. This is it. Pass HB 5483. Where you get your health insurance shouldn't dictate your reproductive rights. If enacted, Connecticut will join a growing trend of states requiring some fertility healthcare coverage under the Medicaid program in an effort to ensure more equitable care, including New York and DC. They both cover infertility diagnosis and 3 cycles of ovulation-enhancing medications and monitoring. With the current hostile political landscape for reproductive health, our state should join DC and New York in leading the way to do everything we can to stand for the fundamental right for people to be able to decide whether, when, and how we have our children. I urge the committee and legislature to vote favorably to improve fertility healthcare coverage so more Connecticut residents have access to the essential medical care we need to build our families, no matter how we're insured. Thank you.
Thank you, Catherine. Catherine, thank you also for working with me on this for the last few years. I was not surprised but disappointed to see that the Department of Social Services in their written testimony is in opposition. It seems as though the numbers that they're putting forward on cost are very similar to previous years. And it's my understanding we did significantly change this year's version. Can you talk through this version versus past versions that we've put forward?
Sure, I'm happy to. I think most importantly, though, Representative Gilchrist, one of the things that I think we really need to pull out of the written testimony, which I think does mirror, from my understanding, I haven't looked at the written testimony in detail to compare one year to another, but does mirror previous testimony they provided. And I think actually one of the most important things to point out would be the way that their estimate includes costs far beyond the actual fertility care that would be required under this bill. I don't know what their assumptions are based on, but it includes things like prenatal care, other obstetric care, in the event that fertility care was successful. And, that's, I don't think, an appropriate way to be thinking about the cost of providing fertility care. The care that will be provided is the cost to actually try to get pregnant. As far as other iterations of the bill, Representative Gilchrist, we have been here multiple years in a row, and I don't want to step out of turn, but I think the latest iteration, I'll go back and double check and happily get back to you. But it doesn't have as cycles for IVF in the same way that previous pie in the sky legislation that we came forward with a few years ago. It's a much more modest increase in what would be covered, sort of from nothing to first step. I'd have to look back at the other bills, to be honest, to get granular today. I'm sorry.
No, that's fine. Thank you. Very much appreciate it and appreciate your work. I do see Representative Hughes has her hand raised.
Thank you, Madam Chair. Thank you, Catherine, for getting a robust, scalable proposal before us this year, and for specifically calling out the barriers for women of color and other folks that, if we do not pass this, even are far more restricted. So the cost of a modest proposal for getting pregnant is immeasurable for those communities that are disproportionately impacted by not being covered at all. So I don't know if you have any numbers or way to quantify that, but I'm so glad that you highlighted that and the cost of failure of this, of this proposal going forward is catastrophic for those communities that have insurmountable barriers now. And a lot of times we're just left with, well, what is this going to cost all insurance, payees versus, again, limiting access to certain populations disproportionately. Can you, I don't know, just talk a little bit more about that?
Sure. So I don't have exact numbers for Connecticut, and it's one of those things. If you build it, they will come. There's not a good way for us to pinpoint the negative, right? The thing that's not coming, the people who are not accessing care, to count them up. What I will say is the paper that I mentioned, which I'm happy to share with the committee, what we found specifically was that across states, right? So there's other states that have private insurance coverage, like our state does now. And the vast majority of them, except for DC and New York, which we didn't have data for at the time, don't have their public insurance their public insurance programs don't cover fertility care. And so what we could do is look at the demographics of the state and look at who's accessing fertility care.
Exactly.
What we saw was that before the mandate and after the mandate, based upon this national database that we have of fertility care utilization, that actually in states that enacted mandates, we saw the disparities. So it was sort of like the people who are already getting the most care. If you look at our paper, it's mostly Caucasian and Asian people got more. So did other people who identify as other ethnicities and races, but the gap actually gets bigger. Right? Like this is what it is before. Everybody went up, but the gap got bigger. So, one thing that I think is really important for us to think about, particularly in a state where we're so supportive of reproductive rights and so supportive of reproductive justice, is to think, what work do we really want to do? Right? Like we want to lift all boats. We don't want to close that gap. So I think the Medicaid makes the Medicaid piece very important. But I'm happy to share that paper with you, Representative Hughes.
Thank you. And now we have a new tool to evaluate proposed legislation with racial impact study. And so I think we ought to be doing that with this so that we get a broader understanding of, racial and
equity
reproductive
issues,
justice in terms of equity, especially to access to fertility care. Thank you, Madam Chair.
Thank you. Catherine, I don't see any other hands. Thank you so much for your time.
Thank you.
Next is Sarah Hinman. No? Ayanna Lyles.
Hi, good afternoon. I apologize. I'm at the airport coming back from DC, so I apologize if you hear any extra noise. But good afternoon, Senator Lesser, Representative Gilchrist, distinguished members of the Joint Human Services Committee. My name is Dr. Ayanna Lyles, and I'm a board-certified OBGYN physician in Connecticut for the last 11 years and vice chair for the Connecticut section of ACOG, which represents 1,068 women's health physicians in our state, as well as I am a resident of Newington. I have the pleasure to provide testimony on behalf of ACOG in support of HB 5482 and 5483. HB 5482 ensures access to 12-month supply of contraception and hormone replacement, all dispensed at once. This is something my patients have asked for, as having a 1 month or 3 month supply of birth control or menopause treatments have been cumbersome. People utilize these medications for a variety of reasons, such as contraception, heavy bleeding, fibroids, endometriosis, perimenopause, and menopause care. To be clear, we as medical experts determine which medication and dosage is appropriate and only would provide a prescription for a 12-month supply for medically appropriate patients, which are the majority of patients. This legislation in no way removes our ability to practice evidence-based medicine or our prescription habits, but improves access as highlighted in my written testimony by my patients. My patients in our state are asking for this, and I also believe it will decrease our unintended pregnancy rate, as well as decrease our maternal morbidity and mortality in the state, which will have cost savings. Please consider passage of HB 5482. With regards to HB 5483, it allows for coverage of fertility care for our Medicaid patients. I highlighted a Medicaid patient of mine who really wants to start her family journey, but needs infertility treatment, as I have provided as much as I can, but she can't access it due to insurance and cost issues. We at ACOG believe all people should be able to equitably plan for their pregnancies, and legislation like this will ensure that. It expands the language as well to include gender diverse individuals and the families that they seek to build. We strongly support the passage of HB 5483 to help with family growth in Connecticut. Thank you all for listening.
Thank you so much, Dr. Lyles. Thank you for testifying from the airport. Safe flight, and thank you for this very valuable information. I don't see any questions. Have a great afternoon.
Thank you.
Next is Kayla Baipal Ottman.
Hello to Madam Chair, as well as to the members of the committee. My name is Kayla Baipal Ottman, and I am the inpatient unit social worker for the Connecticut Hospice. I'm speaking today in support of Bill 5481. I've worked at the Connecticut Hospice since July of 2023, and during my time there, I have encountered many patient and family situations that would have benefited from this bill. Due to Medicare's strict rules regarding hospice levels of care and who can stay on the generalized inpatient unit, I have sat with countless patients and families as they cry after I tell them that they cannot stay on our unit. I have come across many patients that simply get abandoned on our unit by their families because the thought of caring for them at the home or having to pay privately for care is too much to bear. I spend many hours attempting to find skilled nursing facility placement for very sick patients just to be turned down by 10 or more facilities. Patients and families are spending their last bits of time together, worried about discharge and money, rather than being together and loving each other. At the end of life is a very sacred time that should be spent in the manner that the patient and their family see fit, not worrying about whether or not the patient can stay at the Connecticut Hospice inpatient unit. To get specific, we had a patient who came to us at 34 years old. He got to celebrate his 35th birthday with pizza and cake on the inpatient unit, but I digress. This patient had cancer of the bone, skull, and face. In addition, he was obese and was on the autism spectrum. This patient did have Medicaid Husky C, which should, in theory, guarantee placement in a skilled nursing facility. But according to his mother, he was turned down by over 30 skilled nursing facilities while in the hospital before coming to the inpatient unit. He was then turned down by 12 more skilled nursing facilities when I tried to find placement for him. This patient's brother also was on the autism spectrum, and it would be very difficult for him to see his brother die at home, which is why the patient was unable to go home. The patient's mother and I were back and forth for weeks about placement, and I sat with her for much time as she told me her stressors and concerns. Eventually, I decided to bring the case to the attention of the senior management at the Connecticut Hospice. It was decided that the patient would be able to remain on the unit at no cost to the family at routine level of hospice care. I ran into the patient's mother on my way out that day, and I told her that her son would be able to stay. She fell into my arms and cried on my shoulder, and for a few moments I held her while she released all the uncertainties that the last few months had brought. During the patient's time on the unit, he was able to watch his favorite TV show, Doctor Who, and spend a lot of valuable time with his family. His room was decorated with many of his favorite things, including a poster of superheroes, Marvel specifically, and a figurine of Herbie 34. He eventually passed away surrounded by loving family and our staff who all loved him dearly. If the Connecticut Hospice inpatient unit were able to have funding, we could have many more stories like the one I just told. With Bill 5481, I'm hoping that I can spend more time holding space for patients and families as they cry with relief rather than with anguish. Thank you for your time.
Thank you. It's always nice to see a fellow social worker. Representative Johnson, go right ahead.
Thank you so much for that very wonderful testimony. It's really great to hear some of the great work you're doing. I just wondered, in terms of Connecticut Hospice and whether many of the people who you have there also are dually eligible with respect to the Medicare program.
Yes, a lot of our patients are dually eligible.
And what impact does that have on whether they stay in Connecticut Hospice?
There are different levels of hospice care. Maybe I want to defer to Sylvia on this one. Okay. There are different levels of hospice care. there's routine level of hospice care and there's generalized inpatient level of hospice care. Those are the two most important to what we're talking about today. So routine hospice care is what is typically performed in the home or in a skilled nursing facility. Generalized inpatient hospice care is what is provided on our unit at our hospital. And there are qualifying factors for that, such as continuous symptom management requiring IV medications, constant medication dose changes, and that sort of thing. So if a patient is not meeting generalized inpatient hospice criteria, then Medicare will not pay for the room and board at Connecticut Hospice, thus meaning that the patient would have to go home and have home hospice, or they would have to go to a skilled nursing facility and have hospice there. Did that answer your question?
So I'm wondering, based on what? If the doctor's certified that the hospice care is necessary, what are they basing the denial on?
So Medicare trusts us to accurately report whether or not a patient is meeting generalized inpatient criteria or not. So that is up to our medical staff to decide whether or not a patient is meeting that level of hospice care.
So in terms of level of care, does the doctor certify the level of care?
Yes.
And how does the doctor know to certify it for your place versus some other place?
So the doctor certifies the level of care based off of the Medicare's criteria for different levels of hospice care. So if a patient is getting constant symptom management and is requiring IV medications, that would be, one of the qualifying factors for the generalized inpatient unit and would allow them to stay on the inpatient unit, having the room and board paid for by Medicare.
Mhm. And so if there's no place to discharge a hospice patient to, despite the fact that they are already certified for that particular type of care, and then the care maybe is just temporary for the inpatient hospice care that you're speaking of, what procedures do you have for discharge?
Right. So if a patient is on our unit and is not meeting generalized inpatient level of care set by Medicare, we then have a conversation with the family. And a lot of times families say that they are unable to care for the patient in the home. And then in that case, I would offer to find skilled nursing facility placement. And a lot of families can't afford the room and board at the skilled nursing facility.
Okay, let me ask you that. So why would, if they're certified for hospice, maybe not at the so what is the certification of your facility? Is it a hospital certification, a skilled nursing facility certification, or something lower than that, like a rest home certification?
So we are not a skilled nursing facility. We are a specialized hospital.
So you're a hospital special care type facility, like a rehab hospital?
We're not a rehab hospital. We are a hospital that specializes in hospice.
Okay, so you're a hospital level of care that just does hospice. And that's a certification that we have now?
Can you?
How did we get that certification? Certainly, please. I do want to understand this because this is such a different way than it has been over the years. And I just wonder when were these things changed?
Although I must jump in and say you're answering fantastically.
Oh, yeah.
Thank you.
But yes, please.
I'm very impressed with her answers.
I'm sorry. I want to say you're doing a very good job and I do appreciate it. It's just that I have a few more curious questions
No,
about this
that's
and I
okay.
appreciate the testimony and all the work you do. So I'm not trying to be too pushy, but I just kind of want to understand this. Go
I
ahead.
think it's a complicated problem.
I think so too.
So first of all, we are licensed and certified and accredited as a short-term hospital, special hospice, very unique and the only one in Connecticut with that kind of licensure. And we were kind of grandfathered in that in 1974 when we originally established hospice in the United States. So that's why we have this unique licensure. So we can provide acute care, so we can provide hospital level of care, and we can provide hospice inpatient care. So the care we are talking about here is that hospice level of care. In the past, way back when, people could come into a general inpatient hospice and could stay. What happened is that, and I talked about this a little bit earlier in my testimonies, in my written testimony, Medicare is really scrutinizing hospices across the country because of what they perceive as fraudulent activities within the hospice benefit. So they are really scrutinizing these levels of care. So where we would have had a patient that would have come into a general inpatient hospice level of care with very acute symptoms and then passed away, you know, we would stabilize them and they would just comfortably pass away. Now we can't do that. Once they stabilize, Medicare is saying they should not be in a facility. They have to go home. They have to move to a different level of care, because facility care is only for patients who are acutely symptomatic, not for patients who are comfortably dying. And that's where the discrepancy comes. We are reimbursed for a routine hospice if we kept them. Hypothetically, if we kept them in the facility, we get paid $240. If they are in a general inpatient level of care, they are paid at $1,200 and something. So for us to keep those patients in a high-cost, high-end facility is very expensive. And there is no room and board coverage for them. So say hypothetically it is a dual eligible patient. They have Medicare and Medicaid, and we would keep them in the facility at a routine level of care. Medicare would pay at a routine level $200 a day for that patient, and the family would then have to pay the difference, the room and board. Or if there is no reimbursement as a nonprofit, we then have to get philanthropical dollars to sponsor the discrepancy between a general inpatient reimbursement and a routine level of reimbursement. So that is why we are requesting room and board. Earlier, I mentioned that a lot of these patients have a very short stay. We did a study, and it showed that they often have 8 days. You know, it's not a long time that we are asking to extend the care at the back end. So Kayla was specifically talking about patients at the back end. We also can bring them over a little earlier. And the significant cost savings there would be that in a hospital, they are paid under an outlier per diem rate. So it might cost a hospital about $2,000 to $6,000 a day to keep them. We are requesting $820 a day to bring them over and to be able to provide this fantastic care for them sooner until they're general inpatient. Then it's all covered by Medicare, by Medicaid hospice for that level of care, and keep them until they die so that they would never have to go home if there is a disposition issue. That is what we are requesting.
Thank you so much for that explanation. It really, because I remember when they had the Stanford, was it Stanford or Stratford? I forgot, but they had the inpatient hospice, and that was the only hospice in Connecticut you could go to. Are you familiar?
The residential hospital, the
Yeah, it was,
residential house.
yeah, it was,
Yes.
and then the certification for the Medicare program was every 60 days, a 30-day, and then another 60-day period. And so once they were certified, they would be able to go from one level of care to another just within the certification as required by the treating doctor. So apparently
So
the
that-
statute has changed under the Medicare program.
That certification still exists. So they are, they usually have 2 90-day periods and then 60 for the remainder of their life. But because there are 4 different levels of care, we are really just talking about routine and general. They can move back and forth between these levels of care. But specifically in a facility, there is no reimbursement for, other than if they meet that level of care, there is no additional payment for that.
Just curious about and I don't want to delay this any longer, but maybe I'll talk to you offline. Just to see when the systems change, because it sounds like a regulatory, not a statutory change. It sounds like something that they did by regulation as opposed to by statute. And I just think that maybe that's something we should take a look at as well, because it sounds like they're gaming the Medicaid system so the state pays. Not that I'm against the idea that the state would pay for this. I think that it's a good idea based on the testimony I've heard today and what's going on. But I think that there's a real problem with how this is being addressed based on how it used to be and
believe
the
that.
impact on the families, especially at such a difficult
Absolutely.
time. And I just appreciate your work and the testimony of all the work from everyone who has been doing this work. So it's very hard thing to go through, and it's very, very good work. So thank you. And thank you, Madam Chair.
Well, thank you so much for your interest. And I would love to discuss this further because I think we're talking about the most fragile patients that need the most help and their families. So thank you so much for hearing us out today.
Thank you. And I know this is unorthodox. I have an additional question, and I know we pulled you back up, but I appreciate this. The more we hear from you all throughout the day, it's making more sense. Do you think this would open the door to do you think it's been a barrier to other entities offering this care because there was no payment structure? Like, would this have the potential to increase places like yours?
Well, I at the moment, and I think that's why we included the other hospice facilities, not just the Connecticut Hospice in this bill. At the moment, we have 2 other facilities, Regional and St. Mary's, that have hospice units. And this would also help them, for the same reason. So it's not, although my calculations were done based on our internal data, it does affect other facilities in Connecticut, and we included those in the bill to help out with this issue.
Thank you. This is very helpful. Thank you. Rosanna Ferraro has joined us, I believe. Yes, go right ahead.
Good afternoon, Human Services Committee. I was in government oversight and it just sort of dovetailed right at the same time. I'm Rosanna Ferraro.
Busy day today. Busy day.
It definitely, and I actually was watching somebody in government oversight, and they ran up. They moved over here, so just following the trend today. I am Rosanna Garcia Ferraro. I'm the policy director at Universal Healthcare Foundation of Connecticut and a resident of North Branford. Universal envisions a world where justice prevails, health is respected as a human right, and equity is realized. I'm here to speak in support of HB 5483 about fertility care coverage in Medicaid. In our work, we prioritize Black and Brown folks, immigrants, LGBTQIA folks, people with disabilities and chronic illness, as well as folks with low income. There is a lot of overlap between the folks that we prioritize in our work and the folks that would be impacted by this bill. We stand in strong support of ensuring access to fertility care for folks on Medicaid. I think that we would be remiss if we also didn't uplift our partners. Well, we have a number of partners, some are here right now, but particularly in birthing people in the LGBTQIA plus community that that needs to be uplifted here. I do think that every family that wants to have children should absolutely be able to do so. The converse is also true. That's a different bill. So we just want to make sure that folks have access to the care they need when they need it. I think there's a timeliness to fertility care that is also incredibly important to uplift. And I also just want to make sure that I'm here in solidarity with all the individuals that have come to speak on their own personal experience, as well as some of our partners who I can actually see right now on the Zoom. I just want to, I know Senator Lesser isn't in the room at the moment, I don't think, but he has been asking about the codification of the American with Disabilities Act. And I just wanted to say one small thing on that, which was absolutely we should do that. And also we should really take this opportunity. If we're going to codify the American with Disabilities Act, we know from years of having the ADA that there are places where it has fallen short. I, again, would be remiss if I didn't ask you all to take the opportunity to maybe fill some of those gaps, maybe shore up our ADA so that it can be the strongest one in the country. Other than that, I really appreciate your time and I appreciate you all letting me jump in.
Thank you so much. Thank you for your testimony. Representative Hughes, go right ahead.
Thank you, Rose, for sticking with us. Do you have specific language about strengthening our version to be the strongest in the country of the ADA?
I do not. I have a colleague who is number 81, Quinn Meehan, who is extremely well versed in disability justice and other areas of disability. Not a lawyer, but they know an awful lot about this, and I think they and I could get together and send you all something to that effect, because I do think, and they may also be able to answer some of those questions later. They may be watching me say this and be like, no, we will send it later. So, but we can absolutely send some recommendations about where the ADA could be strengthened and how we could have the strongest one.
Thank you, and through you, Madam Chair. I just think that what you commented about this being incredibly timely, and also we just don't want to update, but we want to future-proof against this regime and others that may seek to strip the most vulnerable rights that they should have already been enjoying, but alas, have fallen short of. So thank you, Madam Chair. And we'll look forward to number 81.
Thank you.
Thank you, Representative. Thank you so much. Have a great afternoon.
You too. I hope you all get outside in the sun.
I do too. I'm dreaming about it. I did ask to go on a dog walk, even if it's 8 p.m. I will be going on a dog walk. And Knopf. Oh, thank you. I thought that name. Kenyao Lee.
Hi, good afternoon, Representative Gilchrist and the distinguished members of the Human Services Committee. My name is Qingyao Li. I'm a second-year Master of Public Health student at the Yale School of Public Health, and I'm testifying in support of Senate Bill 433, an act expanding long-term care options. Connecticut's long-term care system is facing a growing fiscal challenge driven by demographic change. Between 2022 and 2028, Connecticut's population aged 65 and older is expected to grow by about 16%. At the same time, roughly 70% of older adults will require some form of long-term services and supports during their lifetime, meaning demand for long-term care will continue to increase in the coming years. As people live longer, the prevalence of disability is also rising. Between 2022 and 2028, the number of adults aged 65 and older living with disabilities in Connecticut is projected to increase by about 21%, further increasing demand for LTSS. This demand is largely financed through Medicaid. Over the past 2 decades, Medicaid spending on LTSS in Connecticut has increased from about $1.9 billion in 2003 to nearly $4.3 billion in 2025, an increase of more than 100%. Looking ahead, projections suggest that if current trends continue, Medicaid LTSS spending could reach approximately $7.7 billion by 2028 as demand continues to grow. In other words, long-term care is already one of the largest drivers of Medicaid spending in Connecticut, and continued growth will place increasing pressure on the state budget. Senate Bill 433 takes 2 practical steps to help addressing this challenge. First, the bill strengthens Connecticut's ongoing efforts to expand home and community-based services. Connecticut has made meaningful progress About 70% of Medicaid LTSS participants now receive services in community settings, but access barriers and capacity limits still remain. Some noticeable examples include workforce shortage, Medicaid cap enrollment, waiting lists, and others. Second, the bill directs the Long-Term Care Planning Committee to examine additional policy options for expanding long-term care services and financing options. This analysis is important because the current system relies heavily on Medicaid, while private long-term care insurance coverage remains limited. Only 15% coverage rate among those who are 60 and older. This poses enormous financial sustainability and access issue for the state's LTSS. As Connecticut's population continues to age, Senate Bill 433 represents an important step towards strengthening the state's long-term care system by expanding access to HCBS and advancing the planning needed to address future financing and access challenge. Thank you for your time.
Thank you so much. Thank you for your testimony and for being here today. I don't see any hands, so have a great afternoon.
You too.
Thomas Burr.
Yes, good afternoon, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Thomas Burr. I am the Public Policy Manager of the Connecticut chapter of the National Alliance on Mental Illness, otherwise known as NAMI Connecticut. I am testifying today in regards to HB 5480, an act concerning peer support services under the Medicaid program, and HB 5485, an act concerning supported decision-making. Regarding 5480, the purpose of the bill is to create a mechanism for peer support services to be reimbursed under the state's Medicaid plans. We support this as we consider peers to be one of the best kept secrets to help people with mental health conditions achieve long-term recovery. Hartford Healthcare, Advocacy Unlimited, and the Connecticut Community for Addiction Recovery have trained hundreds, if not thousands, of recovery support specialists and recovery coaches, but very few have found gainful employment due to the lack of the ability of facilities to be able to bill for their services through Husky. This bill remove that barrier and help many, many people regain their mental health. In addition, the bill will help both the individuals and the state of Connecticut by reducing hospital readmissions, lower emergency department usage, and increase treatment retention. Regarding House Bill 5485, the purpose of this bill is to create an additional avenue for people with disabilities to have agency over the decisions that affect their lives, such as housing, medical care, or financial management, through the ability to allow them to select a trusted adult to aid them in making these decisions. Unfortunately, over the years, I've heard too many stories of individuals who had a probate court-assigned conservator or guardian who really did a poor job in actively responding to and reflecting the wishes of the person they were ostensibly serving. I believe this bill will give individuals an alternative to being subject to a stranger having this level of control over their lives. SDM promotes self-determination and prevents unnecessary restrictive guardianship. We would also encourage the committee to include language which would ensure that the youth with disabilities be made aware of SDM options at age 18 during their IEP meetings to prevent premature, unnecessary guardianship. And I should mention that this bill is very personal to me. I have an adult daughter who suffers from both cognitive, physical, and mental health disabilities. And right now, her mother and I are her guardians, and that's working really well. We always incorporate any decisions we make with her input. Whether we wanted to or not, she would give it. But regardless, it's going to be sooner than later, because we're not spring chickens anymore. We're going to need to make a transition, and having SDM available for her down the road, I think would be very helpful. So in conclusion, we support both HB 54 and HB 5485. And I should also add, since I haven't heard the music yet, that we support Senate Bill 430, an act codifying the ADA, as well as echoing John Philander from SEEK's recommendations around including Section 504 of the IDEA. Thank you.
Thank you so much. Thank you for being here and for your testimony. Have a great afternoon.
Thank you.
Liz Gustafson.
Hi.
Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Liz Gustafson, and I am the Connecticut State Director of Reproductive Equity Now. Thank you for the opportunity to testify in support of both HB 5482 and HB 5483. As a state and regional organization, Reproductive Equity Now works in Connecticut and across New England to make equitable access to the full spectrum of reproductive health care a reality for all people. Connecticut residents deserve to live in safe, thriving communities where all people can seek the full range of sexual and reproductive health care that they need with the insurance coverage that they deserve. Timely and consistent access to affordable contraception is critical for ensuring people can access and utilize the birth control method that meets their individual needs. Our state has made great progress in advancing contraceptive access, but there is still more work to be done to advance equity. Our state has expanded access by requiring most private insurance plans to cover a 12-month supply of FDA-approved contraception at one time. And HB 5482 builds on this progress by extending coverage to those enrolled in Husky. Regardless of medical need, income, insurance carrier, or proximity to a pharmacy, patients deserve affordable and accessible care. Additionally, Reproductive Equity Now believes that the decision if, when, or how someone becomes a parent is one of the most important life decisions we make, and everyone should be able to make that decision without barriers, which includes equitable access to fertility care. Connecticut's existing coverage for fertility care only applies to private insurers, which means that state residents insured through Husky are excluded from the existing coverage. HB 5483 would not cover the full range of fertility health care for Husky, but it is an important step to increase support for family building and for fertility preservation. As someone who has endometriosis myself and was also denied insurance coverage for fertility preservation, I know that firsthand how cost is and continues to be a significant barrier for those seeking and needing fertility care. And HB 5483 is an important step in recognition that here in Connecticut, all people and all families, regardless of insurer, who they are, or how much money they make, deserve access to the fertility care and family building health care they need to start or grow their families. Passage of both bills is a matter of economic, racial, and reproductive justice. Our state must ensure that no one is left behind and that all people have equitable access to insurance coverage of the health care they need. And we urge the committee and General Assembly to support both. And thank you so much for your time.
Thank you so much for testifying. Senator Lesser.
Thank you, Madam Chair, and good to see you, Liz. Just a question, you mentioned the law that we have in place for people with private insurance around your supply of contraception. This bill is a little bit different, right? It seeks to extend that to Medicaid, which makes sense to me. But the obvious difference is this bill goes beyond that and also covers other forms of hormonal treatments, as I understand it. What we heard this morning from DSS was some concerns about if that's safe, if there's, folks they were arguing will need, in many cases, obviously people need hormonal treatments for all sorts of different things, but they were arguing that in many cases that would require ongoing supervision from a medical provider in a way that contraception does not. And I didn't know if you had heard that testimony, if you found that persuasive or not, if you had thoughts about, the commissioner's concerns.
Yes, I did hear that. I read it. And just want to clarify that bill language does give and provide provider and prescriber discretion to prescribe what is medically appropriate and potentially supply less than 12 months for both contraception and for hormone therapy.
Okay. All right. Thank you very much.
Thank you. Representative D'Amico.
So thank you, Madam Chair. So Liz, thank you for coming in and testifying. As far as you're concerned, other than cost, is there any reason for us not to do what is being offered in House Bill 5483?
No, I think we absolutely should pursue any and all opportunity for people to access the fertility and family building coverage that they need, regardless of insurer.
Okay, thank you very much. Thank you, Madam Chair.
Thank you, Representative. Thank you so much, Liz. Good to see you.
Thank you. Take care.
You too. Next is Joseph Sacco. You just need to push the button, please. There you go.
Madam and Mr. Chair and respected members of the committee, thank you for the opportunity to speak in support of Bill 5481. I'm Dr. Joe Sacco. It has been my privilege to be the Chief Medical Officer of the Connecticut Hospice in Branford for 10 years. It is a firm requirement of my responsibility as CMO of our institution to be deeply versed with federal and state laws and regulations overseeing hospice practice. My core duty, however, is to assure that eligible patients receive the highest quality hospice care, that Connecticut Hospice retain its deserved title as not only America's first hospice, but its best. It will not surprise you that these two imperatives are often in conflict. Part of my role is to conduct rounds at the acute care institutions from which many of our patients are referred. All are referred in good faith by my acute care colleagues. All are eligible for hospice care, and all are in need, in real, deep, desperate need of the kind of end-of-life care that we are renowned for delivering. Not all, however, meet Medicare's requirements to qualify for admission to inpatient hospice at our beautiful 52-bed waterfront facility in Branford. I will not use time explaining those criteria. I will say that choosing who does and does not meet them is my greatest source of personal professional angst in my 40-year career. Representative Johnson, you asked earlier who makes those decisions. By and large, it's me. Every week, I meet needy and deserving dying patients with heart, lung, liver, renal, neurologic disease, cancer, dementia, and much more, who are literally stuck in an acute care bed in a hospital somewhere in Connecticut because they are not sick enough to qualify for inpatient hospice according to Medicare, too sick to go to homes lacking the resources necessary for their care, too sick for a custodial stay in a skilled nursing facility where, if accepted, they will soon be sent back to the emergency room, ineligible for a short-term rehab stay covered by Medicare, and no longer sick enough to merit acute inpatient hospital treatment. Talk about being stuck between 3 rocks and 4 hard places. The irony is that those of these patients who are insured by Medicaid are costing the state more money, much more, as much as thousands of dollars per patient per day, than we are requesting from you, sitting day after day in an acute hospital bed as they wait and wait and wait until they are finally sick enough to meet Medicare's inpatient or GIP criteria and come to us and die, all too often, too fast to benefit from the many services we offer. I think we can all agree that this one is common sense. How often do you get a solid, defensible, data-driven offer for better care at a lower cost? We have beds. Let's get these deserving patients into them. Thank you for your time.
Thank you so much. Any additional question? Yes.
Thank you.
Representative Johnson. Yeah,
Thank you
sorry.
so much, Madam Chair, and thank you for your testimony. And I think this warrants more of a discussion, and I'll be speaking with the chair of this committee to see if we can't include you in the Medical Assistance Policy Oversight Council discussions and perhaps come to the Complex Care Subcommittee to get in, kind of drill down into what's going on and maybe the changes in the Medicare law and certainly how they've written the regulations, perhaps not consistently, perhaps with the actual statute. So just a thought.
If I can participate in changing Medicare law in regard to hospice, I will die happy. So thank you for that invite.
That certainly sounds like a great start for the Complex Care Subcommittee.
Thank you so much.
Thank you, Madam Chair.
You're welcome. Representative Comey, followed by Representative D'Amico.
I just want to thank you, Doctor, for your work for such a long time. But I also want to thank my colleague because I've been having conversations, Representative Johnson, I've been having conversations with the Connecticut Hospice folks, and one of the things that I came up with was having a presentation to one of our MAPOC groups. So thank you for that offer. Your committee would be the ideal place for that. So thank you both.
Thank you.
Thank you. Wait, Representative D'Amico. You're popular.
Yeah,
Hold on.
right over here, Dr. Sacco. So,
Yes.
thank you for your testimony today. Appreciate it. I'm in agreement with you. I think a lot of us are in agreement with you. I'm looking at the testimony on this bill that was submitted by the Department of Social Services. Medicaid has strict prohibitions against paying room and board in many circumstances, and so on and so forth. So is this going to be both a federal as well as a state issue if we start to dig into this?
I think that it would make sense for this to sort of transition nationwide because it makes so sense and because together we're going to make the changes here in Connecticut. But yes, it's true that Medicaid does have a prohibition on paying room and board, and that's why we're here today, right? We are hoping that we can stop Connecticut Medicaid from paying thousands and thousands of dollars for room and board in an acute care setting, bring them to the place where they'll get far better care at the end of their lives, and Medicaid will save thousands of dollars per patient per day.
And I agree with you. That
Yeah.
makes perfect sense.
Yeah.
And again, I don't know enough about this as I should, but I suspect that you do. We can do whatever we want, or we can try to do whatever we want at the state level. Are we going to run into federal obstacles? I guess that's the question that I'm raising.
I think that's a great question, and I will be transparent in saying that I'm uncertain of the answer, but I know also that Medicaid is administered jointly by states and the federal government, and I know I spent a lot of time in New York that, Medicaid regulations there were quite different than they are here. For example, in terms of for financing home care, et cetera. So I don't think that would be the case, but I can't guarantee that that's correct.
Thank you very much.
Thank you for your time.
Thank you, Madam Chair.
You're so welcome. One more, Representative Vale.
Thank you, Madam Chair. Is there a definition? I know what hospice is. Is there a defined definition for care in days or time?
There's not a defined definition for the number of days people can stay in hospice. What Uncle Sam requires is that a doctor, and in the case of Connecticut Hospice, by and large, that's me, certify that a patient have a prognosis of 6 months or less if the disease follows its natural course, right? So the people that come into us, by and large, have, declined further disease-directed care or cure-oriented care. And mostly the vast majority of those people, disease-directed or cure-oriented care is not benefiting them anymore. And what they want to do is have the highest quality of life for the time that remains to them. I have to certify a 6-month prognosis, and I have to recertify them during the course of that 6-month prognosis. And I can continue to recertify provided I can assure Medicare that they are continuing to decline and that 6-month prognosis remains a medically reliable estimate. We are talking about it was explained earlier that there are different levels of hospice care. We have many patients at home who are receiving what's called the routine level of hospice care. In order to come into our facility in Branford, which is a specialty hospital, people at present have to meet Medicare's requirements for inpatient level of hospice care, which is much higher acuity, right? And what we struggle with, or what I struggle with, we all struggle with, is when, people are stuck literally in the hospital. They're very sick. They can't go home. Their families can't care for them. Skilled nursing facilities, our social worker applies to 10, 20, 30 facilities. They turn them down because their needs are too great. They're no longer benefiting from hospital-based care. They're not eligible for rehab services in a skilled nursing facility. And we can't take them because they're not meeting Medicare's criteria, right? So what we're asking is to be able to take that population, with a room and board reimbursement that doesn't come close to what's already being paid to keep them in the hospital, in the regular hospital. But the answer to your question is there aren't time limitations. And sometimes we find ourselves, discharging patients from hospice because they haven't died. They haven't gotten worse.
Okay. Obviously, I think we've all experienced this in some way, shape, or form. And my experience was kind of right at the end. So that's why I wondered if there was some type of definition, or hospice is a more broader term, like the Conklin building at Hartford Hospital. I've had people there that I know, and it was near the end. So that's why I'm just curious about timeframes and different levels of care.
Well,
so I'll have to dig in a little deeper.
I mean, this does address the issue that you raised of people coming in at very close to the end. We're looking to move that upstream, such that we can provide care, love up these patients, spend time with their families, help them understand what's going on, provide social service, chaplaincy services, volunteer services, and make their end of life something that is in many ways a positive thing and memorable for their families.
Okay, thank you.
Thank you.
Thank you very much. Thank you.
I can get up now.
Now you're all set. Have a great evening. Thank you. Next, Iris Reyes.
Okay. Madam Chair, Mr. Chair, and members of the committee, good afternoon, and thank you for the opportunity to speak today. My name is Iris Reyes, and I've been a nurse at the Connecticut Hospice since 2008. And for the past 8 years, I have served as the nurse director for our inpatient hospice hospital. Hospice nursing is not just my profession. It has been my life's work for nearly 2 decades. When I began my career at the Connecticut Hospice, the focus was simple and deeply human. Meeting patients where they are, relieving suffering, and supporting families during the most vulnerable times of their lives. Over the years, however, regulatory and reimbursement changes have made it increasingly difficult to provide that care for the patients who need it the most. I want to share what this looks like from the bedside. Some of the hardest conversations I have ever had were not about death itself, but about discharges. I have watched the hope drain from families' faces when we have to explain that their loved one who is finally comfortable, finally peaceful, may need to move again because they no longer meet the general inpatient criteria. These transitions cause uncertainty, disruption, confusion, and distress at a time when families should be focused on being present with the people they love. As a nurse, it is heartbreaking to know what the right thing to do is, but not be able to do it. We see patients who are too medically complex for skilled nursing facilities, or who are repeatedly readmitted because those settings cannot meet their needs. We see families trying to navigate an impossible system while watching someone else or someone they love die. This bill matters because it creates a humane solution. By supporting short-term hospice specialty hospital care for high acuity, Medicaid, and dual eligible patients, this legislation allows patients to receive care in the right setting, at the right staffing levels, with the dignity that they deserve. It allows for us to care for our patients earlier, more consistently, and without forcing traumatic transitions at the end of life. For many years of experience, I can tell you this approach is not only compassionate, but it's responsible. This bill gives us the opportunity to align the reality and regulation with compassion. On behalf of the patients I care for, the families I have supported, the nurses and the staff who do this work every single day, I urge you to support Raised Bill 5481. Thank you for listening, and thank you for the consideration of the voices of those at the bedside.
Thank you so much. Thank you for your testimony and for being here tonight. Next up is Sylvia. Nope, I'm so sorry. I'm getting a little tired. Maria Lima. Is Maria Lima here? Okay. Philip Schenkman. Excuse me, just need you to turn on your button. That's okay. There you go.
Now it should be working. Good afternoon, Senator Lesser, Representative Gilchrist, and esteemed members of the Human Services Committee. My name is Philip Schenkman. I am 24 years old. I am currently a graduate student studying special education. I am speaking today to express my strong support for HB 5485 and the important protections it would create for people with disabilities in Connecticut. According to reports, there are approximately 2.8 million adults in Connecticut. Of those adults, more than 700 million are living with a disability. That means roughly 26% of adults in our state have a disability. I am one of those individuals. Too often, when someone has a disability, others assume that person cannot make their own decisions. Sometimes people believe someone may be too anxious, too overwhelmed, or simply incapable of making their own decisions. I've experienced this myself within situations relating to graduate school and employment. I can tell you that the feeling is incredibly frustrating and discouraging. It is difficult when others believe they should make decisions for you simply because you have a disability. That feeling can make an individual lose confidence and drive when they lose control of decisions about their own life. Every individual, whether they have a disability or not, deserves the right to make their own decisions and maintain control over their own life. That is why supported decision-making is so important. Supported decision-making allows individuals with disabilities to remain in control of their decisions while receiving guidance and advice from people they trust, instead of taking decision-making power away from a person. Supported decision-making ensures that the individual remains at the center of the process. Trusted supporters can help explain options, provide information, and talk through decisions. But the final choice always belongs to the individual. HB 5485 would formally recognize supported decision-making agreements in Connecticut. Having a documented agreement would help third parties such as schools, doctors, housing providers, and financial institutions. It is better to understand who a person trusts to help them and how decisions should be supported. Education is power, and knowledge gives people the tools they need to make informed choices. Personally, something like this would have been incredibly valuable. There have been situations in academic settings, workplaces, and even medical offices where misunderstandings could have been avoided if there was a supported decision-making agreement had been recognized. Fortunately, my parents have always supported my independence and allowed me to make my own decisions, while being there to guide me when I need it. When I first read this bill, I realized that the approach my parents and I have always used is essentially SDM without even realizing it. Connecticut has long prided itself on being a leader in supporting individuals with disabilities. But if we do not provide options that protect people from unnecessarily losing their civil rights, can we truly say we are on the cutting edge? HB 5485 is an important step towards protecting independence and self-determination for people with disabilities in our state. Thank you for the opportunity to speak today.
Thank you, Philip. That was fantastic. I appreciate you being here.
Thank you so much.
Oh, wait 1 second. Representative D'Amico.
Thank you, Madam Chair. Just real quickly, I just want to say thank you, Philip, for jumping into the advocacy world. And you don't know what you've gotten yourself into, but I'm glad you're here, and I really appreciate your testimony.
Thank you so much.
Thank you. Next is Natalie Shurtleff.
Good afternoon, or I suppose almost good evening. It's been a long day. My name is Natalie Shirtliff. I am an Associate State Director of Advocacy with AARP Connecticut. I am also here to support the supported decision-making bill, House Bill 5485. You've heard a lot of incredible testimony about it today, so I'll keep my remarks short and just say that this is a really meaningful bill that will ensure that people have ability to make decisions for themselves. This is how I make decisions without a formal agreement. I reach out to my husband, my friends, my family, get input, feedback, support making important decisions. And so we should allow all folks to use this framework and not have to utilize guardianship or more restrictive means if not necessary. At AARP, we think that it's important for people to be able to choose how they live as they age. And this is an important way for us to support that. So with that, I will ask you to support this important legislation.
Wonderful. Thank you so much. Don't see any questions. Thank you for your testimony.
Thank you.
Adrian Benjamin.
Hello and greetings to a hardworking group of legislators. Y'all are amazing. Incredible listening skills. My name is Adrienne Benjamin. I live in New Britain. I'm here today to represent the Connecticut chapter of the Profound Autism Alliance. And I also want to give you a moment to learn a little bit about my daughter, Zoe Benjamin. She is adorable and 29 years old, and she lives in a group home in Wethersfield. She is one of the people that still needs guardianship and actually will always need guardianship. Her disability is profound autism, which is a combination of intellectual disability and of the most severe kind and severe autism. She's essentially like a 2-year-old, and I am her guardian and always will be until my son will be. But I'm here to support House Bill 5485, supported decision-making is an option for people who that works for. And I know this bill is important to many families and many individuals whose kids have IDD as well as other disabilities. But they're far more fortunate than my daughter and many with profound autism that they can reasonably and intellectually make decisions that work for them. It's true that the people I represent today, those with profound autism, will not benefit from this bill, yet we support it. It's not for us, it's for others. And we want to be united with other people in the DDS world who have different needs than us, but we think it's important to be united for what they need, not just for what we need. Just a quick primer on those who do have the most severe form of autism. I have a graph, which of course, if I had better tech skills, I could have emailed to you all, but I can pass it out later. This is a graph of the people in DDS and their level of need. If you look at the far end, let's see, what side is this, left or right? I don't know. These are the folks that have the lowest level of need. There's about 3,000 of them. Then the middle level of need is about 4,000 in the 4,000s. The highest level of need is where we have the most folks in the 5,500. Now, my daughter, just for example, it's a level of need from 1 to 8. She's level 7. That gives you a sense of what her life is like and what her capacity is. 26.7% of people with autism have this level of profound autism. That's from last year's CDC report. Our profound autism kids, they're young adults, but they will always need adult support, one-on-one, 24/7 for the rest of their lives. Most are totally nonverbal, and you can imagine the frustration and difficulty if you're not able to express your needs, your wants, your feelings, your earache, that you wanted chocolate ice cream, but somebody got you vanilla, and I had no idea I was done. So let's see. Anyway, so the graph shows that the majority of people that get DDS support have the more severe level of need. And I hope that you keep that in mind when you're talking to people about budgets. Lastly, I was really glad to hear Molly Cole and others here talk about there are still needs for people with guardians. Because in California, when they were dealing with supportive decision-making, they made it initially very difficult and expensive for people to get guardianship. Like supported decision-making would replace it. And I'm very glad that in Connecticut, this is seen as an additional option and not as one size fits all. Thank you very much.
Thank you very much. Representative Case.
Thank you. And thank you for always coming forward and watching out for all. I just want to make sure we understand too, this bill is going to come out of this committee, but we need the advocates to follow it along, because once it goes to the House, it's going to get an automatic referral to Judish, because they have to handle all the legalities and everything, because it impacts probate courts and everything else. So we got to be vigilant. We tried to get it out last year.
Right, I know.
So when it goes to the House, it'll get an automatic referral, I believe, to Judish. And we need to be vigilant and watch it there, because we're passionate about it. As I said earlier, Representative Dathan and I have been meeting with the probate courts and others, but it doesn't stop here.
So you're inviting me to come back?
Absolutely. See, they won't have a public hearing. We had the public hearing, so they'll just have a vote.
Well,
So we need to start talking to those members
Okay.
and see how they feel, because it is a right to have somebody to help you to make decisions.
Absolutely.
I know that they're a little bit, some are skeptical, because when you're a conservator or you're the guardian, that's a legal document.
Yes.
This isn't a legal document, so they don't have that when somebody's coming before them. So we need to find out how we can make the courts comfortable with that. And I've been conservator, I get it.
Brother,
we want to give more options for people.
Absolutely.
We just have to follow this process, please.
Well, my attorney cousin lives in Minnesota, so I don't know if that can be much help.
No, but thank you. And thank you, Madam Chair.
Thank you. Thank you so much.
Thanks
Have
so
a great
much.
evening. Next is Phil Onofrio.
Senator Lesser, Representative Gilchrist, and distinguished members of the Human Services Committee. My name is Philip Onofrio. I'm the Director of Ground Transportation Services at Yale New Haven Health Y-Axis Transport. Yale New Haven Health recently acquired Nelson Ambulance Service in November of 2025, marking Yale New Haven Health's entrance into the medical transportation industry. In partnership with the Connecticut Ambulance Association, I'm here today to testify in strong support of Senate Bill number 429, an act concerning Medicaid reimbursement for emergency medical transportation. Yale New Haven Health, one of the state's largest employers, includes Bridgeport, Greenwich, Lawrence Memorial, and Yale New Haven hospitals, along with affiliate organizations such as Northeast Medical Group, Yale New Haven Health Urgent Care, and Y-Axis Transport. Together, our more than 31,000 employees and 7,500 medical staff form an integrated health system committed to delivering safe, high-quality care across the continuum. Their expertise and dedication enable us to serve patients at every point of need, whether in our hospitals, outpatient practices, home care, or urgent care centers, and meet the diverse needs of the health communities that we are privileged to support. This legislation would modernize the antiquated system for Medicaid ambulance billing and adopt a single standard across payers for mileage. It is also consistent with industry standards. And importantly, once implemented, the change is expected to be revenue neutral. To provide background, the Public Utilities Control Authority, or PUCA, created a mileage chart in the 1970s to establish official standardized rates for commercial transportation services. This allowed the agency to properly regulate fares charged by companies like ambulance and livery services, which were based on mileage. It also applied to mileage for the purpose of Medicaid billing. Docket 6770, now Docket 6770A, became effective March 1st, 1974. However, PUCA was disbanded in 2011, and its duties were moved to PURA. Yet the out-of-date mileage system remains for the purposes of calculating Medicaid mileage for ambulance services. The result is that the ambulance providers are currently left with a Medicaid mileage system that is based on old post office to post office mileage charts, not actual mileage traveled. This legislation would update the calculation to the modern, accurate, actual miles driven method. This is what Medicare and all other commercial payers currently utilize, including Medicaid, for in-town mileage calculations. This will ensure all beneficiaries and claimants and providers are reimbursed based on the same distance calculation for the most direct route between 2 points, regardless of which insurance or payer is processing the claim. The legislation's July 1st, 2026 effective date provides a clear timeline for compliance planning. Overall, these reforms represent a net opportunity to improve ambulance service billing accuracy by utilizing current and accurate GPS technology. Thank you for your consideration.
Thank you. Thank you for being here tonight. All right. Have a great evening. Kathy Flaherty.
Good evening, Representative Gilchrist, Senator Lesser, and members of the Human Services Committee. My name is Kathy Flaherty. I'm the Executive Director of Connecticut Legal Rights Project, and I'm here to testify on 3 bills today in support of HB 5480, an act concerning peer support services under the Medicaid program, in support of HB 5485, an act concerning supported decision-making, and in support of Senate Bill 430, an act codifying the Americans with Disabilities Act. Because you've heard from so many people testifying on these 3 bills earlier today, I'm going to keep these remarks relatively short. I think in terms of the peer support services bill, I would agree with my colleagues who said that the lived experience of being a person in recovery themselves is super important. Do I believe that family members absolutely can be supportive, but it should be family members who are peers to family members. So it's a different kind of peer support, and making that clarification is super important. But making peer support services available to more people will be good for people who are newly in recovery, people who are continuing in recovery, because that support from peers can be absolutely life-changing. You've heard fabulous testimony about supported decision-making. And I remember very early in this hearing, somebody asked, why do you think that we haven't been able to pass the bill? And you haven't been able to pass the bill because we've never been able to get a hearing. So the voices of people with disabilities have never been heard on this issue. And we thank the committee for holding this hearing, for raising this bill, and bringing the ability to share our stories and bring supported decision-making to life, because that really, supported decision-making is something that a lot of us actually do every day. And we're just saying, for the people with disabilities who are capable of it, let's give them the same opportunities. And I know Representative Case has mentioned several times that this bill might have to be referred to another committee. I know the Supported Decision-Making Committee coalition, of which CLRP is a part, has had meetings with probate court administration about this bill. They didn't think that the bill as currently written would necessarily involves them at all, because technically it doesn't. This is something that people are doing outside of court because they are making choices about who they want to support them. And what we're saying is that those third parties have to honor that agreement. Should not involve the court at all. That's the whole point. It's an alternative to conservatorship, an alternative to guardianship. And because the system is set up that they are supposed to consider less restrictive alternatives, where this would actually come up is if at some point later on, somebody made a petition against that person for a conservatorship or guardianship, you can look and see, well, does this person have supported decision-making, especially if you get this law passed? And that it will show that they can do that. Just in terms of SB 430, the integration mandate isn't in Connecticut law. I know CHRO submitted testimony that they believe, and they're absolutely right. The ADA is a floor. States can go higher. Connecticut has gone higher in a lot of areas. We want to make sure that people have the most amount of protection. Thank you.
Thank you. Senator Lesser, followed by Representative Case.
Kathy, thank you for your testimony. And yes, at the very least, I'm glad that this committee could provide a hearing and hear from the voices of the folks who are affected, who could benefit from supportive decision making. And I think that's an incredibly important conversation that we've had today. I appreciate your comments about the area, just talked about the integration issue. But, you know, CHRO's testimony expressed some concerns about having to, you know, we do have existing non-discrimination laws in the state for people with disabilities. We are obviously not trying to take away any right that people have, but I just wanted to know as a lawyer, if you have thoughts about how these two issues could, you know, I'm sorry. The hour is late, so I'm conflating supportive decision making and now the codification of the ADA. But with this respect to the codification of the ADA, do you have advice for us about how to keep them from conflicting with one another, or to make sure that we're able to best serve the folks and not take away anything or cause undue complications for CHRO?
I think that probably involves a longer conversation. Happy to contribute to that offline.
I will take you up on that. Thank you.
Representative Case.
Short answer.
Thank you. And thank you, Kathy. I do agree that, you know, we'd love for it just to leave here the decision making. And Representative Dathan and I have been proactive. We've met with some leadership of the judiciary. We've met with the probate courts. We're trying to, as we did with 5001, the more that we can reach out to ahead of time to try to make them feel comfortable with it, the better off we are. It's just, that's what pushed us to go meet with them, because we were hearing that this is where it needs to go. So we're trying to be proactive. I agree. The more we can have people make their decisions with somebody that can help them, let's do it. We have to go on the caution of what the law allows us to do. And I will always fight for the most vulnerable and make sure that they have the ability to do what they need to do. It's just, we've been trying to be proactive with it and try to alleviate that referral, but I believe that's where we're told it's got to go. But let's
Well, we will.
hope we can get it.
Yeah, we will stand with you in doing what we need to do to keep this moving forward.
Absolutely. Thank you very much for coming. Thank you, Madam.
Thank you. Thank you so much. Have a great evening. Next is Sheldon Taubman.
Good afternoon, Representative Gilchrist, Senator Lesser, other members of the committee. My name is Sheldon Taubman. I'm the litigation attorney at Disability Rights Connecticut. We're the protection and advocacy system for the state, serving individuals with a full range of disabilities. I'm here to testify about the impact of three of the bills on people with disabilities, 5485, 430, and 433. You have my written testimony, so I'll just highlight a few things and respond to some testimony I heard today. First, on 5485, the SDM bill, clearly the people we serve are looking for more autonomy, and SDM will allow that while allowing them a consultation with people who can help them in making these important life decisions. SB 430, just mentioned, as Kathy just said, the current state law does not incorporate the integration mandate of the ADA, which is really important. The need for that has really been highlighted just now by the governor's proposal to completely eliminate community first choice, which is available only to people who DSS itself determines after a rigorous analysis would otherwise be institutionalized. So they're proposing to end this. That seems to violate the ADA's integration mandate. If it were part of state law, it would certainly help to push back on that. I'm happy to work with CHRO to make sure that we protect rights either way, that the maximum rights under state or federal law will be protected. It seems to me that the current bill does that, but we can work on improving that. Happy to work with the committee and CHRO. 433, an act expanding long-term care options. This bill includes a requirement that the Commissioner of Social Services shall rebalance the strategic plan for long-term care supports and services to increase opportunities for Medicaid beneficiaries and other persons with limited income who do not qualify for Medicaid, et cetera, to receive care in a home or community-based setting, and requires the same thing of the Long-Term Care Planning Committee. The commissioner testified about this and says it's not necessary. Well, here's what the DSS said in 2020. They have a report, their rebalancing report says that Connecticut has made great progress in the development and implementation of community long-term services and supports for over the past 25 years. And specifically, it refers to community first choice as having made a huge difference in the lives of older adults and younger adults with disabilities. And yet the commissioner testifies it's not necessary. Well, it's really necessary because right now, the governor, supported by DSS and OPM, are very actively seeking to destroy CFC, this critical program which furthers integration and fulfills the mission of the integration mandate in the ADA. If they were to be successful, it would mock the official strategic plan by DSS and the long-term care plan. The arguments being made by the governor are that this is being done to help people and give them more choices, which is a ridiculous argument. And it's also been said somewhat offensively that we'll take care of people on it, but the people after that, too bad, long waiting lists, rationing, etc.
Can you please summarize?
Yes, I'll just conclude by saying that this is a really dangerous proposal. So in looking at SB 433, please be aware that they can write a strategic plan, but as now they can disregard it. So therefore, any requirements imposed on the department to expand options really would have to be express mandates to make sure they would actually work. Thank you very much. Happy to answer any questions.
Thank you very much. Let me just check Zoom, sorry. I don't see any hands. Thank you so much for your testimony and for being here today. Next is Naomi Nova. All right. Andrew Feinstein. I think he was literally just here. Okay, we'll come back. And Daniel came up with Jeffrey Santo.
Good afternoon. My name is Jeffrey Santo, and I'd like to start off by thanking the members of the Human Services Committee for hearing my testimony today. I'm here to testify in favor of, actually I wrote it down, should have. HB 5480, the peer support reimbursement through Medicaid. Even though this bill will not affect me directly because the service I provide is through an independent peer-driven organization, I do not have a DEMIS contract, and I do not have any funding from any other sources. Eventually, hopefully, I hope this bill is a launching point for allowing for reimbursement for peer services outside of the DEMIS network of services. I also wanted to comment a little bit about the supported decision-making. As someone who does peer support work, I know how important it is that people feel their voices are being heard. And speaking with people on a constant basis who are living with things like depression and suicidal ideation, it's when their freedoms and their choices are compromised that they are at their most vulnerable. People living with suicidal ideations often do so because they feel that their life is no longer within their control. That's why we see a high level of people completing the act of suicide after forced hospitalization. That hospitalization literally proved to them that, no, you don't have the right to make your own choice and we can do whatever we want. I can tell you from my lived experience that when it comes to making your own decisions, people need to feel that they are being heard. And as an advocate, that is one of the most powerful gifts we can give to someone, is allowing them to feel heard, validated, and seen. I want to close by thanking Representative Comey. When we were pushing very hard to get peer run respite in front of the legislature and explain what its function is and how it works and why we believe in it, we were pushing for 8 peer run respites. And when we're sitting in our meetings wondering if our voices were being heard, we saw something pop up in the proposed bills under the Public Health Committee, or Health Committee rather, and I wrote it down. It was bill number 6579, brought forth by Representative Comey, an act establishing 15 peer-run support centers. in that moment, we felt heard. And it is going to be probably one of the best highlights that I have had as an advocate so far, because it allowed us to understand that we did have a voice, we were being heard. And as an advocate, I got to experience that on the flip side. Yeah, so that's pretty much it for me.
Thank you. Thank you so much for your testimony and for being here tonight and for the work you do. Have a great evening.
You too.
Did Andrew come back in now? Stacy Ty. No. Quinn Meehan.
Hello, Representative Gilchrist, Senator Lesser, ranking members and esteemed members of the Human Services Committee. My name is Quinn Meehan. I am a Bethany resident. I am a policy and community organizing intern at Universal Healthcare Foundation, a former special ed teacher, and I'm disabled and trans myself. And I'm here in support of several bills: Senate Bill 430, House Bill 5382, House Bill 5485, and House Bill 5480. However, I will focus primarily on 430, though it'll be tricky because so many of the bills on this agenda impact me and my communities directly. When it comes to the ADA, it both touches me in so many ways, and in so many ways it doesn't. Living in Bethany and being a power chair user, I have no means of getting around. We had a senior bus that used to operate Monday, Wednesday, Fridays from 8 to 3 p.m. And I used to joke that luckily those are the only times that I exist. Of course, that's not the case. And recently we lost 2 of those days, and now you have to prove medical, you have a medical appointment to even ride the bus on Fridays. I am a whole person and I do not just attend medical appointments, to be clear. However, even though the ADA does not support me there or grant me any rights to transportation to leave my home, it is the reason why once I get to Woodbridge, I can get paratransit services. And why once I'm in New Haven or that area, I can ride the bus and get on. It's the reason why when I was discriminated against in my employment in 2021, when my disability first onset, and I was told that I could never teach, that I was a bad teacher, despite my students and their parents saying otherwise, just because I needed a power chair. It was the reason why I was able to engage in a lawsuit and get any sort of money towards accessible housing. However, I have a lot more resources than most people, and I don't have to use my power chair, though I'm in a lot of pain and I have a lot less energy and could do a lot less without it. There are people who, in my situation, would be pressured to leave living with their families. And the fact that I'm able to live at home with no rent while I'm in school is huge, but it demands a lot of sacrifice. The point I'm trying to make is that we as a state need to codify the ADA as the federal landscape shifts consistently and constantly underneath us. And beyond that, I think as my supervisor mentioned earlier, it's really important that we as a state, and I would be so proud to be a Connecticut resident, if we were to go beyond that and create a truly just environment for disabled folks of all kinds in Connecticut, without treating the ADA as just a baseline, to feel that we're compliant, but to feel that people actually have truly meaningful lives and are not trapped in their homes in the middle of the woods like I am. So I urge the Human Services Committee to pass this legislation and the other bills that I listed, and I'll submit written testimony later. Thank you.
Thank you so much. Thank you for being here and for your testimony. I don't see any questions. Have a great evening.
Thanks so much.
Andrew Feinstein.
Appreciate your indulgence, Chairwoman Gilchrist and Senator Lesser and Representative Comey. How are you? I'm here to testify on your bill 430 to incorporate or to codify in Connecticut national ADA law, and to create an enforcement mechanism, therefore let me say first and very clearly, I am enthusiastically in support of the idea. I want it to happen. But then the bill needs a lot of work. I am really concerned that the 9-line consolidation provision at the beginning will just serve to confuse the court, and courts will find a way to say that the legislature did not intend to do what you clearly intended to do. I think far more explicit language is needed. You understand the ADA is a fairly short statute, but it includes 1,200 pages of regulations, including a whole bunch of regulations that were pending at the end of the Biden administration, which may or may not have been finalized depending on who you talk to. I think it is, I think that's a really substantive issue. Secondly, obviously we have the issue with the government oversight committee moving towards creating an Office of Educational Ombudsperson, which would handle these complaints, and this bill assigning it to us to CHRO. In either case, we need staff to do that. The clear message, there are about 250 Connecticut OCR complaints each year, it looks like. We need about one professional staff person for every 40 complaints, seems to be the ratio that's operative. And so whether it's CHRO or the ombudsperson, we need that staffing and that expertise in that area. I've got to say that I have also a real issue with the language of Section 2. It says you bring complaints to CHRO. We had similar language in the Education of All Handicapped Act back in the late 70s. The Supreme Court in Smith versus Robinson said that language meant that all other remedies were excluded. And so Congress had to go back and pass a savings provision. To save that, we need to include a savings provision so we're not cutting off other people's rights. I am committed to working with you as much and as long as it takes to get this right. And it's critically important that we get this right, because the Federal Office for Civil Rights is no longer an effective institution for people with disabilities. And so I'm not looking at this as a multi-year process. I would really think it's very important to get it done now. California did something similar, but really in the context of anti-Semitism. Colorado is working on legislation now, and there's real trouble there. Pennsylvania has similar provisions working. Illinois is also working on this. I'm very involved on this on the national level, and so I would love Connecticut to really produce the model statute in this regard. Thank you.
Thank you. Senator Lesser.
Thank you, Madam Chair, and thank you for your testimony. We're big enough to accept some constructive criticism over here, so I really appreciate it. Just in terms of sort of handling the 1,000+ pages of regs, and the ADA is maybe not the longest statute, but it's also fairly long. There's like a few different provisions. Is it your sense, like how would you suggest that we approach it? Should we try, I mean, the way the bill is as is, it seeks to incorporate it by reference. And is that the right way of doing this, or should we try to mirror the statute on the state level?
Well, clearly Title II, which covers state and local governments, is something which we need to look at and incorporate pretty much fully. Title III on public accommodations is also probably something that needs to be included. I'm not sure that we really need to worry about telecommunications and and there's stuff in Title V on immunities, which is probably also worth picking up. I think we have to take a closer look at that. And I also, as I've neglected to say, that the actual provisions covering state and local governments are usually under Section 504 of the Rehabilitation Act of 73, which has a standard which is on a substantive basis identical to that of ADA. But that ought to be included in here, because that's really where the action is in terms, where the case law is in terms of holding state and local authorities to non-discriminatory practices. But I do think it's I think the very brief incorporation of everything by reference is not going to get us where we want to go.
But what do we do about the 1,000 pages of regulations? Because we're not going, I mean, we can't ask the Regs Review Committee to take on that burdensome task and assume that that'll happen in our lifetimes. So,
and much of those regulations are not really relevant to this. And so I do think that we've got to take a closer look at that. I think it's going to take some time, but it's not going to be infinite. I think we can get that done. And if you want sort of a legal memo on that, I guess I'm volunteering.
well, thank you. I'm mindful. I was just talking to my my co-chair a little while ago. We were trying to take stock of all of our to-do lists for this year, and obviously, you're making the case that this is something based on the evisceration of the Federal Office of Civil Rights. That this is something that has to happen sooner rather than later. We have a whole bunch of other folks with what they believe are pressing needs, and we have to sort of triage. But I think our hope, at least on our staff side, was that we could, and it looks like it was a misplaced hope, was that we could reduce the burden on them by just incorporating things by reference. But it sounds like this is a little bit more complicated than that.
I would want to be more specific about that. I don't want to fill up the Connecticut general statutes with 1,000 pages, but I think that if we do it sort of title by title, we can make it very clear as to what we're trying to do. And my view, look, I know what you're trying to do, and I love it, but I face judges every day, and they find creative ways to read the statutes that deprive people of rights. Not always.
Can you talk a little bit about, so the savings provision would be intended to make sure that people who would otherwise have a right to bring a claim in court would not lose that? Is that
exactly?
Okay,
exactly.
And what about other? I mean, it sounds like this is more of an in-depth offline conversation, but generally, how do you see this intersecting with our existing state non-discrimination laws for people with disabilities?
Well,
and I'm referencing in particular the sort of the blanket concerns that CHRO provided their testimony, where they were trying to say that there might be areas where there's disagreement.
There may be. Look, one of the big things is that under federal law, disability is not a suspect category and does not trigger strict scrutiny. In Connecticut, it does. So Connecticut is actually much stronger in that regard. We certainly won't want to lose anything that was that was stronger. I think that the jurisprudence is such that Connecticut's anti-discrimination laws are, in virtually every case, identical or stronger than federal ones.
Okay, but if that's the case, so if that's the case, then that goes back to the question about is this needed? And you think it is because of
I'm not
Title II and Title V.
I'm sorry. I am not sure that the codification is necessary. I am sure that the enforcement agency is necessary.
Okay, that makes sense.
Okay.
I think that's all I have. I'll pass it back to you, Madam Chair.
Okay. Yeah. Go ahead, Representative D'Amico. It's the whole point.
Thank you, Madam Chair. So thank you, Attorney Feinstein, for being here. So based on that dialogue between you and Senator Lesser, this is certainly problematic. I didn't quite understand your last comment about the agency. Could you go into a little more detail about this?
What we have had with the Federal Office for Civil Rights is an independent agency where parents at no cost could bring a complaint about the violation of the rights of their students. It's a shame to lose that. And it's really a shame to lose that because, you know, parents who are well-heeled can generally get a pretty good education out of the special ed system. It's the vast majority of parents who can't afford lawyers and advocates who do not end up with effective programs for their kids. And so we need a no cost or low cost unit that can actually look at what is, from my point of view, what a school district is doing and order corrective action where the school district is violating the rights of the student. Now, we don't particularly have that. I mean, CHRO has dipped its toes into that area, but has not really devoted the resources to it, and is not seen right now as the place for parents to go to get relief. The OCR has been much more in that regard. And so, you know, that's what I'm looking for. I'm looking for a state agency that I would love to call an Office for Civil Rights, but could be CHRO, who would receive complaints, who would have some expertise, both in disability law and also in education law, to receive and deal with these complaints about violations of the civil and constitutional rights of students with disabilities.
Thank you very much. I appreciate that.
Thank you very much, Representative Miko.
Thank you, Madam Chair.
Thank you. Representative Dathan, go right ahead.
Thank you so much, and thank you for your testimony. I know I saw you in and out of the government oversight public hearing this afternoon, and we have been talking about this with the 504 work and the Office of the Ombudsman, and just wanted to get your, because I wasn't in the room, I think, when you testified, with that bill and working along with the good chairs of Human Services, do you think we'd be able to get some good sort of policy to help students? And like you highlighted, and I had mentioned in my comments earlier about the lack of ability for all parents to get a lawyer to help navigate this system. And right now, the reporting is very fragmented for 504s, and for ability to lodge complaints is very difficult. And just wanted your comments on that.
Well, as between the Office of the Educational Ombudsperson and CHRO as the enforcement agency, I'm rather agnostic. Whoever it is needs the resources to do it. And that's the first point. As to 504 fundamentally is a protection of civil rights of all individuals. Now, there's certain kids who are provided specific protections and programs under 504, but 504 applies to everybody. And those rules against discrimination based on disability need to be enforced. Currently we have this elaborate system for students who have IEPs or who should have IEPs, and of due process and all that. There's no parallel system for 504s. In those cases, if you want to bring a complaint against the district for 504, the district hires the hearing officer, and there are no particular procedures applying to that. That should be fixed. And whether we do that, whether we make the complaints case by case on a district level or complaints to an independent agency, the advantage of the independent agency is that that becomes a no-cost place for parents to pursue their interest, and it also creates a higher level of confidence because it's somebody outside the district. Does that answer your question?
Yeah, and I think that is exactly it. We just need to have a little bit better documentation for all of these and resources for parents to go to. Thank you so much, and thank you, Madam Chair.
I just want to comment on that last comment of yours. There seems to be this feeling that we just need to get more information for parents. That's not, there's lots of information out there. The problem is that for most parents, they are so completely overwhelmed with life that the notion of trying to figure out how to pursue one of these actions is just totally beyond them. And so having a number to call and a free place to make a complaint is of enormous benefit. To try to navigate the mediation or due process system by yourself, it's really a hard thing to do, and very few parents have the time to do it. There are plenty of resources available if they want to do it themselves, but plenty of resources about how you do it. But it isn't very difficult, and if you're wondering about working 2 jobs to get food on the table, you just don't have time or mental bandwidth to handle that. So I don't think more information is necessarily the answer.
I think it's a multitude of things. I think seeing last year we put in the educational ombudsman, that role was never filled. And so this year it was eliminated in the governor's budget. And, when we were working on this bill, that was one of the key things we wanted to put back in place, because students with disabilities and their families need to have a resource to go to. And there's no one at SDE that oversees 504s, for example. And so that was really the sort of mechanism for doing this. And the CHRO, is a good enforcement mechanism, as you said, but it's not really the place to go to if you have questions or need some support and get through the process. So anyway, thank you for your comments.
Thank you very much.
Thank you very much.
Thank you. Good to see you.
Have a good evening. Good to see you. Next is Tom Kosker, followed by Gretchen Raffa.
Good evening. Can you guys hear me?
Yes, we can. Go right ahead.
Excellent. Tom Kosker, advocate with Disability Rights Connecticut. I'm here to testify on HB 5485 on supported decision making. But before I do that, I'll quickly comment about the ADA issue. And again, I'm not an attorney, I'm an advocate. There are many smarter people than me in Connecticut that know a lot more about the ADA, but I as an advocate get calls regularly. We at Disability Rights Connecticut get calls regularly on ADA violations, and codifying that in state law, I think, is critical. That protection is vital for students, as Attorney Feinstein said. And again, keeping it simple, obviously, I applaud that effort, and if we can do that, great. But it's definitely protection we need to keep in place and codify in Connecticut. Regarding the supported decision making, it was referenced earlier in testimony earlier today. I'm home now, but when I was in the room, someone mentioned that Disability Rights Connecticut has a supported decision making clinic, and we do. And I think it was Representative Comey or someone else that asked about the need for supported decision making, or the demand, so to speak. And we do get calls regularly. We get calls weekly from individuals with disabilities, from families of people with disabilities looking for guidance and support and help. And what we do at our supported decision-making clinic is provide that kind of education. We educate the individuals about what they are, kind of guide them through the process of developing a supported decision-making agreement. So the demand is there. In 2023, there was a small piece passed in state law here in Connecticut where school districts must inform parents and students during their transition years, their PPTs, planning and placement team meetings, I think starting at the age of 14, about the options for decision making, including supported decision making, was kind of spelled out in that law specifically, in addition to guardianship and conservatorship, because often in the past it was solely guardianship and conservatorship that was being spoken about by school systems, which is where a lot of those families and students learn about their options. So that was passed in law a couple of years ago. That's been very effective. We're seeing the demand from that law in students and families calling us saying, hey, what's this about? As other people have testified today, the demand is there. You've heard from advocates, attorneys, people with disabilities on the need for it. And so again, I think the demand is there. I won't belabor it. You've heard a lot from a lot of folks supporting this bill. I think the need is there, but just wanted to share from my perspective as an advocate who talks to clients, weekly, and here at Disability Rights Connecticut, we support that. That's all I have to say. Thank you.
Great, thank you. Yes, Representative Case.
Thank you. And thank you for your comments, because we really worked to see if we could get this incorporated into 5001, because that was the bill that at the age 14, aging out was to start the process in the school districts where families would be able to understand a little bit before the graduation happens on a plan for their special needs or their child that needs extra services before graduation. I'm glad to hear that is coming out to you guys, and you're starting to see some movement on that. And I think that this supported decision making is just one of the bigger steps so that people understand that there is help out there. But I thank you for your advocacy, and like I said, the more we can get help to this population, the better off we are as a state. But thank you.
Yeah, thank you, Rep. Case. If I can I respond?
Yes, go right ahead.
So, no, thank you for that. And yeah, so we are seeing it. I wouldn't say it's, every school district doing a perfect job. It's a work in process, but I think it's happening, and kind of like build it, they will come. Like, people are being made aware of it. People are being aware of this option. You've heard testimony that we have one of the highest, if not the highest rate of guardianship in the country. And this is just helping there are individuals who need guardianship for sure, but for those that don't, for those that can get away with less supportive means, educating them about their options, making it available, and making it recognized. Because the question we get when people do call us now is, what is this thing that I'm developing, the supported decision-making agreement? And is there a paper? What do I do with that paper? Do I take that agreement somewhere? So getting it recognized in some way. So when they walk into a medical facility, for example, or a bank, et cetera, that it's recognized by state law. And it's something that has more meaning beyond just the words on the paper.
Once again, thank you, Tom, because that's the hardest thing is parents don't know what their rights are and what they can do to advocate for their loved one coming out of school. So once again, thank you for all you do. The more information we can get and whatever you can communicate to us and make sure we get this over the finish line would greatly be appreciated. Thank you.
You got it. Thank you.
Thank you. Senator Lesser.
Thank you, Madam Chair. I don't actually have a question. I just want to thank you, Tom, for all your work on this, on these issues. And you've been a real stalwart advocate for a very long time, and I'm very grateful for you.
Thank you. Thank you for your support.
Great. Thank you so much. Have a great evening.
You as well.
Gretchen Raffa.
Good evening, Representative Gilchrist, Senator Lesser, and honorable members of the Human Services Committee. My name is Gretchen Raffa, Chief Policy and Advocacy Officer at Planned Parenthood of Southern New England, testifying in support of raised House Bills 5482, an act concerning 12-month coverage for contraception and hormone therapy, and 5483, an act concerning fertility care under the Medicaid program. Serving over 52,000 patients last year at 14 health centers across the state and telehealth, nearly 25,000 who are on Husky Health, Planned Parenthood believes all people should have access to quality, affordable healthcare as a basic human right, and that everyone deserves affordable and accessible hormone therapy and birth control that works for them. Yet insurance often limits the supply a person may obtain at one time, typically limiting to a 1-cycle or 3-cycle supply, which is why HB 5482 is urgent and necessary, which provides coverage for 12-month supply of hormone therapy and contraceptives dispensed at one time, and that will ensure continuity and access and eliminate gaps in hormone use. This bill will also bring public insurance coverage for a 12-month supply of contraceptives in line with Connecticut's private insurance coverage requirement established in Public Act 18-10. This is a matter of equity, so Husky Health patients on birth control have the same guarantee as those in coverage as those with private insurance. You've already heard from providers earlier today why this is so important, and one of the most successful proven methods to increase birth control continuation and avoid unintended pregnancies is increasing the supply of contraceptives provided during a visit. This legislature also has an opportunity to do the same for people on Husky Health that need hormone therapy. There are many medical uses for hormone therapy, including menopause management, managing conditions like PCOS or hyperandrogenism, gender affirming care, and more. Consistency is essential for patients because missed refills can disrupt physical and emotional well-being, create anxiety about supply shortages, and add stress for those balancing work, school, or caregiving responsibilities. As someone who is currently in need of hormone therapy for perimenopause management, I know the importance of getting my medication and the impact it would have on my health and well-being if there was a disruption in my hormone therapy, or if I have to worry about supply shortages, which I currently am doing. We all deserve affordable and accessible hormone therapy that works for us, regardless of our income, insurance, carrier, or life circumstances. Moving to House Bill 5483, Planned Parenthood has long fought for a person's right to control their reproductive health, which includes planning their family, having a healthy pregnancy, giving birth to a healthy child, and raising their family in safe and healthy environments. Yet the reality is, for many people, they require fertility care assistance to have children, yet it's oftentimes out of reach because the cost of such health care and the inequity in insurance coverage. HB 5483 will address a critical need by eliminating some barriers to fertility healthcare coverage and is an important first step in improving coverage in Husky Health for this essential family building care, inclusive of all people. While there's a broad range of many services for people with low income, including pregnancy and to help prevent pregnancy, there's almost no access to help people with low income achieve pregnancy, which has a disproportionate impact on women of color. This is a critical part.
Can you please
of the fight. Yep, but this is a critical fight for the for reproductive and economic justice in our state. And under this current hostile political landscape, it's so important that our state does everything we can to ensure that people have the healthcare they need and be able to make the decision of whether and when to have children. Thank you so much. And we urge the committee to pass House Bill 5482 and 5483.
Great. Thank you so much, Gretchen. Gretchen, I don't know if you had the opportunity to look at the testimony from the Commissioner of Social Services today, but there were some concerns in regards to House Bill 5482 and the 12-month supply of contraceptives and hormone therapy. Any response or additional information you can provide to us about best practice and what would take place?
Yeah, thank you for that question, Representative. I think there's a body of research, and I know some of the providers that came before me referenced that, but we know that one of the most successful and proven methods to increase birth control continuation and avoid unintended pregnancy, is to supply that contraceptive care all at once, and ensuring, leading medical research shows that access to a full year supply reduces the barrier. And it also reduces unintended pregnancy, which obviously reduces the cost to the state as well. And so this is such a critical component of being able to control your fertility and plan your pregnancies and space your pregnancies. There's studies out of California, and we can share that with the committee as well. Some are referenced in my written testimony. But again, there's plenty of research going back decades that shows that other states expanded Medicaid family planning program that includes a 13-month dispensing of contraceptive care actually reduces long-term cost to the Medicaid program. And it also allows people that are on Medicaid to have full control over their fertility and not disrupt their contraceptive method. And I will note, sorry, Representative, I know you asked about hormone therapy too. We were really certain to ensure that the bill language allows for the provider discretion too. So this is, again, a conversation that a patient has with their provider, and the provider has the ability to either, not prescribe or prescribe 12 months, but or do less than that. And then this is really about dispensing. And so this bill will just say that hormone therapy can be dispensed up to 12 months at a time. But again, the language in the bill clearly states that a provider can limit that for less than the 12 months.
I think that's very helpful. So nothing in this bill would require a provider to do something that they don't deem appropriate.
Right. The prescribing provider, so 12 months can be dispensed at one time unless the enrollee requests a smaller amount. The prescribing provider instructs that the enrollee must receive a smaller supply. or if a prescription hormone therapy is a controlled substance. And that again has to follow state and federal laws. So that is clearly spelled out in the bill, and we look forward to working with the Department of Social Services just to ensure if there's any need to tighten up the language at all. But that is why the bill is drafted in the way it is.
Okay, great. Thank you. Representative D'Amico.
So thank you, Madam Chair. Thank you, Gretchen, for testifying. So I appreciate the discussion about the about 5482, and as you pointed out, and as the good chairwoman pointed out, there doesn't seem to the bill seems to indicate that it's up to the prescriber as well as the patient to determine if a 12-month supply is needed. So that there's no they're not there's no it's not required to dispense a 12-month supply. I think the language in the bill is fairly clear. I guess we're all in agreement on that.
Correct.
Okay, so I just to bring your attention to the other bill that you testified on, 5483. So I have been looking for quite some time at the testimony of the Department of Social Services on 5483, and it looks to me like the only objection that is raised here is that it's going to cost us too much money. Would you agree with that assessment, or is there some other nuance that I'm not understanding here?
Yes, it looks like the department might be calculating what the cost to the Medicaid program would be for pregnancy postpartum care and for any child that might be covered. This bill is fairly narrow, and it just requires that the Medicaid program will provide coverage for fertility diagnostic care, standard fertility preservation services, any medically necessary ovulation enhancing drugs, and services related to prescribing and monitoring the usage of those drugs. And for Planned Parenthood, we see this as a matter of economic and reproductive justice, because just because someone has public insurance, they should not be able to, they should be able to access the healthcare they need in order to build their families. And that is an essential next step that our state can ensure. So can ensure that Husky Health patients can use their insurance to get the health care they need to build their family.
Thank you very much. Thank you, Madam Chair.
Thank you. I'm having conversations behind the scenes, Gretchen, on other medications that are dispensed in, like, anyway, we've gotten to 3 months, some of us. I just find it very patronizing to not be able to have medication dispensed like this. Anyway, that's just my own statement. Thank you. Thank you for your testimony, and have a good evening.
Thank you very much. You have a good evening.
Next up, Rachel Green.
Good evening, Madam Chair, Mr. Chair, and the members of the committee. Thank you for the opportunity to provide testimony today. My name is Rachel Green. I'm a registered nurse and assistant nurse director at Connecticut Hospice. I have worked at Connecticut Hospice for 16 years and am closely involved in both the admission processes and discharge planning for patients and family receiving inpatient hospice care. In my role, I regularly participate in interdisciplinary discussions and family meetings where we review level of care criteria, clinical status, and discharge planning options. These conversations often take place at very vulnerable moments for patients and families when symptoms are complex, care needs are high, and decisions are time sensitive. What I see consistently is a mismatch between patient needs and the care settings available to them. Many of the patients we care for are medically complex, high acuity individuals who are no longer appropriate for aggressive hospital treatment, but who also cannot be safely managed at home or in a skilled nursing facility. While our inpatient hospice is both an inpatient hospice and licensed acute care specialty hospital, current regulatory limitations often prevent us from accepting or continuing care for patients who would clearly benefit from our setting. As a result, patients remain in acute care hospitals longer than medically necessary, or they're discharged to settings that cannot adequately support their symptom burden. This frequently leads to poorly controlled symptoms, caregiver distress, and avoidable hospital readmissions. Discharge planning under these constraints is particularly challenging. I am often part of meetings where families are told that their loved ones are no longer meeting GIP hospice criteria, despite ongoing complex medical needs. Raised Bill number 5481 addresses this gap in care. By allowing our inpatient hospice specialty hospital to care for this population more appropriately, this bill supports better clinical outcomes while also improving healthcare systems efficiency. Providing care in our setting reduces unnecessary acute care hospital days, decreases emergency department utilization, and lowers the likelihood of repeated readmissions from skilled nursing facilities. This legislation supports clinical decision-making that aligns with patient needs with the appropriate care environment. It allows hospice clinicians to focus on symptom management, safety, and quality of life, while reducing strain on acute care hospitals and the broader healthcare system. Thank you for the opportunity to share my perspective in considering legislation that supports both high-quality end-of-life care and responsible healthcare delivery. Thank you.
Thank you so much, and thank you for being here all day. You
Thank
guys
you.
have a very strong team. Very nice. Thank you.
Thank you.
Is Carol Scully with us? How about Brian Donahue? Andrea Sample? No. Drew McWeeny? Janet Stolfi-Alfano? You did not win the lotto today.
Goodness. This thing is on, yes. Good afternoon. Evening, no, we're evening. We're officially good evening. Excellent. Good evening, Senator Lesser, Representative Gilchrist, and members of the Human Services Committee. My name is Janet Stolfi-Alfano. I'm the Chief Executive Officer of the Diaper Bank of Connecticut. I so appreciate the opportunity to testify before you in order to support HB 5486, an act concerning a diaper partnership grant program, which would provide funding for a special program similar to one that we ran, like Diaper Connections, which was a collaboration between the Connecticut Hospital Association, Connecticut's acute care hospitals, as well as the Diaper Bank of Connecticut, with the goal of increasing access to diapers for families with young children. I have testified before this committee and many others many times, so I will keep, you are all very well versed in diaper need and its impact on Connecticut families. Again, we've been doing this for 20 years. We're meeting a fraction of the true need in the state. It has implications for health and well-being of children, economic stability for families. It's, predicts the health and mental health of moms. What we know is that investing in diapers and support for diapers in diaper banks or other programs actually increases the economic well-being of the family, but also there's a return on that investment. For every dollar expended, there's an $11 return. And UConn's own Connecticut Center for Economic Analysis did a report on this in 2018 that I can happily share, and I'm sure that you've all got it numerous times over the years. I wanted to just take a moment to focus on, this is truly a bipartisan issue. You can see from the testimony over the years that we've gathered from advocates, from women's rights, from religious affiliated groups like the Connecticut Conference and others. This is truly a bipartisan issue. We are grateful that the state of Connecticut really understands that this is a critical need. We have worked hard to meet as much of this as possible, and we need more support to be able to do this. This program was really a product of COVID. It was initially funded with COVID dollars and a really innovative, first of its kind in the country, collaboration between a diaper bank and a hospital, really a full hospital system. And so hospitals and the staff of hospitals recognized in their patients that this is a critical need and they have recognized it as well. So we are hoping to really be able to meet more of that need and continue this work that is critical and innovative, both here in Connecticut and hopefully can be modeled in other places as well.
Thank you so much. Can you tell a little bit more about what Diaper Connections was and its effectiveness?
Sure. So it is a partnership where the Diaper Bank of Connecticut would work with the Connecticut Hospital Association and all of Connecticut's acute care hospitals to distribute diapers to hospital patients. And the hospitals, as you can imagine, each have very different ways and mechanism in which they work. So they each were able to design the way that served them and their families that they served best in the method in which they distributed diapers to families. And so what we are hoping to continue is to be able to gather some more data to understand, does that have an impact on the overall health? Does that impact families' visits to emergency departments, which are very costly? How much of a preventative impact does this have? And so we were looking to really continue that research and collect some more data on that. But we have, self-reports from families indicating that, yes, diaper rash has been reduced. And we know that in the most of the families, and this is true for us in Connecticut, but also nationwide, most of the families who are served by diaper banks are covered under Medicaid. It's around in the 80%. So we know that the families that we're serving are those that are most in need, and that it aligns with those who need, more expensive care.
Thank you. Thank you very much. Any questions? All right. Have a good evening.
Thank you.
Thank you. Thanks for what you do. Varian Salters. Nope. And Kathleen Hayes.
Good evening, Madam Chair Gilchrist, Senator Lesser, and distinguished committee members. My name is Kathleen Hayes. I am here testifying in support of House Bill 5485, an act concerning supported decision-making. I am testifying today on behalf of the Elder Law section of the Connecticut Bar Association, of which I am the current serving chair. I'm also a very proud member of the Connecticut Supported Decision-Making Coalition. I know I've been listening to the testimony today, so I know that you have heard ample testimony from individuals about this bill. And so you know very clearly at this point that supported decision-making is just an elaborate term intended to recognize the simple truth that all people make decisions with guidance from people that they know and trust. We rely on accountants for tax advice, lawyers for legal counsel, mechanics to repair our cars, and apparently now ChatGPT for everything. We all live and make decisions in this interconnected world, but the unfortunate reality is that for people with disabilities and older adults, there's bias, prejudice, and often just a simple lack of understanding that results in the removal of legal decision-making rights through guardianship and conservatorship. House Bill 5485 pushes back against that bias by affirming the right of all people to make decisions with support from trusted individuals, regardless of the presence of a disability or regardless of age. By recognizing supported decision-making agreements as valid legal documents, people with disabilities and older adults retain their autonomy in decision-making. The act that is proposed and before this committee sets forth the requirement that third parties rely upon, or rather give validity and credence to the ability of an individual with a disability to rely on other people and retain their decision-making authority. And that's really critical. Within my practice, I'm an elder law attorney. I also practice in special needs planning, and over time have started creating supported decision-making agreements with many clients who previously would have turned to guardianship and conservatorship because they weren't aware of lesser restrictive alternatives. But today, even when I have clients that create these agreements, they say to me, okay, so what happens when I give this to the school? What happens when I give this to the bank, or when I give this to the medical provider? And my answer is, I don't know. because there's no law right now in the same way as the powers of attorney and healthcare directives that really gives legal presence and validity to these documents and is a notice to third parties as to the validity of it and as to the role and scope of the individual with a disability who's always retaining their decision-making authority and the role of supporter who is only there to support and facilitate that process of decision-making. I did have the opportunity to review some of the comments that were submitted, and I know that there's been much discussed about a referral to judiciary, and I did review the testimony of the judicial branch, and I do think that contrary to the concerns of the judicial branch, Section 1D1 clearly states, as the testimony has supported, that supporters cannot stand in the shoes of
Can
the
you please
individual.
summarize?
Absolutely. So supporters cannot make decisions. And so the concerns that this act will somehow empower other people to enter into the unauthorized practice of laws was one of the concerns of the judicial branch, I think is unfounded in the language of the bill. So thank you so much. We respectfully request that you support this bill, and I'm happy to address any questions.
Thank you so much. You're good. Oh, Representative D'Amico.
So thank you, Attorney Hayes, for coming and testifying on this legislation. You might have heard some of the discussion earlier, or maybe you did not. But I was asking Attorney Martinez, well, we basically engaged in a discussion about whether there are some shortcomings here in this legislation about supported decision-making, and if other states have different language or more extensive language to avert some of the potential problems. So just wondering if you would want to offer any suggestions as to how we could make this bill better, tighter, more acceptable to everyone. So that's my question. Do you have any suggestions as to how we can improve on this?
Not at the present moment. I know a lot has gone in with the coalition working on the preparation of the language before the committee today. This bill has been worked and reworked with multiple eyes and in review of all of the various statutes, the 29 states and the District of Columbia, and Attorney Jonathan Martinez has been at the forefront in many of those states. And so we rely heavily on his guidance and advice in terms of those states that really stand out. And we modeled our statute on what we thought was the best of the best language and what really fit for our residents within Connecticut. I personally, and on behalf of the elder law section as well, feel that this is a very strong bill. One of the things that within the elder law section we always want to ensure is that individuals are ultimately not subject to undue influence or fraud. And we think that this bill ultimately ensures that anyone entering into this agreement is doing so voluntarily, understanding the nature and effect and consequences of the agreement. I think to the extent that there remain any stakeholder concerns or issues, the coalition is very happy to address those concerns. I think that they would need to be narrowly tailored to the concerns that have been raised, as opposed to broad strokes that may not be narrowly tailored to the concerns that have been brought before this committee.
Okay, thank you very much. I appreciate that. Thank you, Madam Chair.
Thank you. And thank you so much for being our last testifier.
Yes, you're very welcome. Thank you.
Have a good evening. Thanks so much.
All right, you too. Thank you.
That concludes our public hearing. Thank you to everyone who testified, and thank you to the staff. Drive home safely.